Yes, good morning, everybody. Yes, okay. Right, so good morning, everyone. So, very warm welcome to this NEET PG marathon. Yes, we'll start with medicine. That is our key subject. That is the entry to all other subjects. So, let us begin with that. So, let me tell you to begin with only that today's session is just a very crisp revision of what is coming tomorrow. So remember that some of the slides, of course, you are going to feel that it's a repetition, but it is a repetition because these are the same topics that are coming every year. Okay. So this is a quick recap. I'm not here to burden you with information, but just I want you to recall important information before tomorrow's exam. Right. So look at the important message that we always keep telling: top topics equal to top ranks. It is not about knowing everything, but it is knowing about everything about a few topics that get you the extremely good rank. Yes. So let me increase the volume if at all that is a problem. Yeah. So fine. So you can increase the volume. All is well and we'll do well. So important topics repeatedly asked every time we are going to get is acute kidney injury. Must know topic. That what are the causes of AKI, how to diagnose, how to approach. Second, CKD associated metabolic bone disease. There is approach to hematuria along with complement level repeated question. Nephritic syndromes, the nephrotic syndromes, of course, glomerulonephritis, which nobody can run away from. Indications for dialysis, the topic of RTA, the topic of SLE, the myopathies, and the polyarthritis syndromes. Right? So, rheumatology has got a relatively less yield as compared to nephrology in your NEET PG exam. So, let us begin with these topics one by one. So, just a quick recall. So, you have to help me with filling these columns up. Acute kidney injury, you said, is diagnosed using any one of the KD-IGO criteria. That are the kidney diseases improving global outcome. As we have discussed in class, there is not a single factor or a single finding which is specific for acute kidney injury. In acute kidney injury, the creatinine is elevated, but the ultrasound may look normal, hemoglobin may be normal. So for diagnosis, we are going to start with the diagnosis using KD-IGO criteria. When the rise in the serum creatinine is more than 1.5 times the baseline within the last 7 days, very good. If the rise in the serum creatinine is more than 0.3 milligram from the baseline over 48 hours, and if the decrease in output is going to be less than 0.5 ml per kg per hour for more than 6 consecutive hours is diagnostic of acute kidney injury. Once you diagnose acute kidney injury, the first question, what is most common site affected? The most common site affected in acute kidney injury is the pre-renal AKI. That means there is reduction in the renal blood flow. In the renal blood flow, the most common cause of the disease remains hypovolemic shock, followed by the cardiogenic shock, followed by the septic shock. And that is why when it is asked, the first line of treatment in this patient is always going to be IV fluids. It is going to be IV fluid, and you will prefer the isotonic normal saline as the fluid of choice in the treatment of hypovolemic shock. But how can you diagnose that it is pre-renal? Repeated question. When urea creatinine ratio is elevated more than 20:1, the urine osmolarity is concentrated more than 500 milliosmol per liter, but the urine sodium level is less than 20 milliequivalent. FENA, fractional excretion of sodium, is less than 1%, which is the most sensitive factor. And the most specific, the biomarker, if it is negative, then it favors diagnosis of prerenal AKI. On the other side, if the patient is having the intrinsic AKI, also called as the renal causes of acute kidney injury, what will be the finding? In renal causes of AKI, the most common site, don't make this mistake, the most common site is tubular necrosis, followed by the interstitial nephritis, followed by the glomerulonephritis, that is rare. The most common site affected is the tubular necrosis. In tubular disease, most common pathology is vascular insufficiency, more than drug induced, more than the toxin induced. Okay. In tubular necrosis, most common cause of tubular necrosis is vascular insufficiency. Okay. Let me magnify only this table now. Is the vascular insufficiency can be due to drug induced like aminoglycoside and toxin related like heavy metal poisoning. In the renal AKI or the intrinsic AKI, the urea create ratio is going to be normal, less than 12:1. The urine osmolarity is dilute, less than 350 milliosmol per liter. But the urine sodium level will be minimum more than 40 milliequivalent. FENA will be more than 2%. And the biomarker, if present, is diagnostic of the intrinsic cause of acute kidney disease. Yes, that's the correct answer. So everybody must know this chart, whichever exam you give. From FMGE to NEET PG to INICET to UPSC, the same topic, the single most important chart in nephrology is difference between prerenal and intrinsic AKI. Chalo, moving on to the second one. Nothing to write here. The CKD associated metabolic bone disease. It is commonly asked CKD associated metabolic bone disease. It occurs only in CKD because minimum duration should be more than 6 months. The most common type is the osteitis cystica fibrosa, which occurs due to the secondary hyperparathyroidism. As I keep repeating, why does hyperparathyroidism occur? Is because of hypocalcemia. So the question, what are the causes of hypocalcemia in CKD? It is one, due to decreased calcium intake because of anorexia. There is decreased reabsorption of calcium because of vitamin D deficiency. And let us not forget, due to increased binding to phosphate, hyperphosphatemia is a specific finding. And that is why the treatment is to correct the mineral homeostasis. Not only correct the calcium, but also to correct the phosphate. The second type is the adynamic bone disease. Adynamic bone disease where it is due to poor weight bearing, causing remodeling bone defect is going to be seen. And here you want to encourage mobility. The third type is the rickets and osteomalacia, which occurs due to chronic acidosis, which leads to demineralization of the bone, and the treatment is to correct the blood pH. So questions are that why does CKD occur? What are true statements? It takes minimum 6 months to occur. Most common type is osteitis cystica fibrosa. First line treatment is not only calcium, but correction of phosphate also. Other two are the relatively rare types of metabolic bone disease. Correct. The third one, repeat one from the DVT slide, but very, very important, that when to call it significant hematuria, when RBC is present in urine sample, when to call it significant hematuria. Number one, when there is symptomatic hematuria, when number of RBC is more than 100 per high power field, or when hematuria is seen on recurrent testing, then you must check for the further investigation. In all patients with significant hematuria, you must look further based on the RBC morphology in the urine microscopy. Most common type is eumorphic, which indicates site of the disease is postrenal. So overall, if I ask you, most common cause of the hematuria, answer should be urinary tract infection. Overall, most common cause of hematuria will be urinary tract infection, can be due to renal calculi, coagulopathy, or rarely due to intraluminal pathology like carcinoma bladder. Very good. But the other side, don't forget that rarely it is a dysmorphic hematuria which is specific for glomerulonephritis. In glomerulonephritis, as I'm telling you, what is most important? To look for the serum complement levels. They always ask you. There are only two conditions where the serum complement level is normal. There are only two conditions where the serum complement level is normal. The serum complement level is normal in adult. The answer is IgA nephropathy. In children, it is going to be HSP that you can identify. But if the complement level is low, we are told that complement reduces in the post-infective causes, but that can return to normal after antibiotic therapy. The most common cause in our country, post-streptococcal GM. But if the complement level is persistently low, then the diagnosis is always lupus nephritis. So must know chart. So what is the specific finding? In glomerulonephritis, dysmorphic hematuria with or without RBC cast is diagnostic of glomerulonephritis. One of the method to identify the cause is to look at the serum complement level. Take it forward. But what is the more specific cause? In a nephritic versus nephrotic syndrome, repeated question, integration with pathology. When to call it nephritic syndrome? When the patient has got hematuria, hypertension in GN, then you call it nephritic syndrome. The most common cause of nephritic syndrome is the IgA nephropathy. How to identify? Other than complement level, which we already knew in the previous slide, we can tell the probable diagnosis based on the antibody present. But the diagnostic test always will remain renal biopsy. So when they give you a clinical scenario and ask you to mark diagnostic test, answer is always renal biopsy, though we prefer to do clinical classification first. So when a nephritic syndrome is having elevated IgA level with a granular pattern with predominant IgA, answer is IgA nephropathy, but the prognosis is the best because risk of progression to RPGN is minimum, less than 1%. But a patient of nephritic syndrome is positive for anti-DNase or ASO titer with a granular pattern with predominant IgG. It is post-streptococcal GN where the prognosis is still good because risk of RPGN is 1 to 5% only. Anti-dsDNA is specific for the lupus nephritis what you will get on the biopsy? Full house pattern where the risk of RPGN is moderately elevated. It is the nephritic syndrome with ANCA. Posse immune finding, MCQ, previous year question. Posse immune is seen in the vasculitis syndrome, Wegener's and Church-Dawes syndrome. Anti-GBM positive, least common cause, where you will get linear pattern seen with the Goodpasture syndrome with maximum risk of RPGN. So they always ask you, what are the findings? How to reach diagnosis? Let us move forward to the nephrotic syndrome. When to think of nephrotic syndrome? When the question is giving you a symptom, edema, anasarca. Edema anasarca presents with classical features of nephrotic syndrome. No atypical feature in a child. Answer is minimal change disease, that is fusion of podocyte alone. But if you get a nephrotic syndrome in adult also having hypertension with 20% sclerosis, answer is FSGS, right? But in an elderly person, if you get nephrotic syndrome with hematuria, spike and dome pattern, answer is membranous nephropathy. 2 points, I'm going to add it here. What you want to remember from this? In the membranous nephropathy, what is the most common antibody present? 85% cases are autoimmune pathology. They are the autoimmune cause of the membranous nephropathy. I want you to type out which is the antibody that you see. Anti-phospholipase A2 receptor antibody. Phospholipase A2 receptor antibody. PLAR antibody is seen. Very good. PLAR antibody seen in membranous nephropathy. While in FSGS, the most common cause of FSGS remains the diabetic nephropathy. Most common cause remains the diabetic nephropathy. But the rare MCQ, the collapsing type of FSGS. Rare is the collapsing type of FSGS seen in patient with HIV associated nephropathy. So previous year topics are always glomerulonephritis gets the big share in our nephrology department. That is what we already know, right? So take it forward. So when to go for emergency dialysis? When do you go for emergency dialysis in a patient with renal failure? So we can remember AEIOU. What are the factors? When the patient is having the acidosis, which is refractory more than less than 7.20. Remember it as AEIOU, acidosis, refractory to treatment. E, electrolyte imbalance, hyperkalemia, which is also the most dreaded feature of CKD. So most common cause of death in renal failure is hyperkalemia associated arrhythmia. That can be indication for dialysis. I for ingestion of dialysable toxin. Which are the dialysable toxin? Salicylate, methanol, polyethylene glycol and lithium. O, overload of the fluid, refractory pulmonary edema. U, for serious uremic symptom, we have discussed encephalopathy, convulsion, pericarditis, shock, intractable vomiting, coagulopathy. 6, serious uremic symptom. And the laboratory finding, severe azotemia, is the indication for emergency dialysis. Perfect है. So यही हमारा nephrology repeated question. Always one of my favorite topics and also examiner's favorite topic. Integration with respiratory medicine. The renal tubular acidosis. In the respiratory, ABG shows normal anion gap in plasma, high gap in urine. How to diagnose RTA? Normal anion gap in plasma, high anion gap in the urine. Diagnosis of the renal tubular acidosis is going to be there. In the patient, the most important, what was the question? Most important finding to identify type of RTA is the urinary pH. After RTA is diagnosed, most important parameter remains urinary pH to know which is the type of RTA. Because I'll tell you what are the questions. When the urine pH is going to be more than expected, 100% diagnostic of the type 1 or the distal RTA. Because distal RTA is the defect in H plus K plus ATPase form, which is most severe, most common inherited type of RTA, presenting in children with rickets and short stature, along with nephrocalcinosis. Again, the question, what is cause of renal calculi in type 1 RTA? Both are correct. Both hypercalciuria and hypositraturia. Both can lead to increased risk of renal stone in patient with type 1 RTA. Look at the other side. When the urine pH is as expected, that means relatively milder type is there. But remember, in early stages of type 1, the urine pH can be more than 7.5 also. In early stages of the type 2, urine pH can be more than 7.5 also because of bicarbonate loss in the urine. But as the acidosis occurs, the urine pH returns to normal. But diagnostic of type 2 is the Fanconi stride. Diagnostic of type 2 is the Fanconi stride. Another question, glycosuria, amino acid urea, and the phosphate urea is there. Very good. The rare type, least common rare type of RTA is the type 3, where problem is not in kidney, but defect is in the carbonic anhydrase gene defect, presenting with cerebral calcification, osteopetrosis. That is why type 3, also known as marble brain, marble bone disease. The most common type of RTA in the clinical practice, but mildest is type 4. What is very clear? Hyperkalemia is a feature only of one disease. Hyperkalemia is seen only in type 4 RTA, either due to early CKD, where there is aldosterone resistance, or drug-induced ACE inhibitor, ARB, can cause this type of RTA. So repeatedly, you have to know what is approach to types of renal tubular acidosis. That is done. Moving on to the next one, rheumatology section. Come on, fill in the blanks for me. In SLE, what is the role of our ANA? ANA is the best screening antibody. In SLE, ANA is the best screening antibody. And after the EULAR update, it is also the essential or the entry criteria that it is to be positive. But the most specific antibody in SLE is the anti-Smith, though it is not sensitive, not common. It is the anti-dsDNA, which is the most preferred antibody. Why most preferred? Because it is both sensitive and specific for the diagnosis. It is both sensitive and specific for the diagnostic. and it is prognostic also. That is important. It is prognostic also is there. Antiphospholipid antibody is again both diagnostic and prognostic in a patient with SLE. What prognosis does it tell you? Thrombosis and recurrent abortion. It tells you thrombosis and recurrent abortion can be predicted with the presence of APLA. With the presence of APLA. Anti-erythrocyte seen with risk of hemolysis. Antiplatelet seen with risk of coagulopathy due to thrombocytopenia. There can be anti-ribosomal antibody. Ribosomal antibody can be seen where it is seen with increased neuropsychiatric symptom, and neuronal antibody seen with the risk of the neuropathy. Peripheral neuropathy can be seen with this finding, right? So we know these answers, but remember there is no escaping the topic of SLE. SLE, the known of antibody. Yes, PDF will be available. So SLE, the diagnostic antibody, prognostic antibody, must know. Repeated question is going to be there. Moving on forward. Idiopathic inflammatory myopathies. We said idiopathic inflammatory myopathies when the patient comes with the rash. When the rash is absent and the defect is proximal, we think of the polymyositis, which is the most common cause of the myositis syndrome. But if the weakness is distal more than proximal, it is the inclusion body myositis. It is the inclusion body myositis is going to be there. And if skin rash is present, then no confusion. It is the dermatomyositis. The previous year questions in dermatomyositis, most characteristic is the presence of Gottron's rash, and most specific antibody is the anti-MI2 antibody is the most specific antibody in a patient with dermatomyositis. Distribution of the rash that is asked. Dermatomyositis is examiner's favorite among the three, though in practice most common remains the polymyositis is going to be there. Very good. Correct. Hai? So again I'm telling, once even one slide you see about that topic, your mind automatically revises, churns out the full topic for you. Excellent. When patient comes with inflammatory polyarthritis means more than equal to 5 joint involvement. When patient is having polyarthritis, more than equal to 5 joint involvement, most common cause is going to be rheumatoid arthritis. But the differential diagnosis can be the SPA, spondyloarthropathy, which further has got 4 causes. Which are the 4 causes? We remember the acronym PAIR. Spondyloarthropathy, remember the acronym PAIR. Psoriatic arthropathy, ankylosing spondylitis, IBD associated, and the reactive arthritis. So direct question. These are HLA-B27 positive. So keywords here, when a patient with polyarthritis comes with a positive RA factor without family history, having most primary site synovitis, predominant articular symptom, think of RA, first line treatment is to give DMARD. Most potent DMARD is to give methotrexate, except in pregnancy. where the preferred drug is hydroxychloroquine. Spondyloarthropathy, seronegative. But what is positive? HLA-B27 positive is there. Primary site is enthesis, extra-articular feature, and first-line treatment can be NSAID alone, can be used for the management of this particular disease. Take this forward. So, all the best. So, keep life very simple. Time management is very important. So, what are the triad for success? Already, listen to this carefully. You have already completed your preparation. Be confident about your preparation. Let us see this. What I want you to say, be confident about your preparation now. That time is over. So, as I always say, before the exam, study as if you don't know anything. But just 1 week or 1 day before the exam, how you must feel? Feel confident like Rajnikant, that you know everything. Be confident, because the triad for success is to remain calm. On the day of the exam, remain calm. Panic is your single worst enemy, not lack of preparation. जितना पढ़ना था पढ़ लिया, अब क्या करना है? जो आता है उसे ट्रांसलेट करना है. उसके लिए क्या करेंगे? You want to remain calm, and please everybody, I'm sure Deepti madam as the most famous propagator of this, is manifest. कि सोचो क्या रैंक चाहिए आपको, क्या ब्रांच चाहिए, क्या कॉलेज चाहिए, मैनिफेस्ट करिए और बिंदास जाके परफॉर्म करिए, है ना? द स्टेज इज योर्स, इट इज सेट एंड इट इज सेट फॉर यू टू विन. ऑल द वेरी बेस्ट टू यू. चलो, सी यू ऑन द अदर साइड एज कलीग्स, as co-consultant, not as my students. All the best to you.
Hello, good morning, all the students. So, hopefully, your preparations are going very well and you are ready to crack this NEET PG. So, today I will be just revising or giving you an overview of the very high yielding topics from two subjects like GIT and CVS. So, let's start with the GIT section first. So, in the GIT, this topic is one of the frequently asked topic. That is a topic of CLEX 2, and one-liner questions, stat questions come from the CLEX 2. So CLEX 2, it is hypersensitivity to gliadin protein. It is present in the gluten. So basically, if question come, it is hypersensitivity to the protein. Gliadin protein is the hypersensitivity. Now. The extraintestinal manifestations. So extraintestinal manifestations here will be the most common extraintestinal manifestation will be dermatitis herpetiformis. This is most common extraintestinal manifestation. Other manifestations can be autoimmune hepatitis. So this is the CLEX proof which is associated with elevation of ALT. This question have come. Which malabsorption syndrome is associated with high ALT? Answer is CLEX proof. There will be a primary biliary cirrhosis as well as autosplenectomy. Therefore, the vaccine for pneumococcal vaccine is indicated here. Pneumococcal vaccine will be indicated. Then IgA deficiency will be present here. Now coming to the most specific antibodies here. Most specific antibody is anti-endomycin antibody, but the problem is it is not available everywhere. While most sensitive antibody which is most commonly done is anti-TTG antibody. So the most commonly done antibody here is anti-TTG antibody, sensitive antibody. But if question come, what is the most sensitive and specific antibody? So here the answer will be Pacific. So the answer here will be yes, it will be anti-TTG. Specific and sensitive both if they are mentioned here. Now, the second important topic is the inflammatory diseases of the intestine, that is ulcerative colitis and Crohn's disease. So, if we'll see the table of ulcerative colitis and Crohn's disease, so there will be smoking that decreases the risk of ulcerative colitis, while smoking increases the risk of Crohn's disease. So, this is a unique characteristic feature here. If tenesmus is given, this is the keyword here. So, this is keyword. For ulcerative colitis. So this is present in ulcerative colitis while it is totally absent in Crohn's disease. Yes. Fistula formation, malabsorption, strictures. So these three features, fistula formation, malabsorption and stricture, they will be absent in ulcerative and they will be present in Crohn's disease. So they will be present in the Crohn's disease. Now the toxic megacolon is a feature of ulcerative colitis, but it is extremely rare in Crohn's disease. Now, coming to the antibodies, so antibody in ulcerative colitis is P-ANCA antibody, and Crohn's disease it will be ESCA antibody. Yes, and skip lesions. Skip lesion will be a feature of Crohn's disease. Granuloma, non-caseating granuloma will be a feature of Crohn's disease. So these are the features which will be present in cases of Crohn's disease. And as far as the treatment portion is concerned, so you will be asked mainly the severe IBD treatment. So severe IBD treatment, this is intravenous steroids. That is the treatment of choice for severe cases of inflammatory bowel disease. In mild to moderate, it is the ASA agents or oral steroid which are given here. Now, coming to the extraintestinal manifestations, so this section is also one of the FAQs, key extraintestinal manifestation in ulcerative and Crohn's disease. So, we all know that Crohn's disease affect the whole of the intestine, so the extraintestinal manifestation will be more in Crohn's disease. So, know this important point, they are more common in Crohn's disease except two. And way to remember is P-ANCA antibody starting with P is seen in ulcerative colitis. So double P will be more common in ulcerative colitis, pyoderma gangrenosum and primary sclerosing cholangitis. So these two conditions, they will be more in ulcerative colitis, more in ulcerative colitis. Now, the next third important topic is hepatitis B serology. One question is always guaranteed on the hepatitis B serology. So you will be given either the phase of hepatitis B or the serological markers of hepatitis B. So there will be incubation period. So the marker in the incubation period will be HBS antigen. And there can be HBE antigen as well during the incubation period, and it is characterized by absence of any antibody, while in cases of acute symptomatic phase, window period and acute recovering phase, the common antibody which will be present is IgM anti-HBC. This will be present in all the three scenarios. So in acute symptomatic, what else can be present? HBS antigen can be present. Yes. And in cases of window period, other markers will be absent. HBS antigen is characteristically absent. Anti-HBS is also absent. So this is one of the question of window period which is frequently asked. While in cases of acute recovering phase, besides this common antibody, this is a common antibody across all the three phases: acute, window, recovering. So anti-HBS will be present here in the recovering phase. Yes, incubation period, no antibody will be present. Yet in window period, nothing will be present except for IgM anti-HBC. While in a past infection, we will get IgG anti-HBC. This will be present, and that can be associated with plus minus anti-HBS. Anti-HBs can disappear later on. It can disappear later on. Now, tell me, post-vaccination marker is which marker? So, my question to you: post-vaccine marker is which marker? What will you mark for a post-vaccination? So, answer here will be yes. For post-vaccination marker, answer will be anti-HBs only. Remember this point, only this antibody will be present, no other marker will be present here. And in cases of chronic infection, so chronic infection will be of hepatitis C, HBs antigen will be present, and along with the HBs antigen there will be presence of IgG anti-HBC. IgG anti-HBC will be present here. Yes. So, in cases of chronic infection, whether it is a carrier state, chronic hepatitis, or cirrhosis, this is the common antibody, which is antigen antibody, which will be present across all the spectrum of carrier, cirrhosis, and chronic hepatitis patients. So, one question is always guaranteed on hepatitis B serology. Now, coming to the liver scoring. So, the liver scoring which are asked from you is the MADRS score. So, the MADRS score is used for alcoholic liver disease. It is used for the alcoholic liver disease, and the common parameter which will be used here are serum bilirubin and prothrombin time. These are the common parameter which will be used in the MADRS score, alcoholic liver disease severity. Second one which is asked from you is the MELD scoring system. So the MELD score system is basically for liver transplant indication. Yes, it is for indication of liver transplantation. Parameter which are used here are serum bilirubin and INR, as well as creatinine. And recently a new marker have come, MELD Na. So in MELD Na sodium is also included. So if question come on MELD Na sodium, so sodium will be included in this scoring system extra. Now NASA score is used for Wilson disease. It is used for the Wilson disease. And the parameter which are used here are serum bilirubin. Serum bilirubin is used, as well as there will be prothrombin time and SGOT. They will be used in cases of the Nazar score. And finally the Child-Pugh score. Child-Pugh score is for cirrhosis due to any etiology. And here, besides the biochemical parameters like bilirubin, prothrombin time, albumin, these are the three parameters which are biochemical. We have clinical parameter like encephalopathy and ascites. So these will be the other marker which will be used in Child-Pugh score for the cirrhosis severity. So to remember in the exam, just remember that two common marker are used in every scoring system: bilirubin and prothrombin time. Your option will be almost correct. Now coming to the topic of ascites. So this ascites topic is very important. Only 2-3 steps you can make a diagnosis of ascites. So the most important step in the ascites will be the SAAG ratio. So if the SAAG ratio is more than 1.1, that is serum albumin minus ascites albumin, and the ascites total protein levels, if the ascites total protein levels are less than 2.5, then it is a case of cirrhosis. While the protein level are more than equal to 2.5, then it is a case of post-sinusoidal cause of ascites. Post-sinusoidal cause of the ascites. So this and do not confuse ascites total protein from ascites albumin. So many students confuse that. So remember, this is a total protein in ascites fluid, not the albumin. While if the SAAG is less than 1.1, then it can be because of two reasons: either serum albumin is low, which is seen in cases of nephrotic syndrome. Yes, nephrotic syndrome. And if the ascites albumin is high, Then it will be a case of inflammatory peritoneal disorders. Peritonitis, inflammatory peritonitis like cancer, tuberculosis, or acute pancreatitis. Acute pancreatitis, and the most common cause of the ascites overall and in India is always cirrhosis. Cirrhosis is the most common cause of ascites. So maximum question, 90% of the question will come from the analysis of ascites fluid. Analysis of ascites fluid. Yes. Now coming to the next one. So this topic they are picking up spontaneous bacterial peritonitis. So this is also known as primary bacterial peritonitis, or we can say spontaneous bacterial peritonitis. So in this condition, the most important is the ascites fluid analysis. In the ascites fluid analysis, this is of high importance. Neutrophil count in the ascites fluid will be, this is the hallmark, more than 250 per mmq. Without that, the diagnosis of SBP should not be marked. And very, very importantly, the SAAG ratio, because it is due to ascites or due to cirrhosis, so the rate SAAG will be more than 1.1. While protein level will be less than 1 gram per deciliter, and that indicate a recurrence risk. So this is a recurrence risk. And drug of choice is cefotaxime. Yes, you have rightly said the most common bacteria in the culture, most common culture which is grown is E. coli. But remember, culture is not mandatory for the diagnosis. Sometimes you will get a question that culture is negative. Culture is negative. So it can be SBP because culture can be negative due to prior antibiotic use as well. So this is not a mandatory criteria that culture should be positive. Now, coming to the cardiovascular system. So in the cardiovascular system, the most important section is the JVP. In the JVP, you should be aware of the JVP waves and at what time those JVP waves are coming. So if we make a diagram of the JVP wave, this is a JVP wave, A, C, X, V, and Y. So from the C wave is the S1 heart sound, and just at the just before the V1 is S2 heart sound. This is the S2 heart sound. And as far as the ECG is concerned, so though this was the question asked in your INICET exam, the ECG manifestation correspond to which event? So just before the A wave there is a P wave. This is a P wave just before the A wave, just before the atrial contraction. And then there was a QRS complex. This QRS complex is followed by the S wave. Mechanical contraction occur later on, and then at the end of the T wave is S2. So this is QRS complex, this is T wave. So this is a superimposition of the QRS, superimposition of the QRS on the JVP line. Most common cause of SBP in nephrotic syndrome is Streptococcus pneumonia. Yes, true. But whenever SBP comes, nephrotic syndrome is not mentioned. Most common cause of SBP is cirrhosis. It is cirrhosis. Now, the second question on the JVP which you will be getting is the JVP abnormality, and absence of the waves are most important. So this is a very frequently asked question, that is absent A wave in the JVP. So this will be seen in cases of atrial fibrillation. This is seen in cases of atrial fibrillation. Large A wave, most common lesion is tricuspid stenosis. So there will be a tricuspid stenosis. While Canon A wave is also an important question. So in the Canon A wave, there will be junctional rhythm. Yes, junctional rhythm. There will be PSVT, and complete heart block. So complete heart block will be present here. Now absent V wave. So absent V wave will be SVC obstruction. So there will be SVC obstruction. Yes, and absent X descent. Absent is X descent is a feature of, it is a feature of tricuspid regurgitation. And very, very important, absent Y descent. So many times this question have been asked. Absent Y descent is a feature of cardiac tamponade. So cardiac tamponade will be the answer here. Cardiac tamponade. Yes. So these absent A wave and absent Y descent, these are the two very, very important absence of the GVP where you can make a diagnosis, where you can make a proper diagnosis. Now, moving on to the next one. Next one is the cardiac murmur. So these days they are giving you the diagram based questions. So these are the cardiac murmur. So my advice is just look at the S1 and S2. Your answer will be clear cut. Like the first diagram. The first diagram here is, this is a case of a pan-systolic murmur. So this is pan-systolic murmur which is present here. And the valvular disease which causes a pan-systolic murmur are chronic MR and chronic TR. Though it can be seen in VSD also, but as far as the valvular heart diseases are concerned, so valvular heart disease here will be MR and TR, chronic MR and TR. And if you can see the second one, so PDA will not be the answer. PDA causes a continuous murmur. PDA will cause a continuous murmur. Now, if you look at this diagram, this is ejection systolic murmur. Ejection systolic murmur. So ejection systolic murmur is a feature of aortic stenosis, pulmonary stenosis, and as well as high cardiac output states. So this is ejection systolic murmur. Yes, correct. Very nice. While this is early systolic murmur. Early systolic murmur. So early systolic murmur is a feature of acute MR, acute TR, and it is seen in cases of a small VSD. It is seen in cases of a small VSD. Yes. Yes, very good. HOCM. So it can also be, ejection systolic murmur can be seen in hypertrophic obstructive cardiomyopathy. Great. Now the fourth murmur in the list, this is a late systolic murmur. Late systolic. So late systolic murmur is a feature of mitral valve prolapse. So it is seen in cases of MVP, mitral valve prolapse. Now moving on to the next one. So this is, as you can see, this is seen in cases of diastole. So look at the diastole. This is early diastole. So in cases of early diastole, this is seen in cases of AR and pulmonary regurgitation, early diastolic murmur. And this is a mid diastolic murmur, mid diastolic. And it shows a pre-systolic increase, pre-systolic increase. So it will be a feature of MS and TS. Valvular heart disease, MS and TS will be the answer here, mid diastolic. And the last one which you can see is systolic and diastolic murmur, peaks around the S2. This is seen in cases of continuous murmur. This is a continuous murmur. And it is seen in cases of PDA, AV fistula, severe stenosis of the artery, severe stenosis, increased blood flow across the arteries. So it is basically the valvular causes which are leading to the continuous murmur. Vascular disorders will lead to continuous murmur, and it is never due to, so this is for your exams, never due to valvular defects. Valvular defects. So this way you can make, yes, Gibson murmur is a murmur which is a murmur of patent ductus arteriosus, patent ductus arteriosus. Now after the murmur comes the topic of infective endocarditis, and high predictability is that infective endocarditis question will come because there are some changes in the criteria. So those criteria will be asked from you. So this is an expected question. Superimposed murmur coincidence with ECG, same thing. That is same thing. The diagram which we have made for S1 and S2, same diagram will be made here. Gram-Steele murmur, Kerry-Coombs murmur. Gram-Steele murmur is PR murmur, and Kerry-Coombs murmur is a murmur of rheumatic fever. Now, most common predisposing factor for the infective endocarditis is mitral regurgitation. Coarctation of aorta cause continuous murmur if it is severe. Congenital heart disease is ventricular septal defect. Cyanotic heart disease, tetralogy of Fallot. Most common non-cardiovascular risk for infective endocarditis is the IV drug abuse. Community acquired infective endocarditis is Streptococcus viridans, while most common hospital acquired infective endocarditis is Staph aureus. So these are the one liner question of infective endocarditis. As far as the organisms are concerned, so it will depend on the type of the valve defect which is affected. So the type of the valve which is defected, like prosthetic valve infective endocarditis, overall it is Coagulase negative staph. Less than 1 year, Coagulase negative, and more than 1 year, it will be Streptococcus viridans. Where nothing is written for prosthetic valve, then CONS will be the answer. While in cases of IV drug abuse, most commonly it is the tricuspid valve which will be affected. Yes, overall it will be Staph aureus, right-sided Staph aureus, and left-sided it will be enterococci. So this last one will be a very crucial thing, that if the aortic valve or mitral valve are given to be affected in IV drug abuse, then the answer will change to enterococci. If nothing is mentioned, then Staph aureus will be the answer. Staph aureus will be the answer here. Now, according to the criteria which are changed, just a revision of the summary of the criteria for infective endocarditis, Duke's criteria. So the major criteria, the two major criteria are retained, like evidence of microbiological evidence, culture, PCR or serology. Imaging evidence, CT scan has been added. Earlier it was echo. While the third one, this is a new added major criteria, that if there is surgical evidence during the surgery, then it will be considered as a major criteria. Means ki vegetation are seen during the surgery. So this is a newly added major criteria. Number 3 criteria. While the minor criteria, initially there were 5 minor criteria which are retained, like predisposing factors. For example, patient is having a rheumatic heart disease, patient is having IV drug abuse. So these are the predisposing factors. Other factors, other minor criteria: fever, immune phenomena, vascular events, and investigation which are not fulfilling the major criteria will be taken. So these are the previous 5 major criteria. Now 2 minor criteria are added, like if FDG PET scan is positive, uptake of FDG is more in the heart, then it is a minor criteria, and clinically a new regurgitant murmur heard is a minor criteria. So these are the 2 new minor criteria, most likely expected question for your exams. Expected question for your exams. Now, the other topic where one question, pharmacology is important, and that pharmacology is important for the heart failure with reduced ejection fraction, and a new change here. So first line drug, we all know that ACE inhibitor or valsartan sacubitril is given. So out of this, valsartan and sacubitril is now considered to be more effective. If question comes, which is the most effective agent, so more effective than ACE inhibitors, valsartan and sacubitril combination. This is known as ARNI. Now the beta blocker, here will be the 3 beta blockers: metoprolol, bisoprolol, and carvedilol, spironolactone, and SGLT inhibitor, out of which SGLT inhibitor are also approved for. So also approved for heart failure with preserved ejection fraction. So heart failure with preserved ejection fraction, these are also indicated. So they are also approved for heart failure with preserved ejection fraction, SGLT inhibitor. So this is a new change or a addition change. Now, coming to the this most feared topic, that is the topic of the arrhythmia. So once you have to make a diagnosis of the arrhythmia, then the management will be done accordingly. So the arrhythmia wide QRS complex means it is more than 3 mm, heart rate is 100 to 250. It is a case of ventricle tachycardia. So heart rate will decide whether it is ventricle tachycardia or ventricle flutter. More than 250 is ventricle flutter. So these are the diagrams here. So here you can see this is a monomorphic. So monomorphic. So in monomorphic, if patient is stable, then the drug of choice is IV amidron will be given. While in cases of the ventricle flutter and polymorphic, this one is a polymorphic. This is polymorphic. VTech. So they are always unstable. So DC shock will be given here. DC shock will be given here. Ventricle flutter and ventricle fibrillation. While if it is a very irregular rhythm, no QRS are identifiable, this is also ventricle fibrillation. So ventricle fibrillation is also managed by DC shock. So in all these three conditions, polymorphic VTech, DC shock, ventricle flutter, DC shock, fibrillation, DC shock will be given. While again in monomorphic ventricle tachycardia, if there is a case of unstable patient, then DC shock has to be given. DC shock has to be given. So this way you can make a diagnosis and you can treat the patient accordingly. Now coming to the P wave. So the other most frequently given question is the PSVT and atrial fibrillation. My advice is whenever in doubt, you are seeing the ECG where QRS is normal, so only two arrhythmia will be given to you, 99%. So QRS is normal, P wave is absent. So if it is a regular heart rate, it is PSVT. If it is irregular heart rate, it is atrial fibrillation. So the drug of choice here will be adenosine, and drug of choice here is beta blocker to control the rate. If both of them are unstable, then DC shock will be the answer. DC shock will be the answer here. Monomorphic VTech, do we give synchronized cardioversion? Yes, we give synchronized cardioversion. In cases of polymorphic or ventricle fibrillation, we give asynchronized. We will give asynchronized cardioversion. Now, coming to the coronary syndromes. So in the coronary syndromes, if the ST segment depression is there and troponin is normal, then it is a case of unstable angina. So look at the troponin values, and if the troponin is elevated, then it is a case of non-ST elevation MI. And mainstay of treatment here is conservative treatment, and contraindication is equally important. Thrombolytics are contraindicated. Thrombolytics, yes, they should not be given here. While if ST segment is elevated, troponin is normal, then it is a case of a Prince metal angina. This is a very unique condition which you might get. ST elevated, chest pain, troponin level, Prince metal angina. Here nitrate will be given, followed by calcium channel blocker or alpha blocker. Contraindicated, aspirin and beta blocker. Yes, contraindicated will be aspirin and the beta blocker in cases of the Prince metal angina. Okay, question is, how will you differentiate a polymorphic from VFib? Very simple. In polymorphic, we take QRS are identifiable. In VF, they are not identifiable. If synchronized and defibrillation, both in the synchronized shock and defibrillation is nothing but asynchronized shock, that is given in cases of polymorphic VTech and ventricle fibrillation. For PSVT is next step, then it will be a carotid massage. If patient is stable, if unstable, then DC shock will be the answer. While in cases of ST elevation MI, so this is ST elevation MI, these are the time period which should be on your tips. Door to balloon time less than 90 minutes, that is from the arrival to the PCI done. Symptom onset for the PCI should be less than 24 hours, then it will be done. Door to needle time, it will be less than 30 minutes. So these time periods are very, very important for you to understand. Symptom onset for thrombolytic therapy is less than 12 hours. Less than 12 hours. Beyond 12 hours, do not give thrombolytic therapy. Now shifting to the PCI center from a non-PCI center, if the delay in the PCI is, so if the delay in the PCI is less than 120 minutes, then we will shift the patient to a large hospital or to a PCI center. So these three events, non-escalation MI, Prince metal angina, est elevation MI. Usually one question is always asked from here, especially the practical management will be asked. Now the topic of the hypertension, so there is a lot of controversy ki which guidelines should we follow. So we will follow whatever is the latest guidelines, which says that in grade 1 hypertension, if comorbid conditions like diabetes, CAD, okay, door to needle time is arrival of the patient till the starting of the thrombolytic infusion, that is less than 30 minutes. Now if these comorbid conditions are absent, lifestyle will be given. If these comorbid conditions are present, then we give lifestyle with drugs. While in all the patients of grade 2, lifestyle with drugs will be given. Indeed, this was the recently asked question in the INICET as well. Patient was in grade 1 and in the peripheral health center, you are a medical officer, patient does not have any comorbid condition, what will you do? So the answer was lifestyle modifications. Now, the agent to be given is if patient has diabetes, CKD, post MI, unilateral renal artery stenosis. So in all the cases, there is one drug of choice: diabetes, CKD, post MI, unilateral renal artery stenosis. So we give ACE inhibitors. Angina, hyperthyroidism. So in this we have beta blocker. Pheochromocytoma, benign prostate hypertrophy. So obvious choice will be in these cases pheochromocytoma, medical management has to be given, then it will be alpha blocker. So depending on the comorbid condition, we choose a particular agent accordingly. Yes. Now, finally coming to the last topic. So the last topic is always a guarantee in your exam. So identify what condition is this. Patient has dyspnea. Patient has backstride of low blood pressure, raised JVP, and soft heart sounds. Absent Y descent on the JVP. And you can see the QRS complex alternatively changing: high amplitude, low amplitude, high amplitude, low amplitude, means electric alternance on the ECG can be seen. So always one question you will get, this is a case of a cardiac tamponade. Each and every word is a keyword for you. And what is the treatment for this condition? Treatment for this condition is pericardiocentesis. Pericardiocentesis. So these were the high yielding topics that I picked from the cardiovascular system and the GIT system. So now wishing you all the very best for your exam. So 3-4 days are left for your exam. So whatever preparation you have done, just revise those notes. No new things. Just revise, revise, and revise. All the students who have cracked good ranks, they said only one thing: they have just revised the notes. That's it. So once again, wishing you all the very best for your exam. Thank you.
Hello, hi. Can you hear me? Am I audible? Am I visible to all of you? Can you hear me? Yes, shall we begin? My hello to all of you. Good afternoon, my dear students. I'm Dr. Sachin, Psychiatry faculty. So I have got this golden points for you today. Yes, somebody is writing not audible. Can you all hear me? Please check my voice. Please check my voice. I'm in DAMS office studio, so I think you should be able to hear me. Is the voice okay now? Voice. Volume. Okay. Okay, other students, please confirm, is my volume okay? You can increase the sound a little bit. Fully audible, no problem, sir. Okay. Shall we start? Shall we start? So, the marathon, the idea about the marathon is that we are discussing the most important crucial points not to be missed before going to the exam. So we are trying to revise 19 subjects in 2 days where I have been allotted 30 minutes. So in 30 minutes I wish to cover 80 points. This PDF would be shared in my Telegram and WhatsApp group, also in DAMS Telegram group. So I think I have already shared in the morning. Have you seen that? Have you seen that? Okay. So this PDF is already there. So without wasting any time, let's quickly start the session. Disorganized speech or not understandable speech is seen in which disorder? Answer: form of thought disorder. Form of thought disorder or schizophrenia. Very famous question. Loss of association or derailment is seen in which psychiatric disorder? Again, schizophrenia. In this, the thoughts are not connected to each other such that the speech is not understandable. Speech is not understandable. Next, neologism. You all know it is seen in schizophrenia, but which type of schizophrenia? In neologism, we have disorganized speech. So it is most commonly seen in disorganized variety of schizophrenia, known as hebephrenia. Known as hebephrenia. Most common delusion in schizophrenia. Delusion of persecution, also known as paranoid delusion. Also known as paranoid delusion. Delusion of grandiosity is seen in which psychiatric disorder? It is seen in mania, but it can also be seen in schizophrenia. It can also be seen in schizoaffective disorder. Mostly mania, but sometimes can be seen in schizophrenia, can be seen in schizoaffective disorder. Mostly schizophrenia, but can be seen in mania, can be seen in schizoaffective disorder. Delusion of nihilism is seen in severe depression with psychotic symptoms. Which is this syndrome known as Cotard syndrome. Cotard syndrome. Bizarre delusions are seen in schizophrenia. Bizarre means implausible, can't happen. Most common obsession. Dirt or doubt. I think I have asked you this in the classes. Dirt or doubt. Dirt. Most common compulsion. Washing or checking. Checking. If a patient with obsession tries to resist obsession, he or she will have. He or she will have. Come on. If a patient with obsession tries to resist the obsession, he or she will have anxiety. Most common psychiatric comorbidities seen in patients of OCD, depression. Thought insertion, thought withdrawal, and thought broadcast. Insertion, withdrawal, broadcast are seen in which psychiatric condition? Insertion, withdrawal, and broadcast are seen in which psychiatric condition? Schizophrenia. Flight of idea is seen in NEET PG old question. Flight of idea is seen in. Yes, these are disorder of possession of thought. Flight of idea is seen in mania. Slowing of thinking is seen in depression. Perseveration is seen in organic mental disorders. Do you think we are revising the most important points? Do you think we are revising the most important points? 15 points done in 5 minutes. Do you think you are supposed to know this? Yes. And I think all of you already know this. All of you already know this. You have to tell yourself, yes, I remember it. The more number of times you say this to yourself, the more will be the positive framework of the mind with which you go. The more number of times you say to yourself, yes, I remember it. If I would have been at your place, I would have said, yes, I remember it. Yes, I remember it. The more you tell your mind, I don't remember anything, I don't remember anything, the more the mind goes into a negative loop. Yes, I remember. Last 3 days, don't do active recall. Don't do active recall. What do you mean by active recall? Suppose I am revising these points. I will not keep my hand and force my mind to recall. I will tell my mind, okay, this is the question, this is the answer. This is the question, this is the answer. This is the question, this is the answer. I will not solve MCQs in last 3 days. I will just see question, answer, I remember. Question, answer, I remember. Question, answer, I remember. I will start my day with an easy topic, easy subject. I will not start with a tough topic, tough subject. I will not start with memorizing. I will start with just looking. Just looking. Okay, I will start my day with memorizing. Not memorizing, just looking. In the next 3 days, I will make sure to talk to my family members. I will make sure to talk to my family member, and I will make sure to talk to them about anything else apart from studies. Talk to them anything else for 5 to 10 minutes apart from studies. कुछ भी बात करो पढ़ाई को छोड़ के. Break is equal to break. You, even if you talk to each other, don't ask how is your preparation going, how are you prepared for the exam. Please don't ask these questions to each other. I am not asking you how is your preparation going, how are you going. You're fine. You're fine. Okay, you're fine. Absolutely fine. I am fine. I'm done. I'm happy. Thought block is seen in anxiety, schizophrenia. Illusion is also known as pareidolia. Pareidolia. Most common type of hallucination, auditory. Third person more than second person. Most common type of auditory hallucination, running commentary. Third person. Visual hallucinations are suggestive of organic mental disorders. etiology known, cause is known. Tactile hallucination with substance. Tactile hallucination with substance. Cocaine. Magnon symptom. Formication. Olfactory and gustatory. Temporal lobe epilepsy. Temporal lobe epilepsy. Synesthesia with substance. LSD. Reflex hallucination. Affective flattening are seen in which psychiatric disorder? Schizophrenia. Labile affect is seen in mania or bipolar disorder. Incongruent affect is seen in. Incongruent means not matching to the mood. Serial 100 minus 7 subtraction test is used for attention and concentration. Recent memory is tested by asking last 24 hours recall test. Don't test your memory in last 3 days because that will give you anxiety. Don't ask yourself. Don't ask, rather tell yourself. Yes, I remember. No testing, no recalling, no MCQ practice, nothing. Only reading with open eyes. No hand keeping, no mugging up, only reading. Visual memories. Similarity test is used to assess abstract ability. MMSC test which function? Cognitive function. Minimum duration required to diagnose schizophrenia. Six months as per DSM, 1 month as per ICD. Most important neurotransmitter implicated in pathophysiology of schizophrenia. Dopamine. 32 points done. Say yes, I remember. Say yes, I remember. All those students attending my YouTube live session today, ensure that you go with a very calm mind. Ensure that you give yourself positive boost. That is dopamine. Negative symptoms are predominant in which subtype of schizophrenia? Simple. Motor symptoms are seen in catatonia. Drug of choice for treatment resistant schizophrenia? Clozapine. Delusional parasitosis is also known as Ekbom syndrome. See, I remember this also. I remember this also. ये भी मुझे आता है, ये भी मुझे आता है, ये भी मुझे आता है. इतना तो मैं कर ही लूंगा, पास तो मैं हो ही जाऊंगा, ब्रांच तो मुझे मिल ही जाएगी. ये भी आता है, कुछ तो पढ़ा होगा मैंने. ये भी आता है. अच्छा देखो, ये भी याद आ गया. मुझे आता है, मुझे आता है, मुझे याद है. No confusions, no queries, no discussion, no clarification. Let the confusion remain as it is. No problem. We will solve it after 3rd August if you wish to. अब जो कंसेप्ट क्लियर होने रह गए वो मंडे को करेंगे. 3rd अगस्त होने दो मंडे को. ओके बस देख लो. Delusion of love is known as De-Clermont syndrome. Today's session is absolutely for the students who are writing the 3rd August exam. Those who are not writing the 3rd August exam and listening to this marathon, you are more than welcome to ask doubts, but not now. Not now. This session is not doubt session. And you know, doubts are contagious. So all those people attending the chat, please don't look at what people are asking. दूसरे का डाउट जो कि आपका क्लैरिफाइड था वो आपका डाउट बन सकता है. अगले 4 दिन तक हम किसी से भी डिस्कस करके पढ़ाई नहीं करेंगे. उसके कंफ्यूजन को खुद के पास लेकर नहीं आएंगे. ओके उसका कंफ्यूजन उसके पास रहने दो. आप अपना क्लैरिटी अपने पास रखें. डोंट कैरी द डाउट्स ऑफ अदर्स. फर्स्ट लाइन ट्रीटमेंट ऑफ मैनिया, एंटीमैनिक्स, lithium valproate also, and antipsychotics also. Both are first line. New drug for mania, endoxifen. Most effective drug in treatment of depression, tricyclic antidepressant. Fastest acting antidepressant, ketamine. Increased sleep and increased appetite is seen in atypical depression. Atypical depression. Low mood for more than 2 years is known as dysthymia. Neurotic depression. Treatment of bipolar depression is antidepressant plus mood stabilizer. Most common type of phobia, specific phobia. Feeling of impending doom is seen in panic disorder. Free floating anxiety, constant worry is seen in generalized anxiety disorder. Drug of choice for all neurosis is SSRI. Sensory motor neurological symptom after stress is seen in conversion disorder. 5 sets, 42 question per 42 minutes per set. Forty question per set. In each set, I will attempt 38 out of 40 minimum, so that my total attempts are 190 plus. एक सेट में 2 से ज्यादा सवाल नहीं छोड़ने हैं. It is possible that you leave 4 questions in first set and the second set is even more difficult and you leave 4 questions in the second set. Third set is even more difficult and you leave 6 questions in the third set. In one set, 38 out of 40 if you attempt, your total attempt will be 190. Am I clear? 2 से ज़्यादा क्वेश्चन नहीं छोड़ने हैं. Whether you agree to me or not agree, this is what I recommend. Automatically your unconscious mind will remember. सर ने कहा था 2 से ज़्यादा नहीं छोड़ने हैं. Don't leave more than 2. After each set, I will pause for 30 seconds and then start the next set. Is that clear? After each set, I will pause for 30 seconds and then start the next set. Is that clear? Pause and take a breath and then start the next session. Multiple somatic complaints without any organic cause. डीप ब्रेथ का मतलब, डीप ब्रेथ का मतलब प्राणायाम नहीं करना है. Patient is preoccupied with thoughts of having a serious life-threatening medical illness. Hypochondriasis, illness, anxiety disorder. Most effective drug in OCD. Clomipramine. Psychotherapy of choice in OCD. Exposure and response prevention. Psychotherapy of choice in phobia. Systemic desensitization. "25 points remaining, 7 minutes remaining. Are we going at a right speed? It's okay, you are not supposed to judge. Drug of choice for Tourette syndrome. Drug of choice for ADHD. Methylphenidate. Do you like the method of revising golden point? Question, answer, question, answer, question, answer. Only golden points. To teach this, I need 30 minutes. To prepare this, I spent 3 hours. Because I wanted to know how much to deliver in 30 minutes. Your time is more precious than my time at this moment. You have an exam after 4 days. Still, if you are sitting in front of YouTube and listening to me, that means you like me. Thank you so much. अगर आपका 4 दिन बाद एग्ज़ाम है फिर भी आज आप मुझे सुनने के लिए आए हैं, ये मेरे लिए बहुत ही गर्व की बात है. थैंक यू सो मच. Drug of choice for ADHD plus tics. Atomoxetine. First symptom to respond in ADHD treatment. Hyperactivity. Impulsivity and attention deficit. ADHD diagnosis must be onset before 12 years of age. Most common type of SLD, dyslexia. Autism spectrum disorder with normal language is PNIN. Asperger syndrome. Last 20 points. Are we ready? Are we all set? Microcephaly is seen in which autism spectrum disorder? Rett syndrome. Recently launched drug for autism in India, sulforafane. And here comes the alcohol. Drug of choice, alcohol withdrawal. Benzodiazepine. If you want to give oral, chlordiazepoxide. If you want to give IV, lorazepam or diazepam. Alcohol de-addiction, anti-craving, naltrexone or acamprosate. Naltrexone, both are equally good. Drug of choice, delirium tremens. IV lorazepam plus thiamine. Drug of choice for delirium of any etiology, haloperidol. Please clarify this. This question came in last FMGE exam. Drug of choice for delirium after head injury, haloperidol. Drug of choice for delirium tremens, IV lorazepam plus thiamine. Lorazepam plus thiamine. ये याद रहेगा? हाँ याद रहेगा. ये आपको याद है? Yes, I remember. If it is any etiology, haloperidol. If it is delirium tremens, then it is lorazepam plus thiamine. Benzodiazepine of choice in alcoholic liver disease. The benzodiazepine that love liver. Lorazepam, oxazepam. Drug of choice, opium intoxication. Naloxone. Asked in NEET PG 2022. Have you people seen FMG July 2025 questions? There were 8 questions. I don't want you to waste your time on that. Opium poisoning, naloxone. First question. A person not satisfied with his job, stressed at job, adjustment disorder, doable. A person feel he's great, delusion of grandiosity, people want to kill me, delusion of persecution, doable. Treatment of choice for nocturnal analysis, behavioral therapy, Bell and Pad, doable. Patient having schizophrenia, started on antipsychotic, developed dystonia. After dystonia, started on benztropine and developed anticholinergic side effect. Please see the 8 questions answers, only answer. 26 July was FMG exam, 3rd August is NEET PG exam. Possibility of a question coming from FMG to NEET PG is good. Have you seen the 8 answers of FMG? One was dissociative fugue. Okay. One was Telemanas. Do you all know what is Telemanas? It is an app. Mental health helpline 14412. App for telepsychiatry consultation by Government of India. Telemanas. I don't want you to waste time in checking out the FMG MCQ again. So I'm telling you right now, right here. 8 क्वेश्चन मैंने अभी बता दिए हैं आपको जाके नहीं देखने पड़ेंगे. सारे बता दिए जो आए थे. ऑलमोस्ट ऑल क्वेश्चंस वर डूएबल. आप सारे कर पाएंगे, बस एक टेलीमानस याद रख लेना. ओपियम सब्स्टिट्यूशन थेरेपी, मीथाडोन, better than buprenorphine. Opium anti-craving, relax prevention, naltrexone. Latest discovered drug for anti-craving for cannabis, N-acetylcysteine. Give it to your friend after exam. Substance that does not have withdrawal symptom, LSD. Bad trip, LSD, also seen with cannabis. Amotivational syndrome, cannabis. Hallmark symptom of delirium, altered sensorium, disoriented to time place person. Rapidly progressive dementia with myoclonus. Creutzfeldt-Jakob disease caused by prions. Visual hallucination movement problem. Which dementia? Lewy body dementia. Latest anti-amyloid drug. Donanemab and lecanemab. Confabulation is seen in Korsakoff syndrome. 30 minutes exactly and we have finished the 80 points. All the best for your exam. May you all carry my luck with you. अगले 4 दिन के लिए 5 दिन के लिए my luck with you. Wish you all the best. Message me after 3rd August evening. I'll wait for your message that were you able to solve psychiatric question, and I am sure your answer is going to be yes. Bye bye.
All right. Hello, everyone. Am I audible and visible to all of you? Please acknowledge. Am I audible and visible to all of you? Please acknowledge. Okay, so quick recap after psychiatry. I really enjoyed the session. So even I want you to believe in the fact that मैंने ये सब पढ़ा है, मुझे ये सब याद है, मुझे ये सब याद आ जाएगा. Although the fact of the matter is कि जो पढ़ा है वो याद हो नहीं रहा है, जो पढ़ रहे हैं वो याद हो नहीं पा रहा है, और जो पढ़ा नहीं है वो याद आएगा कहाँ से. So it is good to have positive affirmations. Affirmation is a very nice word on Instagram these days, along with one more word, manifestation. So it is good to do all these affirmations and manifestations, but practically it all lies here. If you have it, you have it. And if you have it, you will make sure that you make your point proven. So I won't take much of your time. I'll just show you images, because one image is 1,000 words. So I will not write anything, neither I want you to write anything. Just focus on images and we do quick recap. This is a picture frame spine. One can see very clearly. It is clearly seen in Paget's disease of bone. Paget's disease of bone, 8 to 10 times elevated level of alkaline phosphatase is the classical biochemical hallmark. Okay? So Paget's disease, picture frame spine, 8 to 10 times elevated level of alkaline phosphatase. You have to remember this. The second image is Ruger-Jersey spine. If all four end plates are dense, picture frame spine, only if superior and inferior end plates are dense, we call it Ruger-Jersey spine. Now, Ruger-Jersey spine is seen in osteopetrosis and renal osteodystrophy both. But if you have to choose one, then the answer should be renal osteodystrophy. You have to remember this. That is the second question. What you can see right now is a clinical image of something called as wind-swept deformity. Genovarus on one side, genovalgus on another side, wind-swept deformity. Question: the most common cause in children is rickets. The most common cause of this problem, wind-swept deformity, in adults, that is rheumatoid arthritis. So please remember, it is very, very important for all of us. The third image that I want you to see is genovarus and genovalgus. So if I have shown you genovarus on one side and genovalgus on the other, we call it windswept deformity. But if you see this, then on the right hand side you have genovarum, on the left hand side you have genovalgum. So bow legs is genovarum, knock knee is genovalgum. MCQ time, very simple. Genovarus, most common cause in children, rickets. In adult, osteoarthritis. Genovalgus, most common cause in children, idiopathic. In adults, it is rheumatoid arthritis. You have to remember this. This thing comes the most often. What is the blood level of calcium phosphate ALP in osteomalacia and osteoporosis? So in osteoporosis, the calcium is normal, phosphate is normal, ALP is normal. And you will agree with me that this is one of the most frequently asked MCQ. Drug of choice for osteoporosis, bisphosphonate. Is that an anti-resorptive or osteopromotive? Anti-resorptive. So please remember, drug of choice for osteoporosis, bisphosphonate. And what happens to the blood levels? Calcium normal, phosphate normal, ALP normal. Osteomalacia. The basic problem in osteomalacia is vitamin D deficiency, which further leads to calcium deficiency. Calcium and phosphate are brothers. So in osteomalacia, if calcium is low, phosphate is low, then ALP, which is a marker of osteoblastic activity, will be high. Quick recap: osteoporosis, calcium normal, phosphate normal, ALP normal. Osteomalacia, calcium low, phosphate low, ALP is a marker of osteoblastic activity, so that is high. Please remember this, one of the most frequently asked question. You have seen rugger jersey spine, you have seen picture frame spine, time for you to see fish mouth spine, quote fish spine, biconcave vertebra. So you can see collapse of the vertebral body height, which can be seen in osteomalacia as well as osteoporosis. But if you have to choose one, remember Malaysia. So P for picture frame is seen in P for Paget's, R for rugger jersey spine is more classical of R for renal osteodystrophy, M for mouth of fish spine is classical of M for Malaysia of osteo. Mallet finger, swan neck deformity, bow to ear deformity. First of all, you should see mallet finger. So if you can see mallet finger, then I hope most of you will agree that there is a extensor tendon injury which has happened here. Now, because of this extensor tendon injury, you can see that the distal interphalangeal joint has gone into flexion. I'm sure you all can see extensor tendon injury and flexed DIB. So this is mallet finger. Now, what is swan neck deformity? One small change in this problem, I'll tell you the change. If DIP goes into flexion with normal PIP, we call it mallet finger. But if you take DIP into hyperextension, it will become swan neck deformity. I'm sure you all can see. So mallet finger, DIP is in flexion, swan neck deformity, DIP is in flexion, and PIP is in hyperextension. So if you remember mallet finger, it will be very easy for you to remember swan neck deformity. The third deformity is the easiest because all you have to do is you have to just flip swan neck. So when you will flip swan neck, you will get something called as bow to ear deformity. So in swan neck, DIP was in flexion, here DIP is in extension. PIP in swan neck was in hyperextension, it is in flexion, that is bow to ear deformity. I hope you get the three deformities clear: mallet finger, swan neck, bow to ear. Just like blood levels of calcium, phosphate, ALP are very frequently asked in osteomalacia, osteoporosis, just like rugger jersey, picture frame, fish mouth is very frequently asked. Similarly, mallet, swan neck, bow to ear are also frequently asked. If somebody is talking about mallet finger, swan neck, bow to ear, you have to talk about gamekeeper's thumb. So injury to this ulnar collateral ligament of first metacarpophalangeal joint due to forceful outward deviation of the thumb because a ball comes and hits you here is called as gamekeeper's thumb. Do remember this. The next image is from something which you should guess right now. Can you people guess this? What is this? This is basically trigger finger. Alright, so this is basically trigger finger. So in trigger finger, first of all you have to tell me which is the most common tendon which is involved. Flexor digitorum profundus. This is FDB in front of you. Which pulley is involved? A1. Which joint level is involved? Metacarpophalangeal joint. So it's a trigger finger, A1 pulley, MCPJ, FDB. I think all these MCQs are clear to all of you. Now, if you see this image, you have to tell me that which test are they performing. They are performing Finkelstein test, modified Finkelstein test. So in modified Finkelstein test, you have to flex your thumb, you have to clench your fist, and if somebody will takes your wrist into forceful ulnar deviation, and if you have pain where my blue arrow is, this is called modified Finkelstein test. But that's not important. What is important is this, that this test, ठीक है, एक तरफ तो नाम तो हो गया important है Finkelstein, but which condition do we use it in? Very nice. Dr. Riluzol has mentioned it right. De Quervain's tenosynovitis. De Quervain's tenosynovitis is a problem. De Quervain's tenosynovitis is a problem which is a stenosing test, which is a stenosing tenosynovitis of APL and EPB. So 6 extensor compartment. The first extensor compartment have got 2 tendons, abductor pollicis longus, extensor pollicis brevis. They share a common tenosynovial sheath. So stenosing tenosynovitis of that tenosynovial sheath is basically called as de Quervain's tenosynovitis. And the test that we perform is called Finkelstein test. So I hope you now remember this problem. Now, I want to talk to you about one more thing, that if there is a young adult male, if he is in 40s, 50s, if there is a history of diabetes mellitus and that too uncontrolled, untreated, then the person comes to you and says that he cannot put his hand in his shirt. So we are talking about what? We are talking about frozen shoulder. Frozen shoulder has got 3 stages: freezing, frozen and thawing. But that's not my question. I have 2 questions for you. One, if they give you a clinical picture of a young male or a middle-aged male with diabetes with problem in movement of shoulder, your first diagnosis is frozen shoulder. Second, if they ask you about the stages freezing, frozen, thawing, the next thing is, which I am expecting, and I'm coming to the point that they might ask you, which is the first movement to be involved in frozen shoulder, answer is external rotation. The first movement that is lost is external rotation. That's why I've shown you this image. NEET PG 11th of August, there was a question. NEET PG last year, 11th of August, there was a question, Hawkins classification. So I'm expecting Hawkins sign. So neck of talus fracture is very common, and after that avascular necrosis of the body of talus is very common. So what happens after fracture neck of talus? In first 4 to 6 weeks, avascular necrosis occurs. But then because of some collateral circulation around the ankle, that AVN disappears. So this appearance and disappearance of AVN is a good thing or a bad thing? Good thing. That good thing is called as Hawkins sign. So if they ask you a question that Hawkins classification is in, okay, I'll show you first Hawkins classification. So this is Hawkins classification. Believe me, they will never ask you the details of types of Hawkins and all. No, they won't ask you. They will just ask you, okay, Hawkins classification is seen in. Answer is fracture neck of talus. That's what it is about. Then if they ask you about Hawkins sign, where do you see fracture neck of talus? Is Hawkins sign depicting AVN? It depicts that AVN appeared and then it disappeared. So is that a good thing or a bad thing? That's a good thing. It's a sign of it's a sign of revascularization. That is what I want you to understand. 2 very important soft tissue conditions: tennis elbow, golfer's elbow. So tennis elbow is lateral epicondylitis, golfer's elbow is medial epicondylitis. मेरा बात समझ में आ रहा है? Tennis elbow is lateral epicondylitis, common extensor origin, Tendulkar had. Golfer's elbow, although I don't play golf, but still I have this medial epicondylitis, common flexor origin. But that's not the question. The question is, which is the most common muscle involved in tennis elbow? Answer is ECRB, extensor carpi radialis brevis. Which is the most common muscle involved in golfer's elbow? FCR, flexor carpi radialis. So always remember this: tennis elbow, ECRB, golfer's elbow, FCR. There are 4 tendons to make rotator cuff. One is subscapularis, I'm sure you all can see. Second is supraspinatus, I'm sure you can see. Infraspinatus and teres minor, I'm sure you can see. So rotator cuff in anatomy is constituted by all these 4 muscles which combine together to make rotator cuff, which is present superiorly, anteriorly, posteriorly, but that is deficient inferiorly. So you have to remember this. Now, if there is a rotator cuff tear, there are few MCQs which we need to know. Which is the most common tendon to be torn in rotator cuff injury? Supraspinatus. What is the first movement to be affected? Difficulty in initiation of abduction. What is the first investigation? Ultrasound. What is the investigation of choice? MRI. What is the gold standard investigation? Arthroscopy. 5 MCQs. Now 4 more. What is the treatment of choice for acute traumatic tear? Rotator cuff injury, acute traumatic tear, treatment of choice, arthroscopic repair. What is the treatment of choice for chronic irreparable tear in a young patient? Tendon transfer. What is the treatment of choice for a chronic irreparable tear in an old patient? Reverse shoulder arthroplasty. All these MCQs are very, very important. This is one of the most expected MCQ from orthopedics and radiology. They might give you a clinical setting also, that a young boy, 14-15 years of age, who is into excessive running and suddenly he complains of pain in the knee, and X-ray is done and that shows a formation of a bony spicule along the insertion of patellar tendon. I'm sure the white arrow is also showing you that problem. So what is the clinical diagnosis? Osgood-Schlatter disease. Yeah, most of you are right. Shagufta, Saurabh, most of you are right. Osgood-Schlatter disease. So it is a traction osteochondritis of tibial tuberosity due to constant pull of patellar tendon. Now, this same person can come up to you with Sever's disease, which is traction osteochondritis of calcaneal tuberosity due to pull of tendoachilles. So please understand Osgood-Schlatter, please understand Sever. Osgood-Schlatter, Sever. Osgood-Schlatter, Sever. Two very important topics of orthopedic radiology. Scaphoid is a bone that has got a retrograde blood supply. Scaphoid is a bone which forms the floor of anatomical snuff box. Scaphoid is the most common carpal bone fracture. And if you have fracture of scaphoid, that is usually in the waist. The proximal pole can go into avascular necrosis, but the most common complication will remain non-union. I will revise all these points with you. It is the most common carpal bone fracture. It makes the floor of anatomical snuff box. Therefore, when you have a fracture, you have tenderness in the snuff box. Usually, fracture happens through waist. Proximal pole can go into avascular necrosis, but still the most common complication of fracture scaphoid is non-union, and you have to remember these points. Clear? Now, avascular necrosis is something which has been coming almost every alternate year. Most common cause of avascular necrosis, idiopathic. Most common area of avascular necrosis, in front of you, head of femur. What X-ray sign do we see in avascular necrosis of head of femur? Crescent sign. What is the first movement that is affected in avascular necrosis of the head of the femur? Abduction. There are many causes. Alcohol is one, steroid is one. There are many causes, but most common will be idiopathic. The most common side will be head of femur. The first movement that will be involved will be abduction. Alright, always remember. X-ray will show you crescent sign. Investigation of choice. Come on, for blood supply, what is the investigation of choice? MRI. So remember all these points about avascular necrosis of head of femur. They are very, very important. I'm sure on the scan you can see that in the center there is a radiolucency, and that radiolucency is black in color, which is actually nothing but a nidus of less than 2 centimeter with peripheral rim of sclerotic rim called osteoma. So you have an osteoid surrounded by osteoma, and it will give you night pain because prostaglandins are the reason behind night pain, and eating aspirin will be a great help. So I'm sure by now you must have been clear, which I think 1 or 2 people have already judged, Funny Star and Dr. Muthu, Divya, osteoid osteoma. So classical X-ray picture of osteoid osteoma. You can see a growth of the bone growing outside the bone with a bony stalk. Okay? With a bony stalk. So there is a bony stalk with a cartilaginous cap. Alright? So there is a bony stalk with a cartilaginous cap, and it is coming from distal femur. It is coming from metaphysis of distal femur. So we are talking about what? Come on, speak up. Osteochondroma. Now, what you are looking at right now, can anybody tell me what you are looking at right now? Growth plate is visible. This is one of the most important thing that we are talking about right now. 5 साल से लगातार हर साल ही आ रहा है. Even a little bit discussed in radiology, I'm aware and I'm sure. So, growth plate is visible, मेरे भाई. GCT cannot have a visible growth plate. ठीक है, GCT just cannot have a visible growth plate. Number 1. Number 2, GCT will be epiphysio metaphysial. This is primarily purely metaphysial. So we are talking about what? Come on. I can't see the answers in the chat box. We are talking about what? No, it's not SBC. It's not GCT. No, it's not GCT. It is ABC. Dr. Swankar is the first person to write in the chat box, followed by Archana and Soumya. So we are talking about aneurysmal bone cyst. This is not a typical soap bubble. The growth plate absence or presence is more important. ठीक है मेरे भाई, ABC. Onion skin, onion peel appearance can be seen in osteomyelitis, can be seen in Ewing's sarcoma, can be seen in Gary's osteomyelitis, can be seen anywhere. But the classical one will always remain Ewing's sarcoma. And remember, in Ewing's sarcoma, translocation 1122 is classical. Remember, CD99 marker MIC2 CD57 is classical. Okay? So always remember this. This is very, very important. You are looking at a fracture of tuberosity at the base of the fifth metatarsal, and a tendon is inserted over there called peroneus brevis. When I appeared for my PG entrance exam, they had asked us a question that named the tendon. Options were longus, brevis, tertius. Answer is peroneus brevis. Now it is due to the pull of peroneus brevis that you are looking at an avulsion fracture of the tuberosity at the base of the fifth metatarsal. So that is called as pseudo-Jones fracture. All right. So this is called as, I repeat everyone, this is called as pseudo-Jones fracture. Colles fracture के बिना entrance exam मैंने तो आज तक देखा नहीं. I've never seen any entrance exam without an MCQ directly or indirectly related to Colles fracture. So first of all, extra-articular, intra-articular, extra-articular. Distal end of radius, yes, with anterior displacement, posterior displacement, posterior displacement. Most common complication, finger stiffness. Always remember this. Always remember this. Most common complication, finger stiffness. All right. Most common complication, finger stiffness. Second most common complication, malunion. Second most common complication, malunion, dinner fork deformity. Second most common complication, malunion, dinner fork deformity. Always remember this. Okay? Chaliye. Now, the fracture that you are looking at right now is again something without which I don't think the entrance exam is possible. Most of you guessed it right. Supracondylar fracture humerus. Most common displacement, posteromedial. Most common fracture due to fall on outstretched hand in young children. Most common fracture in children around elbow. Most common complication, everyone, malunion, which will give rise to which deformity? Cubitus varus gunstock deformity. Most common nerve injury, beautiful MCQ comes very often, anterior introitious nerve, motor branch of median nerve. Most common vascular injury, brachial artery. Always remember. Okay, after this, these two very important commonly asked fractures, let's talk about this fracture. Can you identify which fracture is this? Can you identify which fracture is this? Okay, so let me straight away come to the point. This is a clear-cut Colles fracture. All right, so this is a clear-cut Colles fracture. It is not Barton, mere bhai. It is not Barton. Many people they message me, sir, Barton laga rahe. It is not Barton. If you will see, then you will see that the distal radial articular surface is maintained. The distal radial articular surface is maintained. So it is an extra-articular fracture. So your job is to identify extra-articular or intra-articular. In the lateral view onto the right-hand side of your screen, you can see the continuity of the distal radial articular surface. So that makes it extra-articular. So this is Colles fracture. So identifying is very important. This is classical sun ray or sunburst appearance, which is not due to calcification of blood vessel, which is due to periosteal reaction along the Sharpie's fibers. And I'm sure you people are aware more than me that it is seen in osteosarcoma. Now, what you are looking at right now is a Codman's triangle. The tip of that arrow is showing you something called as Codman's triangle. So the previous one, sundry appearance, is due to periosteal reaction along Sharpie's fiber. This Codman's triangle is due to periosteal elevation. So the lifting of the periosteum is reason behind Codman's triangle. I wanted to do a quick recap with all of you because it is impossible to have an entrance exam without a question on either of them. So on the left hand side, what you are looking at is GCT. On the right hand side, what you are looking at is ABC. All right. So on the left hand side is GCT. On the right hand side is ABC. Please keep that in mind. This is very, very important because this is something without which you cannot expect your exam. So guys, the purpose was to revise almost 25-30 images with all of you towards the last lap of preparation. The idea is not to confuse you, not to belittle you, not to make you feel belittled. Please make sure that at this moment, whatever you have read, whatever you have remembered, whatever you have retained till now, that will be helpful. Doing anything new right now won't make any sense. Listening to what others have done till now won't make any sense. Because no magic can happen in last 2 to 3 days. The only magic that can happen is that you believe that you have magic in you. Because we all are magicians in our own way. So please remember that at this moment, do not underestimate yourself. You are your topmost priority. Entrance exam can be cracked not only with the help of an IQ, but rather at this moment what you need is an EQ, emotional quotient. So you have to be emotionally strong, stable, no lability, no uncertainty. The universe, there's a very old saying, the universe does not respond to an uncertain mind. Take your sleep properly. I know it is easier said than done. There must be 1000 anxieties going on in your head right now. What if is the biggest thought that is coming into your mind every second minute. But believe me, you have a lot to gain and a less to lose. पाने के लिए बहुत कुछ है, खोने के लिए इतना कुछ नहीं है. बहुत बड़ी चीज ये नहीं है, हाँ बना देंगे तो बन जाएगी. So you have to have the faith in you, in your preparation that you have done till now. All you need to do is you need to execute it well right now. Because if it is not executed well, I give you my word that whatever you have done till now will be useless. So any stupidity or any seeking of external validation right now is not going to help you. It is not going to help you. So have faith in yourself. Things will be fine. I give you my word. I give you my promise. Please make sure that you consider yourself as your topmost priority. It will be very difficult for you for next 3 nights to sleep, because when you will go off to sleep, you will have 5,000 doubts coming into your mind. And what I want you to do at that moment is start thinking about the 4th of August. That is something with which you have to sleep. What is your plan on 4th of August morning or 3rd of August late night? Keep thinking about that. Whether that can be a party with your friends, that can be meeting your family, that can be talking about your friends, special friends, anything. It can be anything, a solo trip, anything. Because if you will sleep peacefully, then you will sleep in time, you will get up in time, and next day you can give your 100%. Because any wastage of time while sleeping, if your anxieties overpower you, then you will wake up later next morning, and that will add more regret that I wasted my time, and regretting on that regret will add up more time. Your biggest competition, I can tell you just one thing, is you right now. Your competition is not somebody sitting on the chat box on YouTube or somebody who you know or anything. कोई competition नहीं है. आपका सिर्फ एक ही competition है और वो आप खुद हैं इस वक्त. I'll say something which I strongly believe in Hindi. खुद से जीतने की जिद है. मुझे खुद को ही हराना है. मैं भीड़ नहीं हूँ इस पूरी दुनिया की, क्योंकि मेरे अंदर ही एक जमाना है. Yes, you can do it, and I know you can do it, and you will make everybody proud of you.
Very good afternoon, all my students. Audio video fine. Can we start with the session? Yes, beta. All my students, can we start with the session? Very good afternoon. So let's start with this ENT segment. In next half an hour, I will try my best to give you all the important. Very good afternoon, beta. All the students, thanks for the update. I will be giving you all the expected important topics which are must read topics, beta. Clear? So in next couple of days, not couple of days, you can say next couple of hours, let's revise these topics in a nice way. Is it clear? So what are the mandatory, which are the mandatory, like we are expecting 10 to 12 MCQs of ENT. Out of 10 to 12 MCQs, yes, but one golden statement, we have to think like a 10 standard student, and we have to use common sense to rule out the option. Is it clear? So in the last spell, just focus on this ruling out the option, which are mandatory topics. Epistaxis, MCQ have to be there. Angiofibroma, MCQ have to be there. Pure tone audiometry, MCQ have to be there. So these are the 3 areas out of 10 MCQs. Out of 10 MCQs, I am giving you 3 must read topics, or you can say these are mandatory topics. Clear? Is it clear? So before starting the session, I will try my best to complete these three MCQs, these three topics with epistaxis, angiofibroma, Peyroton audiometry. Now you will say, sir, how you know epistaxis is going to be there? Last year polyp MCQ, this year epistaxis, alternate always. Epistaxis, what MCQ I'm expecting this year, they will either ask you telespa, transendoscopic ligation of sphenopalatine artery, or they will ask you Trotter's method. What is Trotter's method? Pinch the nose, spit out the blood. Pinch the nose, spit out the blood. That is your Trotter's method. Is it clear? Everyone, kindly update in the chat box. Reply beta. Let's make this session very interactive. So telespa or Trotter's method. Trotter's tried nasopharyngeal carcinoma. I can add one MCQ in nasopharyngeal carcinoma on your NEET examination. That is here. Which MCQ? There will be a long history of serous otitis media. There will be long history of serous otitis media, and they will be asking you 5 lines on serous otitis media, 3 options on maryngotomy grommet, but last line in the MCQ will be a lymph node in the posterior triangle. Lymph node in the posterior triangle, that is going in the favor of diagnosis nasopharyngeal carcinoma, and we will go for radiotherapy. Clear? So this is a new MCQ which was there in your last session. So I'm expecting one MCQ on nasopharyngeal carcinoma. So epistaxis, telespa, Trotter's. Angiofibroma, either Holman-Miller sign, posterior wall of maxillary sinus bending down, or they will ask you which investigation not to be done, that is biopsy not to be done. Is it clear? Angiofibroma. Pure tone audiometry. Everybody, every student revise with me which are the important MCQs related with pure tone audiometry. We have 10 important graphs, beta. 10 graphs which should be on your tips. This is my 25 decibel normal. 25 decibel normal. Is it clear? If both the graph, air conduction, bone conduction are within, that is attempted normal. If airborne gap is there, that is conductive. If there is no airborne gap in the range of moderate deafness, that is 60 decibel. So, bacha log, what you will attempt? You will attempt sensory deafness. And if it is 80 decibel, it will be neural deafness. Is it clear? And if they repeat the same MCQ of last INICET, both the graph beyond 25 and there is a big gap, will go for airborne gap with sensory deafness, that is mixed deafness. Is it clear? I hope everybody's, the way the chat box is moving, it means you have revised the notes properly. Revise with me. Both the graph within 25, normal. Airborne gap, conductive. Both are beyond sensory or neural. Both are beyond with airborne gap is equal to mixed deafness. U-shape audiogram, congenital deafness. High probability they will ask you one out of these two. Either rising curve, high probability they will be asking you on rising curve, that is your Meniere's disease. That is Meniere's disease, low frequency hearing loss, low frequency hearing loss. And if they ask you downsloping graph, that is my downsloping graph, presbycusis, that is high frequency hearing loss. Is it clear? High probability they will be asking you MCQ on presbycusis, because last week in your FMGE examination, they have asked you high frequency hearing loss, presbycusis, old age. Is it clear? 2000 Hertz Carhart notch, 4000 Hertz Boiler's notch, MCQ expected. So these are the must read topics for upcoming examination. The 3 topics mandatory. So out of 10 MCQs, 3 MCQs, epistaxis, angiofibroma, and pure tone audiometry. Now let's brush up the remaining topics. Which are the must read topics? They can ask you fracture, vertical fracture, horizontal fracture. Always remember, chevalet is vertical, trauma is coming from below. And if the examiner repeat the same MCQ of last session, it will be Jarjaway fracture, that is horizontal fracture. Is it clear? I hope everybody is comfortable. Leaf foot fracture, low maxillary is leaf foot 1, on which they can ask you bleeding spot over the palate. Leaf foot 2 is known as pyramidal fracture, and leaf foot 3 is known as craniofacial disjunction, disjunction. Is it clear? The MCQ which I am expecting this year, they will be asking you CSF rhinorrhea. CSF rhinorrhea is commonly seen in Which of these two? LeFo 2 and 3. It is more commonly seen in 3 than 2. Always remember, it is more commonly seen in 3 more than 2. Is it clear? Done. Now CSF rhinorrhea, again a emergency topic, mandatory topic. Which two MCQs? What is the treatment of choice? Is wait and watch with IV antibiotics. No surgical intervention immediately. This option, immediately surgical intervention, is a false statement. Examiner can ask you CSF rhinorrhea. Everyone, CSF rhinorrhea is commonly seen at which point? That is cribriform plate. It is cribriform plate. And what is the site? Investigation of choice for site of leakage. If examiner asks you site, that is HRCT. That is HRCT. I hope you are getting the concepts better. That is HRCT. Is it clear? Crystal clear concept. Clear? So wait and watch, investigation of choice, site. If they ask you site, it is HRCT. If they ask you overall investigation, that is electrophoresis, beta 2 transferrin. We will go for beta 2 transferrin. Done? Clear? After learning these basic points, this is your Gurin sign, bleeding spot over the palate. Gurin sign, bleeding spot over the mastoid. Battle sign, everyone stop writing, close your eyes. These are signs of trauma, not infection. Examiner will give you a long history of infection, and they will ask you which sign will not be visible. So which sign will not be visible? Gurin or battle sign will not be visible. Expect one MCQ on abscess. If there is a abscess on lateral wall, it is most common abscess of head and neck. That is known as parapharyngeal abscess. And if there is a abscess on the posterior pharyngeal wall, that is your retropharyngeal abscess. Is it clear? MCQ expected. What is the treatment for parapharyngeal abscess? The treatment is IND along anterior surface of sternocleidomastoid. In retro, it is posterior surface of sternocleidomastoid. Is it clear? Crystal clear. Parapharyngeal abscess extend up to hyoid bone. Retropharyngeal abscess extend up to bifurcation of trachea. Is it clear? One more important concept, how you differentiate parapharyngeal abscess from peritonsillar. Any student who can write in the chat box? But this is a very favorite question of your NEET examiner. How to differentiate parapharyngeal abscess from peritonsillar abscess. Always remember neck swelling. In the MCQ, if they mention the word neck swelling, I will be going for parapharyngeal abscess. If there is no external swelling, that is going in the favor of parapharyngeal abscess or peritonsillar. Neck swelling, parapharyngeal. No neck swelling, peritonsillar. Is it clear? Done. Recurrent abscesses, if they show you this type of mass, it is angiofibroma. Most common site, sphenopalatine foramen. No biopsy, no debulking. Which artery we embolize in angiofibroma is your internal maxillary artery. If they show you a unilateral cervical lymph node, that is neck lymph node, nasopharyngeal carcinoma. In the last session, they have asked you one MCQ, 50-year-old patient from Northeast complaining of hearing loss, some ear symptoms, tympanic membrane bulging. They have shown you tympanogram, that is flat tympanogram, but in the last line they mention there is a lymph node in the posterior triangle of the neck. So if there is a lymph node, we will go for NPC. What is the treatment? Radio plus chemo. Is it clear? In the larynx, expect one MCQ from your congenital dyspnea. Last year, they asked you which classification is used for congenital stenosis. This year, they can either ask you webs. What is the most common site for congenital webs? Anterior commissure. And which classification is used? Cohen's classification. Is it clear, beta? Either they will repeat the same MCQ, that is your congenital stenosis, Which classification? That is Cotton-Mayer classification. Congenital webs, they will ask you Cohen's classification, or they can ask you, make an MCQ on laryngomalacia. What is laryngomalacia? Most common congenital anomaly, that is your omega shaped epiglottis. And what is the treatment? That is wait and watch. Worth remembering point for upcoming NEET examination: laryngomalacia, cry is normal. There is no change in the voice. Cry will be normal. Is it clear? Crystal clear? So expect one MCQ on Kanavada. Motive behind this session to give you must read topics, beta. In the last spell, we want to give you momentum. Take my words, beta. Even if you have missed few topics, few segments, no worries. At this point of time, no regret, no guilt should be there. Go with the confidence. Whatever we know, just attempt confidently. And if any new MCQ come, try your best to rule out the option, beta. I will suggest you on this platform, just be aggressive, beta. Play the game like Virat Kohli. Don't leave a single MCQ, but apply logic. Guesswork, tukka should be educated tukka. Is it clear? So apply the logic, rule out the choices. Is it clear? Expect one MCQ on this. I can say confidently in the next week this MCQ is going to be there, which now crosses from piriform fossa internal laryngeal nerve. This MCQ is in trending, so you can write this MCQ expected for you in upcoming NEET examination 2025. What is the MCQ? Which now is crossing from the smuggler's fossa internal branch of superior laryngeal nerve. 50-year-old patient with a history of fish intake, complaining of loss of sensation in the upper part of, ये आना ही आना बेटा, ये क्वेश्चन आएगा, जब आएगा तो आप मुझे याद रखना. Clear? Internal branch of superior laryngeal nerve, MCQ expected. Then they will ask you either of these two. They will either show you thumb sign, तो बेटा इसको टिक कर देना, epiglottitis. What is not to be done? No painful stimulus to be given in patient of epiglottitis. And if they show you this stipple sign, go for croup. Which organism for croup? तो बेटा वो 3 आपको बैक्टीरिया देंगे, उनको क्रॉस कर देना, रूल आउट कर देना. Any virus given in the option, go with that option, because croup is viral, epiglottitis is bacterial. I hope you will not miss this MCQ. And in this spell, in the next few days, just flip up the pages of DVT in a very fast mode. If you revise these things in a very fast mode at this point, it will give you momentum and understandable. Clear? Coming back, this is papillomatosis. Again, I can write 2025 NEET MCQ. Why? This question always repeated in alternate year. Papillomatosis, 4 points. Most common site for papillomatosis is anterior commissure. What is contraindicated in this patient? Always remember, we never intubate this patient. If the patient have difficulty in breathing, I will go for tracheostomy, not intubation. Which drug is approved for this patient? Cidofovir. Expected MCQ. Very good, very nice. One student, human papillomavirus 6 and 11. Larynx 6 and 11. Pharynx is 16 number. Is it clear? One MCQ was there in the last week FMGE exam. Which is the most common site associated with human papillomavirus? Always remember, larynx carcinoma is more associated with alcohol, smoking more than alcohol. Human papillomavirus commonly present in, बेटा जस्ट रिमेंबर दिस पॉइंट, ये वायरस कहाँ पे रहता है? ये टॉन्सिल फोसा के अंदर, टॉन्सिल क्रिप्ट्स, देयर आर क्रिप्ट्स, CRYPT क्रिप्ट्स. सो मोस्ट कॉमन tumor associated with human papillomavirus is here oropharynx carcinoma. This is expected MCQ. Is it clear? One more MCQ which was there in the last FMG examination. If you remember na, classroom, we have drawn a line diagram, nasolacrimal duct open in the inferior meatus, and this is here superior meatus, sphenoid sinus open, here posterior ethmoid open, opening of the ostium. I taught you uncinate bone. Where is uncinate bone attached? I taught you lower attachment is with inferior turbinate and upper attachment will be going somewhere to the middle turbinate. Beta, have this image print on your mind. What is uncinate bone? Uncinate bone is a bony partition which is inferiorly attached with inferior turbinate, and superiorly attached with middle turbinate. याद रखना इस बात को. Clear? No, beta, it is not. The papillomatosis is not only glottic, it can occur anywhere. Most common site is anterior commissure. Always remember, uncinate bone inferiorly attached with inferior turbinate. Inferiorly attached with inferior turbinate, superiorly attached with middle turbinate. Superiorly attached with middle turbinate. Is it clear? Crystal clear. Then they will ask you something on CA larynx. Like last NEET, they have asked you which chemical is used. Which chemical is used to differentiate benign from malignancy, that is supravital stain. This year, they can ask you the management part. Carcinoma in C2. Always remember, it is your CO2 laser. T1, T2, we always go for radiotherapy as a treatment. Why? Because quality of life complications are minimum. T3, T4, it is total laryngectomy followed by radio and chemo. If patient deny, I can go for concurrent chemo radiation. Now I want to add one point here. As for treatment part is concerned, they can ask you which investigation is mandatory before horizontal partial laryngectomy. So just remember, horizontal partial laryngectomy, pulmonary function test, PFT should be normal. Pulmonary function test should be normal. Sorry. Clear? They can ask you MCQ on tracheo-esophageal prosthesis. So we have FMGE voice button. This is Blom Singer. This is your Provox. So what the concept you should learn, if examiner asks you after total laryngectomy, on the anterior wall, we put tracheostomy tube. On the posterior wall, we put a prosthesis. What is the name of this prosthesis? Tracheo-esophageal prosthesis. On the anterior wall, it is here tracheostomy tube, permanent tracheostomy tube is used. Is it clear? And tracheoesophageal prosthesis is used on the posterior wall. There is one expected MCQ. Patient is not able to raise the pitch. If patient is not able to raise the pitch, the bowing of the vocal cord, cricothyroid muscle, that is superior laryngeal nerve, external branch. So expect one MCQ on cricothyroid muscle. Pitch of the patient not increase. Clear? So MCQ on thyroplasty. Type 1 medialization, treatment for bilateral superior laryngeal nerve palsy. And lateralization is the treatment for bilateral recurrent nerve palsy. In any head and neck surgery, if superior laryngeal nerve is gone, it is aspiration with aphonia, complete loss of voice. Aspiration with aphonia, and recurrent laryngeal nerve, there is dyspnea. Always remember. Clear? So these are the expected MCQ on thyroplasty. Type 4 is indicated for androphonia. It is indicated for androphonia. What I'm doing with the help of this file, PDF file, I'm trying to revise with you last 5 to 6 years PYQ, from where there is a probability. Last NEET, trachea deviated to one side. Which procedure will be difficult? Obviously, tracheostomy will be difficult. Last week, there was one MCQ. Patient, we were intubating the patient, and the intubation was very difficult. So what is the next step? Next step, either we can go for tracheostomy or we can rupture cricothyroid membrane, cricothyrotomy. So just remember, if you are finding difficulty in putting the endotracheal tube, next step will be either cricothyrotomy or tracheostomy. Tracheostomy, dead space is reduced by 30 to 50% expected MCQ. High level tracheostomy is for malignancy. High level tracheostomy is for malignancy, and low level tracheostomy is for infection like diphtheria. So this point should be on your tips. High level is for malignancy, low level is for diphtheria. If you see one ring on the AP view, it is a circle AP view, it is in the esophagus. If you see double ring, it is your button battery, button battery. Is it clear? If you see a ring on the AP view, that is your esophagus, and if you see a line, that is your respiratory tract. Clear? Trachea. Done. One MCQ I'm expecting in this segment: auditory snap or palpatory third. These words, palpatory third, auditory snap, is related with foreign body in trachea. And if there is a foreign body in supraglottis, we will be having inspiratory dyspnea. If there is something in the lower respiratory tract, it is expiratory dyspnea. Double ring sign expected. I am expecting one MCQ on this topic. Can you tell me, beta, this is a pinna of a diabetic patient. Any diabetic patient in my OPD, if he is coming from nose, expected MCQ for upcoming NEET: mucormycosis. Expected. I can write here 2025. Either they will ask you mucormycosis or they will ask you malignant otitis externa. So in the OPD, if there is a MCQ, a diabetic patient from nose, mucormycosis, ear, malignant otitis externa, and MCQ from oral cavity, it is Ludwig abscess. Is it clear? Malignant otitis externa, which lab investigation is used for prognosis? ESA. Which bacteria? Pseudomonas. And what is the drug of choice? Third generation cephalosporin. Every student, listen carefully. Malignant otitis externa, they will not ask you which bacteria. They will ask you they will not say bacteria of malignant otitis externa. They will use the word necrotizing otitis externa, one and the same. So malignant, also known as necrotizing otitis externa. Is it clear? They will show you air fluid level. These are blebs, beta. Blebs. It is not red tympanic membrane. There is no cartwheel appearance, no redness. Patient will having no fever. I will be going for serous otitis media. Serous otitis media. What is the treatment? Grommet. Myringotomy with grommet. Where? Anterior-inferior. We go for anterior-inferior segment. Is it clear, beta? With adenoidectomy. If it is ASOM, I will go for myringotomy in posterior-inferior. And two important MCQs of ASOM: cartwheel appearance. One is cartwheel appearance. One is lighthouse sign. Lighthouse sign. Cartwheel appearance, it is seen in pre-suppuration. Pre-suppuration. Lighthouse sign seen in stage of suppuration. Suppuration. Clear? So these points should be on your tips. This is your cartwheel appearance, ASOM. Done. They can even ask you, grommet is inserted. Can you use grommet in meniers? Yes, we use in meniers to inject gentamicin. Is it clear? Then type of mastoid surgery: canal wall up, canal wall down. Canal wall down is the most common surgery we are doing. Modified radical is the most common surgery in CSM. But this is a favorite MCQ of your NEET examiner. What is the difference in radical, modified radical? Modified radical, we preserve normal. Whatever is normal, we preserve it. Radical, we remove everything. In modified radical, if ET tube is not blocked, radical ET tube is blocked, is commonly used in malignancy. You should be confident of cortical mastoidectomy, other name Schwartz operation, and cat surgery, combined approach tympanoplasty, is a type of canal wall up. Canal wall up. Is it clear? Traumatic perforation. Always remember the golden rule. Traumatic perforation, we prefer to wait and watch. It heal of its own. Expect one MCQ on glomus tumor pulsatile. In the MCQ, if they mention the word pulsatile, it is glomus tumor pulsatile symptom. Last year, they ask you flap sign, loss of bony partition between carotid and jugular. This year, I'm expecting they can ask you rising sun sign or brown sign. What is rising? The tumor increasing day by day. And brown sign, blanching of the tumor on increasing the pressure. Is it clear? Audiograms, we have already learned. This is your severe sensorineural deafness, Carhart notch, autosclerosis, tympanogram. For the last 2 years, we are observing, they're asking tympanograms. This should be mastered. This is normal. If they show you this is known as B or flat. Always remember, beta, B is seen in perforated tympanic membrane. Flat is seen in fluid in the middle ear. Type C is ET tube dysfunction. High probability they will give you this graph. I can write here 2025 NEET MCQ. This is AS graph. It is seen in autosclerosis, autofibrosis, tympanosclerosis, tympanofibrosis. And this is hypermobile. This is AS, seen in ossicular damage. Ossicular damage. Is it clear, beta? So this should be on your tips. Maximum hearing loss at 4,000. Noise induced trauma. Last UPSC they have asked you this MCQ. That is here, which is the maximum limit in any factory, that is 85 decibel. Industry WHO guideline. 8 hours in a day, 5 days in a week. It should be on your tips. Is it clear? Which investigation? This is your rising curve. I am showing you electrocochleography. These 2 slides dedicated to Meniere's disease. What is Meniere's? Sensory deafness. What is the investigation of choice for sensory? Electrocochleography. What is a hallmark feature of Meniere's? Anybody who can write in the chat box. What is a hallmark feature of Meniere's? Is here fluctuating deafness. Beta. Every student close their eyes. In your MCQ, if the word pregnant female, if they mention the word pregnant female, go for autosclerosis. Fluctuating deafness, go for Meniere's. If they mention the word ice cone appearance, Antony classification, rollover phenomena, neural deafness. Which formula is, which hallmark feature for sensory? Recruitment phenomena. What is recruitment? Oversensitivity. Oversensitivity is known as recruitment phenomena. Is equal to clear? Am I understanding? Oversensitivity, short increment sensitivity index, recruitment, and patient is feeling very uncomfortable in noisy surrounding. These are hallmark feature for sensory deafness. Here I am giving you a nice concept, Tullio's phenomena. Differential diagnosis of Tullio is either sensory deafness or any fistula. Sensory deafness or any fistula. It is your sensory deafness. Is it clear? Crystal clear? If examiners show you ice cone appearance, this is going in the favor of acoustic neuromas. Which cranial nerve is first to be pressurized? Fifth nerve. Loss of corneal reflux is the earliest sign, is a PYQ. Is it clear? If facial nerve involved, sensory fibers involve early than motor. Sorry. In this context, they can ask you Hitzel-Berger sign. Loss of sensation in the posterior superior part of the canal. Clear? What is the investigation of choice? That is your BARA. High probability, they will ask you auditory pathway. ECOLI MA. Olivary complex. This is superior olivary complex responsible for stapedial reflux. Again, this is a very old PYQ. You should be confident that. Then they can ask you something on BPV. Here I will take 1 minute to explain. Either MCQ choice will be BPV or vestibular neuritis. Always remember, beta, the common in any student who can write in the chat box, what is common between these two, BPV and vestibular neuritis? In both the condition, there is no hearing loss. In the MCQ, they will mention 50-year-old female. When she wake up in the morning, she get vertigo in a position. The word position will be there. In a specific position, she is getting vertigo. Calcium carbonate body enter into posterior semicircular canal. Investigation of choice, Hallpike maneuver, and treatment of choice is apple. This is something dedicated to BPV. But if the examiner mentioned the word vomiting, examiner mentioned the word history of upper respiratory tract infection, one virus from laryngopharynx enter into vestibular nerve, no hearing loss, self-limiting. This is self-limiting. Is it clear? So what message I want to give you here? Upper respiratory infection, history of URTI with vomiting. If mentioned, it is high probability with vestibular neuritis. But vomiting can be even seen in BPV. It is very rare, but can be seen. It is documented. So never rule out the diagnosis of BPV if they have mentioned the word episode of vomiting or nausea. But if the word position is there, that is definitely going in the favor of BPV. This was somewhere last INICET MCQ. Expect one MCQ on hearing aid, conductive deafness, hearing aid, sensory deafness, cochlear implant, and neural deafness, brainstem implant. Is it clear? This is your BTE, behind the ear. If I keep a hearing aid on mastoid, we call it as BAHA, bone anchored hearing aid. If the examiner give you a MCQ where canal atresia is mentioned, canal atresia, go for BAHA, bone anchored hearing aid. This image of your implant, cochlear implant, should be on your tips. They should not give unethical MCQs. Like last NEET, they ask you what is this small electrode. The long electrode is known as electrode array, and the small short electrode, which they have asked you in NEET 2024, that was reference electrode or ground electrode. All the parts of cochlear implant should be on your tips. Cochlear implant is kept in scala tympani, kept via round window, lowest age 1 year. These are the must-read topic for cochlear implant. What is this diagnosis? There is a fistula in the roof of semicircular canal, superior semicircular canal dehiscence syndrome. If you have 1 second to revise this topic, just remember it is conductive deafness with CNS symptoms, Tullio's phenomena positive. Conductive deafness. Revise me. This is conductive, not sensory neural. Conductive, not sensory neural. This question from last NEET can be repeated, where they will show you a perforation, septal perforation. It is SMR, submucous dissection. Is it clear? Which surgery was done in the patient? It is SMR. I am confident all the important air cell on your tips. Most anterior, better everyone close your eyes, revise. Most anterior, agar nasi. Most posterior, anodi. Largest, bulla. Lowermost, Haller cell. Hypertrophic rhinitis, inferior turbinate. If they show you double density, that is allergic fungal rhinosinusitis. Peanut butter like mucus and double density. I'm expecting one MCQ on rhinophyma or rhinoscleroma. Rhinoscleroma, which word? Woody nose will be there. If woody nose with foul smelling crust, it is rhinoscleroma. Woody nose with atrophic merciful anosmia, atrophic rhinitis, roomy cavity. Mulberry-like mucosa is hypertrophic rhinitis. Mulberry-like polyp, rhinospodiosis. They will give you a typical history of taking bath in the ponds. This is something to do with rhinospodiosis. Organs classification: tumor below the line, good prognosis; above the line, poor prognosis. Related with maxillary sinus. One is Ladman classification. Is it clear, beta? So these are important expected MCQs. Even if you couldn't study in the last few months or last few days, no worries, beta. What I will suggest you on this platform, let's do in next couple of days PYQ only. Just do PYQ. If you have done all the last 5 years PYQ, let's add DVT book with that segment. Is it clear? Revise your PYQ thoroughly, beta. Last 3 years, 4 years PYQ should be on your tips. Even if you couldn't study in the last few days, no worries, beta. Let's play this game with confidence. Art of ruling out. Go with a peace of mind. Have a sound sleep. All these things are very difficult to say, but very easy to say, difficult to do. But let's try, beta, and give this examination with full confidence. Make a promise to me in the chat box. We will give this exam with full confidence, irrespective of our preparation. Am I understandable? Is it clear? Don't do any unwanted difficult MCQs in next 4-5 days. Never. Just focus on doable MCQs, beta. Don't do anything which bring your confidence down. Is it clear? Just concentrate, revise. Very best of luck, beta. We all are with you. I promise you, each and every word we have discussed on this platform will help you in the examination hall. Best wishes, best of luck. We stop here.
कर दो सर, आप स्टार्ट कर दो.
Okay. Just wait a minute. Yeah. Good evening, students. I hope I'm audible and visible. Okay. Let us start. First, tell me what is the diagnosis here? Yes. This is the first question of the day. What is the diagnosis? You can notice a hypertranslucent air-filled area. Along with that, there is a compressed lung margin. And you see absent breath sounds with contralateral shift. Come on, answer. What is this? The correct answer is, it is a left-sided pneumothorax. Starting with the first previous year topic, let it be any year, always examiner's favorite topic is pneumothorax. Never forget how to clinically, radiologically identify pneumothorax. The clinical entities algorithm. Now, pulling lesions, pushing lesions, no push, no pull. What are the pulling lesions that you know? One is collapse and other is fibrosis. And other is pushing lesions. One is pleural effusion, other is pneumothorax. No push or no pull. It is consolidation. So we are doing the respiratory medicine and ABG rapid revision. I'll ask you questions, tell me the answer. So collapse is completely airless lung field. So if you percuss, what is the note? It has to be a dull note. Whereas, because there is no air at all, breath sounds will be absent. And on the chest X-ray, what is the color of abnormality? What is the color of abnormality? I want the answer from everybody. How is the color? Very simple. It is white and there is no air. It will be very white. This is called as white homogeneous abnormality. White homogeneous abnormality. Fibrosis, impaired note. Because there is less air, breath sounds will be diminished. And this is also white because there is still some amount of air. It will appear less white. This is called as heterogeneous. Then consolidation due to secretions and infection, dull note. And the classical auscultation finding is bronchial breath sound. Now my question to you. What is the characteristic radiological finding on consolidation? Your answer should be air bronchogram. Pleural effusion because it is fluid, stony, dull. And on auscultation, depending upon the amount of fluid, breath sounds will be diminished to absent. And what will be the chest X-ray finding? It is white with meniscoid fluid level. A pneumothorax, examiner's favorite question. Percussion, hyperresonant or tympanic note. Auscultation, breath sounds will be absent or diminished. And on the chest X-ray, you can notice hypertranslucent area with compressed lung margin. So this nobody should forget in the exam because this is examiner's favorite topic. You should know how do you clinically and radiologically differentiate collapse, fibrosis, consolidation, pleural effusion, pneumothorax. Okay, then next topic of interest is spirometry. Now in spirometry, the first parameter that you have to see is ratio. Now my question to you, if ratio is low, What should be your direct answer? Low ratio, low ratio. What should be the answer? Low ratio, what should be the answer? So low ratio in the sense your answer should be, it is nothing but obstructive. If the ratio is low, it should be obstructive. If the ratio is normal or increased, it can be either normal lung or it can be a restrictive disorder. It can be a restrictive disorder. Now come on students, if it is obstructive, tell me what are you dealing with? If it is obstruction, what are you dealing with? You are dealing with two diseases. One is asthma and other is COPD. And how do you differentiate? By bronchodilator reversibility. So if it is bronchodilator reversible, your answer should be asthma. If it is persistent obstruction, your answer should be COPD. On the other hand, if it is restrictive, is that intrinsic restrictive lung disease or extrinsic restrictive lung disease? Intrinsic means directly your lung is shrinking. ILD, occupational lung diseases. Whereas extrinsic, we have kyphoscoliosis and various neuromuscular disorders. Very, very important topic. Spirometry. See the ratio. If ratio is low, obstructive, then bronchodilator reversibility. If it is reversible, asthma. If it is not reversible, it is COPD. Then if the ratio is normal or increased, see FEC. If FEC is less, then it is restrictive. Now coming to types of respiratory failure. How many types? 4 types. Now tell me, what is type 1 respiratory failure called as? So what is the name of type 1 respiratory failure? This is hypoxemic respiratory failure. And what is the name of type 2 respiratory failure? It is hypercapnic respiratory failure. Examiner's favorite is always this hypercapnic respiratory failure. So type 1, these diseases: severe pneumonia, ARDS, fibrosis, pulmonary embolism. And those who have attended my class, what will be the mnemonic that I have told you for type 2 respiratory failure? It is COPD. C stands for central, O stands for obstruction, P stands for peripheral, D stands for diaphragm. Central means something happening at the level of brain, brainstem injury. O for obstruction in the airway, severe COPD. Peripheral, your respiratory muscles, neuromuscular disorders. And finally, diaphragmatic injury. Type 3, why it happens? Perioperative respiratory failure due to lung atelectasis associated with general anesthesia. So that is type 3 respiratory failure. Then type 4, it is due to hypoperfusion, as in shock. So whenever somebody is having shock, the amount of blood reaching your muscles reduces and muscles will not work properly. That results in a respiratory failure. Then if they ask you general anesthesia related respiratory failure, what your answer should be? Your answer should be type 3. Next topic is ARDS. Here they are going to ask you the diagnostic criteria. So very important, patient will have acute shortness of breath within 1 week. Chest X-ray will show bilateral diffuse pulmonary infiltrates. And what is the type of edema? It is non-cardiogenic pulmonary edema. And important oxygenation criteria is PaO2 by FiO2 less than 300 mmHg. These criteria you should know by heart. And if they ask you what is the most important in management of ARDS, your single best answer should be low tidal volume mechanical ventilation. How much low? The answer is 4 to 8 ml per kg. And the magical figure is 6 ml per kg body weight. Then you should give sufficient PEEP to improve oxygenation. And what are the other options available? We have ECMO, and you are asking the patient to lie in prone position. When you are not interested from front, you see backward. What is this position called as? Prone ventilation. So prone ventilation. Two things you have to keep in your mind in ARDS. Most important is low tidal volume mechanical ventilation, and most advanced treatment available is ECMO. Then pulmonary embolism. Usually they'll ask you what is investigation of choice. They'll give you a clinical scenario. Here for pulmonary embolism, it is in block letters CT pulmonary angiography. This has to be the diagnostic test of choice. Then depending upon the clinical scenario, is it massive, submassive or minimal? So what is the disease defining feature of massive? When do you call it as massive? Patient is presenting in shock. If patient is presenting in shock, this patient will not survive without reperfusion. And that reperfusion is thrombolysis, preferred in majority. So stabilize, give anticoagulation, definitive treatment will be thrombolysis. Now if it is submassive, here BP is normal, not that bad, but this patient you have to start an anticoagulation and closely monitor. Only if he is not improving with anticoagulation, as a last resort, go for thrombolysis. Here thrombolysis mandatory in majority. Here thrombolysis only in selective cases. Then minimal. Normal BP, normal RV function. Because the thrombus is small, just you can go with anticoagulation. So the golden points here is, when you suspect it to be pulmonary embolism, in majority the diagnosis or next step, usually examiner is expecting CTPA. And in treatment, if it is shock related, never forget about thrombolysis. Then coming to pneumonia, community acquired pneumonia happens outside hospital, whereas the one happening within hospital, the broad term nowadays, it is called as nosocomial pneumonia. Nosocomial pneumonia. If it happens outside ventilator, it is hospital acquired pneumonia. Within ventilator, it is ventilator associated pneumonia. Now what are the organisms? If they ask you most common typical pattern, your answer should be Streptococcus pneumoniae. Most common atypical, Mycoplasma. Got it? Typical is Streptococcus. Atypical is Mycoplasma. Can you name other atypical pneumonias? Because these atypical pneumonias are examiner's favorite. Legionella and viral pneumonias. Then hospital acquired, if they ask you single organism, staph. If they ask you group of organisms, it is gram negative bacilli. Ventilator associated early VAP, again it is Streptococcus. Late VAP and VAP overall, it is Pseudomonas. And this is the star of ventilator associated. So late VAP and VAP overall, your answer should be Pseudomonas. Late VAP and VAP overall, answer is Pseudomonas. Then try to identify this infection with a few clues. So there is a ship traveler with diarrhea and pneumonia. So whenever I say it is a ship traveler or people residing in hotel developing pneumonia with diarrhea, one possibility that you should have in your mind is water contamination. So which pneumonia is spread through contaminated water? Yes, it is Legionella. And what is the usual treatment of choice? It is azithromycin or fluoroquinolone. And if they ask you best for Legionella, it is usually respiratory fluoroquinolone. Azithromycin can be given as a common drug for all atypical pneumonias. Very good, students. Then fever, dry cough, and there is hemolytic anemia. This I always tell in my classes. If it is hemolytic anemia, what should be the suspicion, hemolytic anemia, what should be there in your mind? So it is mycoplasma. It is mycoplasma. And the usual treatment here will be azithromycin or fluoroquinolone. And usual treatment here will be azithromycin or fluoroquinolone. Then coming to, this is a truck driver and you are getting patient's respiratory sample, that is bronchoalveolar lavage is GMS positive. Truck driver, fever, GMS positive ball. What you should think of? It is pneumocystis. It is pneumocystis. And what is the treatment of choice against pneumocystis? It is cotrimoxazole. It is cotrimoxazole. Got it? Then, who is this patient? He is a chronic alcoholic and he is having purulent sputum, and the chest X-ray is showing this image. What is that image on a chest X-ray? You can see a cavity. So there is a cavity. There is air and there is fluid. This is called as lung abscess. It is called as lung abscess. So this is a primary lung abscess, and this is because background alcoholism, there should be aspiration, oral anaerobes, and treatment will be clindamycin. Whenever they give you lung abscess, always think like this. Is it primary or secondary? Primary is generally due to aspiration. Most common will be oral anaerobes. Secondary is due to pre-existing lung diseases. Organisms such as staph or pseudomonas. Organisms such as staph or pseudomonas. Next question is, previous year topic is approach to pleural effusion, whether it is transudate or exudate. So the criteria is based on Light's criteria. So usually in transudate, the protein ratio will be less than how much? 0.5. LDH ratio will be less than 0.6. Exudate, any one of the following, either protein ratio more than 0.5 or LDH ratio more than 0.6. If it is transudate, life is very easy because majority will be the systemic causes. Out of this, most common overall is your heart failure. Other systems, we have kidney nephrotic syndrome, liver, hepatic hydrothorax. Whereas exudate, the name itself, X, very difficult to explain. You have to go for so many investigations. Get the cytology done. Is it malignant? Gram stain. Is it infective? It is very difficult to deal, as if you are dealing with your X. TB markers. What are the TB markers? It is lymphocyte rich. ADA will be high. Interferon gamma will be high. That is 40. This is 140. Easy to remember. Low glucose pleural effusion. Empyema malignancy. Examiner's favorite. Never forget. Rheumatoid arthritis is low glucose pleural effusion. High amylase pleural effusion. Pancreatitis. Esophageal rupture. And variety of malignancies. And high lipid pleural effusion. Again, examiner's favorite. We have two. One is chylothorax and other is pseudochylothorax. Now tell me. Chylothorax is due to excess triglycerides. Why is pseudochylothorax? What is the lipid elevated in pseudochylothorax? Come on, answer. Lipid elevated in pseudochylothorax is cholesterol. The value is more than 200 mg%. TB, rheumatoid arthritis. So always, whenever they ask you regarding pleural effusion, never forget about this thing. Are you dealing with chylothorax or is it pseudochylothorax? If it is chylothorax, triglycerides will be high. If it is pseudochylothorax, cholesterol will be high. This has to be clear. Then asthma, stepwise management is important. And most of the questions these days they are asking you on this basic knowledge. What is that basic knowledge? There are two types of treatment for asthma. One is controller, which decreases inflammation, inhale corticosteroid. Whereas other is reliever. Now what is the big deal in this reliever? Because there is recent change. Right now, preferred reliever or rescue medication is not monotherapy. It is combination. What is that combination? Low dose inhaled corticosteroid with formoterol. Now, why are we using this combination instead of this monotherapy? Whenever you give monotherapy, it is just like using a single arrow to deal with multiple targets. You see, asthma is not just bronchospasm, it is inflammation related bronchospasm. If you just give SABA, it will only take care of bronchospasm. That inflammation can progress later midnight. Patient can land up in exacerbation. But if you give this combination is just like this blockbuster combination. Now you have multiple arrows targeting all aspects of the disease. What will ICS target? Inflammation. What will formoterol target? Bronchoconstriction. Everything is covered. So if they ask you initial treatment for asthma, patient is having wheezing episodes, you are considering it as asthma, how will you start treatment? Now it is combination. What is that combination? ICS formoterol. Never forget. The combination here that you should know is it is all ICS formoterol. Next question that I think is important is the biologic treatment. There are so many costly drugs. You should know anti-IgE, omalizumab, anti-IL-5, mepolizumab, reslizumab, anti-IL-4 receptor blocker, benralizumab, anti-IL-4 receptor blocker, dupilumab. But the star item is anti-TSLP, that is tezepelumab. Remember, tezepelumab. It is thymic stromal lymphopoietin blocker. See, they say that even somebody's body, your allergic response has to start. Who should be active? TSLP. Now, if you block the TSLP, that allergic response is not going to happen. So, this is something that is going to be asked in your future exams. Anti-TSLP approved for asthma is tezepelumab. This is very, very important. Then gold guidelines. Commonly they ask you, this patient is having this much FEV1 and he is having COPD. Is it stage 1, stage 2, stage 3, stage 4? Roughly translated as mild, moderate, severe, very severe. So the cutoff FEV1 is very important. Mild or stage 1 more than or equal to 80% of predicted. Then next stage 50 to 79, 30 to 49 and less than 30. And what are recent updates in gold COPD? The recent update is 2 new drugs have been approved after so many years. Ensifentrine, it is a dual PDE3 and PDE4 inhibitor. And this is used as a bronchodilator and it is going to tackle dyspnea. And in COPD, one reason for poor control is previous history of asthma. In subset of patients who are having combined asthma-like inflammation, now a biologic is approved in COPD, dupilumab. Now see here, for asthma there are so many biologics, but for COPD, dupilumab and recently mepolizumab is also approved. But it is still not in the gold guidelines. Next year it might be released. So it was recently published in an article. So dupi and mepolizumab both are being now used in COPD as biologics. Then aspergillus related lung disease. This is a common starter question for any examiner. So from this you need to have a question. This is just like that item you have in a buffet anywhere, let it be North India, let it be South India. That one item I feel is ABPA in a buffet of questions. ABPA is the star item, just like your gulab jamun. North India you eat, South India you eat, everywhere India means you eat this sweet ABPA. So this ABPA, don't forget, it is a complex hypersensitivity. It is combination of type 1, type 3, type 4 hypersensitivity. And very important, all these patients will be either having bronchial asthma or cystic fibrosis. This is a hypersensitivity reaction. You need to know that there will be skin test positivity, high IgE, aspergillus specific IgE, and the values of IgE 500 to 1000. And what is the CD chest finding? This you need to answer. It is central or proximal bronchiectasis. What is drug of choice for ABPA? Option A, antifungal. Option B, steroid. What should be your answer? Antifungal is not the single drug of choice because this is primarily an inflammation. So the drug of choice should be anti-inflammatory such as steroid. This is steroid responsive disease. Then invasive pulmonary aspergillosis. Now it is an infection. Whom it will happen? Will it happen in you? Will it happen in me? No. It happens in immunocompromised. And what is the type of invasion? It is transbronchial angioinvasion. See how bad it is. It is invading your bronchus. It is invading your blood vessel. So this patient will have shortness of breath, hemoptysis. And the important CT chest findings in the active phase, you see CT halo sign. And in the recovery phase, air crescent sign. Now this is an active fungal infection. Here you have to give good antifungal. That is nothing but voriconazole. Aspergilloma, it is just colonization in pre-existing cavity. And on the CT, you see a monad sign even on X-ray. And one fancy item or sign here is ball moving its position with patient's decubitus. Already disease in lung with cavity. Now a fungus is sitting. Make sure you remove that area. So many questions has been asked till now. Everything I tried to include in a single slide. Then ILD, UIP, NSIP, common question. UIP, like I told you, all bad things. Elderly, being elderly is bad. Being male, these days, every day one story. Girlfriend killed, wife killed, wife's boyfriend killed. So being male is very bad in this society. Chronic symptoms, smoker, fine crepitations, clubbing. Then all bad things. Very bad fibroblastic foci are seen. Then on the radiology, bad finding, again bad finding. Honeycombing, most bad finding. Then treatment and prognosis, everything is bad. Male bad, elderly bad, fibroblastic foci bad, honeycombing bad, bad prognosis. And what you have here, one perfenidone, one nintedanib tablet for namesake. Then lung transplant is the ultimate treatment. Then NSIP, something good here. Being middle age is good. Being female is very good. Subacute symptoms is good. Fine crepitations is good. Here, fibroblastic foci are not that great. It is only lymphocytic inflammation. And radiology, more of good findings called as ground glass. So it will be good prognosis. Yes. So the mnemonic that I tell in my class to my students, NSIP, girls, ground glass and good prognosis. Girls, ground glass and good prognosis. Then I will show you a few images. You only tell me which is UIP, NSIP. Very quickly. 60-year-old male referred for dyspnea and exertion. What is this finding? Can you see abnormal rounded areas at the periphery of the lung? This is called as honeycombing. So this is called as honeycombing. So when you notice honeycombing like this, what should be your answer? UIP, usual interstitial pneumonia. When you don't know the etiology, it is also called as IPF. Very simple. Next patient. It is more of ground glass opacities and subacute symptoms, restrictive pattern. This is nothing but NSIP, non-specific interstitial pneumonia. Both radiological, clinical, you should never forget when you are attempting. Then occupational lung diseases, very simple. Common is silicosis. The others are asbestosis, coal workers pneumoconiosis. Asbestosis, pleural plaques, pleural effusion, more of lower zone fibrosis. Malignancy, most common is not mesothelioma, lung cancer, that is adenocarcinoma. Most specific is nothing but mesothelioma. There can be round atelectasis. Silicosis, more in the upper zones, and classical pattern is progressive massive fibrosis. TB can happen as silica particles or damaging the alveolar macrophages. And here bilateral hilar lymph node enlargement with eggshell calcification can be seen. Lung cancer can also be seen. Co-workers pneumoconiosis, upper zone lesions, individual lesions initially. When they merge, it is called as complicated co-workers pneumoconiosis. And star item here is Kaplan's syndrome. What is Kaplan's syndrome? It is combination of rheumatoid arthritis with pneumoconiosis. Again, many questions have been asked from this. I tried to simplify in a single table. Now, what is this combination and what is the final diagnosis? First, tell me, what is this combination? Hilar lymphadenopathy, polyarthritis, erythema nodosum. The answer is Lofgren syndrome. Number 2, you can see areas of involvement on bridge of nose, areas beneath eyes and cheeks. So what is this referred to as? It is called as lupus perineum. It is called as lupus perineum. Then there is uveitis fever or Hereford syndrome. Combination of uveitis, parotiditis, then fever, facial nerve palsy. All this are nothing but various phenotypes of sarcoidosis. All these are nothing but various forms of sarcoidosis. If you see any of this, your diagnosis should be sarcoidosis. Now, what is this patient's story? Excess daytime sleepiness, obsessive snoring. You have done a sleep study, also called as polysomnography, which is a gold standard test for this condition. You see apnea, there is no airflow, but still respiratory effort is present. What is this combination called as? It is called as obstructive sleep apnea. Obstructive sleep apnea. Now, if there is a patient with obstructive sleep apnea and there is unexplained hypercapnia, so OSA with hypercapnia, what you should first rule out? Possibility of obesity hypoventilation syndrome. These days examiners are asking obesity hypoventilation syndrome. Then lung cancer, again a favorite topic. Adenocarcinoma is most common type worldwide. So it is peripherally located. If you see young male, female, non-smoker, asbestos, in all this situation it is adeno. Highest with clubbing adeno. Highest hematological paraneoplastic syndrome, Roche syndrome, adeno. Squamous, what is the mnemonic that I have told you in class? This will give you 1 mark, 1 question right in your exam. Everything with C. Central, cigarette smoking, cavity formation, and a paraneoplastic syndrome with respect to calcium. And here calcium excess is due to excess parathermone related peptide. It is a life-threatening metabolic abnormality. Small, central, strongest association with smoking, and this is the cancer with highest metastasis because of rapid recurrence. Very poor prognosis. So small cell, very poor prognosis. Many paraneoplastic syndromes. Hyponatremia, hypokalemia, hypocalcemia. So the reasons are enlisted. So hyponatremia due to syndrome of inappropriate ADH. Hypokalemia, excess ACTH. Hypocalcemia, excess calcitonin production. Now what is this combination? There is a tumor in the lung apex with the damage to first 2 ribs. First 2 ribs are gone. The nerve root C8, T1, T2 are involved, and there is ptosis associated with Horner syndrome. This combination is called as Pancoast syndrome. Combination is Pancoast syndrome, and the tumor is Pancoast tumor. Then coming to ABG, frequently asked question is metabolic acidosis, anion gap classification, high anion gap, acidosis, normal anion gap. High anion gap, usual addition of acid, such as ketoacidosis, lactic acidosis, renal failure, and various toxins, all alcohols that can result in acid formation. Then normal anion gap, I have discussed the mechanisms: pancreatic fistula, ureterosigmoidostomy, diarrhea, aldosterone deficiency, renal tubular acidosis, carbonic anhydrase inhibitor use. Then metabolic alkalosis, the types: saline responsive, unresponsive. Saline unresponsive usually associated with volume loss, vomiting, Rayleigh tube aspiration, diuretic use. Unresponsive, primary aldosteronism, Cushing syndrome, renin secreting tumor, Bartter syndrome, Gitelman syndrome, Liddle syndrome. Because we are only going to use half an hour to revise, so I'm just telling the names. All the precise mechanisms have been extensively discussed in the class. Normal value of anion gap 8 to 12 milliequivalents, 10 plus or minus 2. Then coming to TB, this is just like your X, always after you. And TB, drug sensitive, drug resistant. New case or old case, drug sensitive, the treatment is the same. In India, it is the same: 2 HRZE plus 4 HRE. Now don't think what is happening in US, UK, don't think about it. What is there in national program, that only you have to answer. Isoniazid resistant TB, you remove isoniazid and the rest levofloxacin, rifampicin, pyrazinamide, ethambutol. Definitions are important. MDR, resistance to both H and R. XDR, it is an MDR TB resistant to 1 fluoroquinolone. Along with that, bedaquiline or linezolid or both. Whereas pre-XDR, it is MDR with resistant to 1 fluoroquinolone. These are all the recent updated definitions. Apart from these regimens, apart from these definitions, don't refer anything else on Instagram or Facebook or any other social media, because they only want to divert you. These are from the recent Indian guidelines. Then coming to the treatment. So I have just summarized this. H mono or poly drug resistant regimen, 6 to 9 months of levofloxacin, rifampicin, ethambutol, pyrazinamide. Then there is for MDR 3 treatments now. Shorter regimen, this is 9 to 11 months, 9 to 11 months treatment. 4 to 6 months, bedaquiline for 6 months, levofloxacin, clofazimine, pyrazinamide, ethambutol, isoniazid, ethionamide. Next 5 months, levofloxacin, clofazimine, pyrazinamide, ethambutol. Longer regimen, usually the total duration is 18 to 20 months. We have levofloxacin, bedaquiline, linezolid, clofazimine, cycloserine. And lot of noise is the 6 months BPAL-M regimen: bedaquiline, pretominid, linezolid, and moxifloxacin. This is the summary of all the regimens for drug resistant TB available in our country. With this, I would like to conclude this session by giving you very important topics. Same thing I have discussed here: clinical entities, spirometry, obstruction versus restriction, respiratory failure types and AA gradient, ARDS, pulmonary embolism, diagnosis and treatment, pneumonia especially atypical is important, pleural effusion, the differentiation, transudate, exudate, aspergillus and lung, ABPA is star, ILD, UIP, NSIP is the star, occupational lung disease, asbestosis is the star, sleep apnea, OSA, OHS are the stars, lung cancer, the differentiation table. ABG, apart from interpretation, anion gap is very important. TB, the definitions and the treatment regimens. So thank you so much, students. You have done the hard part. Now only trust your preparation, not any other sources. The last few days is not about learning more. It is about revising and believing more. I hope we have done our part. Thank you so much, students. All the best. Now stay tuned.
Hi all my students. Good afternoon and welcome to the session of the General Pediatrics and Neonatology. So we'll be discussing the part of here.
Good evening.
the PYTs which are important from the NEET PG point of view. The simple one-liner question, the pre-ductal SpO2 monitoring in the newborn is done from the, and that is done from the right upper limb. That is always done from the right upper limb, because you want to know which blood is. Voice is okay, I hope. Right. So pre-ductal SpO2 monitoring is done in the newborn from the right upper limb. Anything problem or voice is clear? Okay, voice clear. Voice is clear. Okay. Then you should know what are basically the indications of the positive pressure ventilation in the newborn, and we are comparing it to the what are the indications for the chest compression in the newborn. So if you see the indications for the positive pressure in the newborn, the indications are heart rate is less than 100, or there is apnea, or the child is gasping. These are the three indications where you particularly start the positive pressure ventilation. And what is the indication for the chest compression? The indication for the chest compression is heart rate is less than 60 in spite of giving effective positive pressure ventilation for 30 seconds. Heart rate is less than 60 in spite of giving the effective positive pressure ventilation for effective, the word is effective, right? Then you should remember what is the concentration of the oxygen used. If you are going for positive pressure ventilation in a child which is more than about 35 weeks, you always start with the room air. We are starting with the room air, that is 21% oxygen. In less than 35 weeks, we are starting basically with the 21 to 30% oxygen. But if you compare it to the chest compression, in the chest compression always we are giving 100% oxygen. Remember, they will always give you a preterm child. They will ask you the concentration of the oxygen. You will start thinking on the lines of ROP. Chest compression is a life-saving thing. Preterm child, term child, always you give 100% oxygen. What is the ventilation rate for the positive pressure ventilation? It is 40 to 60. Just think of what is the normal respiratory rate in a newborn, 40 to 60. So what is the ventilation rate you want? 40 to 60. Then the chest compression to positive pressure ventilation, the ratio is 3:1, but remember that has to be given every 2 seconds. That has to be particularly given every 2 seconds, right? So just certain things to be remembered regarding the chest compression and the positive pressure ventilation. Regarding the ABGAR score, if we consider the ABGAR score, remember ABGAR score does not tell us about the need of resuscitation, because you are taking the first ABGAR score at 1 minute and the resuscitation should start at birth. So ABGAR score does not tell us about the need of resuscitation. And in hypoxic ischemic encephalopathy, the ABGAR score is 3 or less than 3 at 5 minutes. Right? This must two important lines to be remembered regarding the ABGAR score. Neuropathological changes in the hypoxic ischemic encephalopathy. In the preterm child, there is periventricular leukomalacia, that we simply say PVL. And this PVL mainly affects the fibers supplying the lower limb. So this will result in particularly what? This will result in the spastic diplegic type of the cerebral palsy. This will result in particularly the spastic diplegic type of the cerebral palsy. Clear? Now in a term child there is status marmoratus. This is particularly status marmoratus. And this status marmoratus is going to affect the basal ganglia. So this particularly results in the chorioathetoid type of the cerebral palsy. This results in the chorioathetoid type of the cerebral palsy is there. Right? Clear. Neonatal seizures. Now what you need to remember, overall what is the most common cause? Overall the most common cause is the hypoxic ischemic encephalopathy. Hypoxic ischemic encephalopathy. Most common cause in the preterm child, intraventricular hemorrhage. The most common cause in an infant of diabetic mother, it is hypoglycemia. This is particularly the hypoglycemia. Overall the most favorable prognosis, that is the hypocalcemia. Clear? So this is the just one liners I have taken, and they have to be remembered like this. First investigation to be done in the case of the particularly, what is the first investigation to be done? The first investigation we are doing is the blood sugar, right? What are the metabolic causes which can particularly cause neonatal seizures, hypoglycemia, hypocalcemia, hypomagnesemia, hyponatremia, and hypernatremia, right? This much is the essence to be remembered in the neonatal seizures. Talking of the respiratory disorders in the newborn, three important ones. One is the hyaline membrane disease, one is the transient tachypnea of newborn, one is the meconium aspiration syndrome. Hyaline membrane disease is particularly seen in the preterm child, TTN seen in the term child, meconium aspiration syndrome is seen in the post-term child. In the HMD, the respiratory distress usually develops. In the HMD, the respiratory distress is maximum up to 24 hours after birth. If it is after 24 hours, it is not HMD. In the TTN, just remember, no Krebs, no Rocci. In the meconium aspiration syndrome, actually it has the three things which is causing the damage. And what are those three things? Chemical pneumonitis, emphysema, and atelectasis. These are particularly the three things which are causing the damages there. Clear? Just right. Then we see in the chest x-ray. If you particularly see in the chest x-ray, here in the HMD initially is the reticulogranular appearance. This is particularly the reticulogranular appearance, which is followed by particularly the air bronchogram, and which is followed by ground glass appearance. In the TTN, it is prominent or the bulging fissures, or it is the sun ray appearance, which is due to the enlargement of perihilar lymphatics, right? If you see here in the meconium aspiration syndrome, multifocal consolidation due to pneumonia, emphysema can cause overinflation, atelectasis can cause collapse. Clear? So this is particularly here we say in the chest x-ray. Then a small topic, PPHN, persistent pulmonary hypertension of the newborn. This is primary and this is secondary. Primary PPHN, mother is exposed to NSAIDs during pregnancy. If the mother is exposed to NSAIDs, the child can have primary PPHN. Secondary PPHN, this is seen in pulmonary hypoplasia, which may be due to oligohydramnios, right? And this is seen in the pulmonary parenchymal disease. For example, this can be meconium aspiration syndrome. And you study the complication of meconium aspiration syndrome is persistent pulmonary hypertension of the newborn. Hypothermia. Hypothermia means cold stress is particularly 36 to 36.4, moderate is 32 to 35.9, severe is less than 32. And the mechanism of heat production in newborn. The mechanism of heat production in newborn is the non-shivering thermogenesis, and this is due to presence of the brown fat. Non-shivering thermogenesis. Certain things to be remembered in neonatal sepsis. Neonatal sepsis, one is early onset, late onset. Early onset is acquired from the mother. That is acquired from the mother. This presents as pneumonia. Late onset is hospital or community acquired, and this presents as meningitis. What is the first line of drug in the early onset? It is injection ampicillin or cloxacillin plus gentamicin. And if does not respond to MP or cloxa plus genta, then it is piperacillin tazobactam plus amikacin. Piperacillin tazobactam plus amikacin. In the meningitis, It is cefotaxime plus amikacin is the first line. Not responding to cefotaxime plus amikacin, meropenem plus amikacin, and remember very importantly the duration. The duration of the treatment for neonatal meningitis is 21 days. 21 days is there. Right. There are certain conditions in the newborn for which you don't require any treatment. Bilateral retinal hemorrhage, bilateral subconjunctival hemorrhage, and the repeated question says both are least common in C-section. They both are least common in the C-section, and both of them does not require any treatment. Per vaginal bleed in first week of life, no treatment. Caput succedaneum, no treatment. These are certain conditions which are present in the newborn for which no particular treatment is required. No particular treatment is required. Then is the neonatal jaundice. Just remember what is the criteria for pathological jaundice. Pathological jaundice, there can be increase in unconjugated or increase in conjugated bilirubin. Jaundice on day 1 is always pathological. Jaundice persisting beyond day 14 in a term child or beyond day 21 in the preterm child. And rate of rise of bilirubin more than 5 milligram per deciliter per liter. More than 5 milligram per deciliter per liter, they all are the pathological. So you can very well correlate physiological will not present on day 1, will not persist beyond day 14 in a term child or beyond day 21 in a preterm child, and rate of rise of bilirubin should be less than 5 milligram per deciliter per day. Then there are congenital RBC disorders, and what you should simply remember, this congenital RBC disorder can present as jaundice and they are not presenting as jaundice. They can present, they cannot present. If they can present, this includes hereditary spherocytosis, hereditary elliptocytosis, G6PD deficiency, pyruvate kinase deficiency, and alpha thalassemia. These are all the congenital RBC disorder which can present as jaundice. Hereditary spherocytosis, elliptocytosis, G6PD deficiency, pyruvate kinase deficiency, and alpha thalassemia. Not presenting as jaundice, beta thalassemia and sickle cell anemia, because in both of them beta chains are affected, and when a child is born, that is not requiring the beta chain. Not requiring the beta chain. One of the very frequent repeatedly topic, breastfeeding failure jaundice and the breast milk jaundice. One is breast milk jaundice, one is breastfeeding failure jaundice. This is usually seen in the first week of life. This is usually seen in the first week of life, while the breast milk jaundice is usually seen in second or third week of life. In the breastfeeding failure jaundice, you will always get history of the weight loss. History of the weight loss. In the breast milk jaundice, there is adequate weight gain which is present. Breastfeeding failure jaundice is basically due to increased enterohepatic circulation, and breast milk jaundice has got two things. One, there is increased beta glucuronidase which is present in the breast milk, which increases enterohepatic circulation, and there is fatty acids which inhibits the conjugation. Which particularly inhibits the conjugation, right? So this was the 3 lines to be remembered regarding the neonatal jaundices there. Then we see extrahepatic biliary atresia, EHBA. What will be the presentation in the child? There will be increased conjugated bilirubin plus clay or pale stool. Clay or the pale stool. What is the first investigation to confirm? That is liver biopsy. The first investigation to confirm is the liver biopsy, and the gold standard for diagnosis is intraoperative cholangiogram. The gold standard for the diagnosis is the intraoperative cholangiogram, and if required, the Kasai surgery should be done within 60 days of birth, right? So these are the 3 things for the first investigation to remember. The confirm will be what? That will be liver biopsy. Gold standard to confirm will be what? Intraoperative cholangiogram, and if required, the Kasai surgery should be done within 60 days of birth. Then the neonatal hypoglycemia, the blood sugar is less than 45. How to manage? A child is asymptomatic, it is 20 to less than 45. Remember oral feeds. Asymptomatic less than 20, IV glucose infusion. We are going for IV glucose infusion. Symptomatic, you are giving a loading dose of 10% dextrose 2 ml per kg followed by IV glucose infusion. So what you should remember, if only it is symptomatic, what we require particularly a loading dose. If it is not symptomatic, loading dose is not required. Asymptomatic 20 to less than 45 oral feeds, and asymptomatic less than 20 IV glucose infusion is there. Then antenatal steroids, again a very frequently repeated topic. It decreases the incidence of the hyaline membrane disease, IVH and NEC. That we are giving in India, dexamethasone. Do remember the dose of dexamethasone, 6 mg 12 hourly 4 doses, betamethasone 12 mg 24 hourly 2 doses. Dexa is the fourth letter, we are giving is 4 doses, beta is the second letter, we are giving is the 2 doses. And they are given if the duration of pregnancy is 24 weeks to 33 plus 6 weeks, and we are expecting delivery within the 7 days. So this is the condition where we are giving is the antenatal steroids is there. Very true, everybody is giving good answers. Necrotizing enterocolitis, right? This is 3 things to be remembered: the risk factors, the metabolic triad, and the radiological features. In the risk factors, it is prematurity, formula feeds, patent ductus arteriosus. And out of the 3, the strongest risk factor is the prematurity. That is the strongest one, right? Then metabolic triad is HAT, where H stands for hyponatremia, A stands for acidosis, T stands for thrombocytopenia. In the radiological features, we say it is stage 2A. In the stage 2A, you get is pneumatosis intestinalis, presence of air in the wall of intestine. And in the stage 2B, there is presence of air in the portal vein with or without ascites. Clear? So this is, I have taken these 17 points which according to me are important in the neonatology for the NEET PG. Now one slide of the so-called intrauterine infections. So what all the features we are getting in the intrauterine infection? In the toxoplasma, there is a triad of hydrocephalus, intracranial calcification, chorioretinitis. In the rubella, there is cataract, sensory neural hearing loss, patent ductus arteriosus more than pulmonary stenosis. In the parvovirus, it is anemia, myocarditis, non-immune hydrops. In cytomegalovirus, it is microcephaly, periventricular calcification, and sensory neural hearing loss. In the varicella, it is hypoplasia of the limbs and cicatricial skin rash, which is present in the dermatomal distribution. So 5 intrauterine infection, and I have just summarized here what all can be the features in them, right? Toxoplasma, rubella, parvo, cytomegalo, and the varicella is there. Right. Good everyone, very good. Chromosomal disorders. So certain things we remember in the Down syndrome. Now in the Down syndrome, the most common Robertsonian translocation is seen with chromosome number 14, which is group D chromosome. Most common Robertsonian translocation is seen with chromosome number 14, group D chromosome, not with 21, right? Remember, Robertsonian translocation. Clear. There is an increased incidence of congenital heart disease. Most common is the endocardial cushion defect. There is bilateral serous otitis media, so there is presence of conductive hearing loss. There is increased incidence of leukemia. The most common in infancy is the M7 type of AML, megakaryocytic type of AML, and it is the acute lymphoblastic leukemia. There is increased incidence of the celiac disease and the autoimmune disease. So this is basically what we say is the Down syndrome points to be remembered here, right? In the Turner syndrome, The most common congenital heart disease is the bicuspid aortic valve. In the skeletal changes, remember short fourth metacarpal metatarsal output, a very unique feature. This fourth finger, if you say particularly, that is short. So we say short fourth metacarpal metatarsal output. There is cubitus valgus and there is shield-like chest. There is sensory neural hearing loss. If you compare it to Down syndrome, it was conductive hearing loss. Here we say sensory neural hearing loss. There is increased incidence of the autoimmune disease, that is type 1 diabetes and the Hashimoto's thyroiditis. Type 1 diabetes and Hashimoto thyroiditis, and overall the stature is the short stature. Right. Then if you consider the Klinefelter syndrome, Klinefelter syndrome, tall stature, lower segment is more than upper segment. There is no mental retardation. Most common congenital heart disease is the mitral valve prolapse. Mitral valve prolapse. An important increased incidence of SLE. SLE is normally seen in females. Klinefelter is the only condition. Klinefelter is the only condition where it is seen in the males, and this is due to involvement of the gene TREX1. Absolutely right, no mental retardation we have given here. Now certain things to be remembered in the rickets, a very important line. Normal PTH level excludes the diagnosis of vitamin D deficiency. If in the question you get the PTH level is normal, just forget vitamin D deficiency. Even forget vitamin D dependent rickets, chronic renal failure. This cannot be vitamin D deficiency. If there is increased PTH and increased serum phosphorus and there is rickets, your cause is chronic renal failure. Your basically cause is the chronic renal failure. Then is the refractory rickets, the one which is not responding to cholecalciferol. This can be particularly increased PTH, normal serum phosphorus, normal PTH, decreased serum phosphorus. If it is increased PTH, it is chronic renal failure, VTDR 1A, 1B, 2A and 2B. Normal PTH, normal serum phosphorus, only one condition we remember, that is distal renal tubular acidosis. Here we say proximal renal tubular acidosis and the X-linked hypophosphatemic rickets. So this is the picture of the refractory rickets is to be remembered. Certain points of differentiation between the marasmus and the kwashiorkor. We know in the marasmus there is loose folds of skin, but in kwashiorkor there is tense and the shiny skin. Here there is no edema, here edema present. In marasmus, old man, monkey or simian faces, here we say moon-like faces. In marasmus, no hepatomegaly, in kwashiorkor, hepatomegaly present. In the marasmus, there is loss of the subcutaneous fat. Loss of subcutaneous fat, and here we say flecky paint dermatitis. Right? Just important points you need to remember between both of them, marasmus and kwashiorkor. Then you should remember the doses for vitamin A supplementation in the same child. 6 months to 1 year, we are giving is 1 lakh international unit. More than 1 year, 2 lakhs international unit. More than 1 year, less than 8 kgs, 1 lakh international unit. If there is sign of vitamin A deficiency or history of recent measles, sign of vitamin A deficiency or history of recent measles, we are giving is 3 doses, 1, 2 and 14 days. We are giving is 3 doses on 1, 2 and the 14 days. Right? So vitamin A supplementation is duly important in the same child. My second last point, upper segment, lower segment ratio. We all know the growth is cephalocaudal, so initially the upper segment is more. So at birth the ratio is 1.7 is to 1, 3 years 1.3 is to 1, 5 years 1.2 is to 1, 7 years 1.1 is to 1, 10 years 1 is to 1. So there are certain conditions where we get is the infantile body proportion and where we get reverse infantile body proportion. Infantile body proportion basically means is upper segment is more than lower segment, and reverse means is lower segment is more than the upper segment. Infantile body proportion is seen in hypothyroidism, achondroplasia, and rickets, right? And if you see, basically they all are three also the disproportionate cause of the short stature. Disproportionate cause of the short stature. Reverse infantile is seen in Marfan syndrome, Klinefelter syndrome, and the homocystinuria. So there is basically infantile body proportion. One is the reverse infantile body proportion. This, according to me, is the list of the milestones which you should remember. At 5 months, you say bidextrous grasp, 6 months unidextrous grasp, 7 months transfers objects from one hand to another, 9 months waves bye-bye. Waves bye-bye. Always remember, when the child comes for the measles vaccination, child waves bye-bye for the first time. 9 months speaks bisyllables, Baba, Dada, Mama, object permanence. 15 months child jargons. 2-year child knows 50 to 100 words. 3-year child knows 250 words. 4-year child hops and uses the past tense. Right? So this was from my side the time allotted to me, 30 minutes. I have tried to compile the important points for you all people. Right? I hope you are in the very best phase right now. And from Dr. Ashutosh Agarwal, your pediatrics faculty, lots of wishes to all of you. May God bless you all, and may God you all what you want to achieve. Always remember, one PG seat. Pray to God, you are definitely going to get your PG seat. Remember this. Thank you all. Thank you so much. May God bless you all. Right? I have tried to basically, thank you Tanvay, I have tried basically to compile. Clear? So with this, I am taking, thank you Mohammed for my daughter. Thank you. Thank you all.
Good afternoon. Hope audio video everything is okay. Hope audio video everything is okay. Am I on screen? Yeah. I'm on screen. Audio video everything is okay. Just say okay or put thumbs up in the chat box. Good afternoon. Good afternoon. Yeah, great. Right. It's a marathon. We have just 2 days, 2 to 3 days maximum. Today is Wednesday, Thursday, Friday, Saturday. That's all. No problem. This is sufficient. Just spend some time to revise many things. Don't do any new exercise. Don't do anything new now. Now you need to just revise what you already have. Got it? Just I'll take 1 hour. Just I'll take 1 hour. Yes. Just recollect few points. Antibiotic production is the bacterial growth curve. Bacterial growth curve is very important. Antibiotics production seen in which phase? Antibiotics are produced in stationary phase. Which phase is ideal for antibiogram? Antibiogram ideal phases, logarithmic phase. Which phase is ideal for sporulation? Which phase is ideal for sporulation? Okay, just I'm seeing the chat box because it's not coming in my this one. Yeah, sporulation stationary. And adaptation, phase of adaptation is first phase, lag phase. The phase of adaptation is lag phase. Very good. People answering beautifully. Involutional phase is the last, death phase, decline phase. Decline or death phase is involutional form. That's all. Next is Chemical disinfectant concentration is isopropyl alcohol. It is any alcohol 70%. Chlorhexidine, best skin antiseptic, especially CVC, central venous catheter, is 2%. And Lysol Cresol to clean the vomitous stool, 5%. Chlorine, 1 to 10% available. Sorry, 0.5 to 10% available. 0.5 to 10% available. Very good. After orthophthaledehyde, usually 0.55%. And glutaraldehyde 2%. Glutaraldehyde 2%. Beautiful, beautiful. Beautifully people are answering. I'm so happy. Next is, what is this? This is called lawn culture Kirby-Boyer method. Lawn culture Kirby-Boyer method, antibiogram. Lawn culture Kirby-Boyer method, antibiogram. So today is the new laptop. Just now I opened, I put all the softwares fast. 10 o'clock started, by 12:30, 1 o'clock everything is over. First class for you. Okay, right. Bioterrorism agent categories. Very important, sometimes they'll ask. MDR TB category C. Yellow fever also category C. Emerging viral infections. E. coli any diarrhegenic. E. coli O157H7 category B. Ebola very dangerous category A. SARS, not COVID-19, old SARS comes under category C. Yersinia pestis, plague, category A. So you must know about these things. Great. And microbes associated with autoimmunity, important. Rheumatic fever associated with gas, group A beta hemolytic streptococcus. Streptococcus pyogenes. Viral always myocarditis, think of Coxsackie. Coxsackie B virus, that is important. Reiter syndrome, many people, gonococci, chlamydia, Shigella, Yersinia, many people. Reiter, multiple sclerosis, chlamydia. Scleroderma bacteroides. Guillain-Barré syndrome. Nowadays, it is very famous. Many outbreaks happened. Is Campylobacter jejuni. Campylobacter jejuni. Very good. Beautifully answering. Just another 50 minutes. Important points. HS are examples. Hypersensitivity reaction. Allergic rhinitis comes under type 1. Contact dermatitis comes under type 4. Serum sickness type 3. Graves disease type 2. PK reaction type 1. Lepra reaction 3 is type 3. Lepra reaction 3 is type 3. Good. Now, very important, name the test and organism. That's all. Rapid revision. It's a marathon, we need to run. So it is called coagulase test. It is positive in Staphylococcus aureus. And everybody aware of that. What is the tongue? It is called strawberry tongue. Very good. It is seen in commonly, as a microbiologist, I can say it is in scarlet fever. And do not forget Kawasaki disease also. and this is called CAMP test. CAMP test positive for GBS, Listeria, and Vibrio Eltar. These CAMP test is called modified CAMP test, but always remember CAMP test positive for GBS. Reverse CAMP test positive for Clostridium perfringens. And what is this? This is called pseudomembranous tonsillitis. Pseudomembranous tonsillitis. Corynebacterium diphtheriae. Pseudomembranous tonsillitis, Corynebacterium diphtheriae. Very good, very good, very good. Because when you remove the membrane, you can get raw area with bleeding. They may ask anything Corynebacterium diphtheria after giving the picture. Mechanism of action of toxin, selective medium, anything. Don't worry. You cool, you will succeed. Next is, what is this? This is called Edshore. Another differential diagnosis, ecthyma gangrenosum, but remember Edshore. Where you can get Edshore? Edshore seen in anthrax. Another disease, cutaneous anthrax. Scrub typhus. Very good. Scrub typhus and some other ricket cell diseases. You can get Edshore. Scrub typhus, mainly anthrax, Edshore, this one. And this is called, see, swelling, sinus and granules. It is called cervicofacial actinomycosis. It is caused by actinomyces. Classical feature is lumpy jaw. People call it as lumpy jaw. Actinomyces, people call it as lumpy jaw. Snap, you are right. Shunkarath. Beautifully people mentioning lumpy jaw. Aishwarya, Drishti, Tarun, ABK, Sakshi, Anushka. Great. What is it? What is the name of the test? This is called Naegler's reaction. Demonstration of lecithinase. It is commonly seen in Clostridium perfringens. And do not forget, lecithinase activity also exhibited by Bacillus cereus. But number one, Clostridium perfringens, Bacillus cereus also we can demonstrate the test. Lecithinase. Clostridium perfringens is the first answer. Second answer, Bacillus cereus. This is called pseudomembranous colitis. See, the birds are outside my home. My garden, my birds are still shouting. Pseudomembranous colitis. They're singing. Is Clostridium difficile associated with clindamycin and treatment fidaxomicin, vancomycin and fidaxomicin. Vancomycin and fidaxomicin. Sorry. Vancomycin and fidaxomicin. Next is, what is it? What colony this is? How they look like? How you people call it as? We call it as what colony? This is called fish eye colony. This is fish eye colony. We can see in Salmonella. Many medium. One example, Wilson Blair medium. Wilson Blair medium. Very good. This is what medium? This is called LJ medium. LJ medium, rough, buff, tough colonies. Rough, buff, tough colonies. LJ medium. For Mycobacterium tuberculosis. Yeah, beautifully people answering. I'm so happy. This gives confidence to me. I'm very confident about my kids. The way you are answering, the way, the speed. These are the questions they ask in the exam. Anyway, after 3 days later, you are going to tell, yes, sir, this is true. Okay, right. So, Runyan's classification. This is very important. Mycobacterium smegmatis comes under rapid growers. Mycobacterium kansasi, photochromogen. Mycobacterium ciliatum comes under scotochromogen. Mycobacterium ulcerans, non-photochromogen. Mycobacterium marinum is photochromogen. Mycobacterium avium, again non-photochromogen. You need to squeeze your brain. You need to squeeze your brain. Okay. That's all. This is called question mark shape. What is it? This stain is called Fontana stain. Leptospira interrogans. Leptospira. Leptospira interrogans. Yes, Sahina, right? Fish tank granuloma. And this is called bisected pearl appearance. Aluminum paint. Bisected pearl, aluminum paint. Any other name? Is mercury drop appearance. Bordetella pertussis. Bordetella pertussis. That's all. Make it easy. Okay. So this is gram negative kidney shape, intracellular diplococci, Neisseria gonorrhoeae. And everybody knows what is the rash called? Target rash or annular rash. What is the name of the disease? Lyme disease. Yeah, people beautifully answering. I'm so happy. Pranaya, Amida, Ishrat, Devanashi, and Hina. Great. Target rash or annular rash for Lyme disease. Next is, come on, what appearance? Owl eye appearance. Owl eye appearance. That's all. Cytomegalovirus. Renal transplant, congenital infections. Renal transplant, congenital infection. That's the reason. Mainly. Okay, interstitial pneumonia. Many things it causes. PP65. PP65 antigen. This is what appearance? Slapped cheek. This is slapped cheek appearance. Parvovirus. B19. Very good. Tarun, Abhijit Chaudhary, right? Abhijit regularly coming. The names are Aishwarya, Abhijit are very familiar names. Good. Great, great, great. Next is, what is this spot? Oral cavity is Koplik spot. White lesions in oral cavity, Koplik spot. Suggestive of Koplik spot. Suggestive of measles. Koplik spots suggestive of measles. And inclusion body, Warthin-Finkeldy bodies. Next is, what is it? Burkitt's lymphoma. Epstein-Barr virus. We call it as EBV, Epstein-Barr virus, or human herpes virus 4. Epstein-Barr virus or human herpes virus 4. Next, we should learn in one slide, 7 to 8 points. You already saw the slide in the DVT also, but this is important. Hepatitis in pregnancy, hepatitis E virus. Shipyard eye. Shipyard eye. You can say adenovirus. Adenovirus. Great. Devil's grip. Coxsackie B virus. Bonham disease. Transfusion hepatitis is always hepatitis C virus, we call it as. Serum hepatitis is hepatitis B virus. Transfusion hepatitis C, serum hepatitis B. Antibody dependent enhancement seen in dengue virus. Australia antigen is hepatitis B, surface antigen. Kaposi sarcoma, human herpes virus 8, AIDS defining illness. These are all key points about viruses. Key points about viruses. Patients with hepatitis B marker 100% possibilities. If all are negative, he is no protection, he may be susceptible. IG core surface antigen positive, core antibody IgM positive, acute hepatitis. Core antibody IgG plus surface antigen, chronic hepatitis. And only antibodies, core antibody, surface antibody recovery. Convalescent phase. Only core antibody IgM window period. Only core antibody IgG past infection. No infection, no disease, only protection, vaccination. This table is important. Must know table, my dears. Must know table. Great, great, great. Now, parasitology. What is it? Vaginal discharge, single nuclei like this. Is Trichomonas vaginalis. Trichomonas vaginalis. This is leaf shape we call Giardia lamblia. It exhibits jerky motility or wobbling motility. It exhibits jerky or wobbling motility. Giardia lamblia, jerky or wobbling motility. Here it exhibits falling leaf motility. Falling leaf motility. Now see the people. Oval shape, always you can think, what is it? Cyst isospora. These two without size we cannot answer, but you are able to see ghost cyst. Partially acid fast, cyclospora. Round shape, uniformly, fully stained, acid fast, cryptosporidium, small. Four to 6 micrometer, into 2, 8 to 12 micrometer, into 3, 24 to 36 micrometer size. 4 to 6, 8 to 12. Make it easy. Make things simple. Numbers asked already. I told, my dear, before you ask, I told the number. I know. This is the question my kids will expect. Not only you, examiner also expect. Don't worry. Yes or no? Yes. Next is, yeah, this is called trypomastigote, trypanosoma. Trypomastigote, trypanosoma. And this is multiple rings in the RBC. Are able to see Acol formation. Acol formation, multiple rings. Plasmodium falciparum. Next is, what is this? Maltese cross appearance. Babesia. Maltese cross appearance, Babesia. Next is, see carefully here. This is terminal spine. Schistosoma hematobium. Make it easy. And forked tail. Tail cercariae. In schistosoma. Forked tail cercariae seen in schistosoma. Very good. People discussing many points. Great. And intermediate host, fish. In fish tapeworm, Diphyllobothrium latum, Clonochis sinensis. Cattle. Many places, mainly Taenia saginata, beef tapeworm. Even you can go for toxoplasma. But mainly cattle, Taenia saginata. This is crab for Paragonimus westermani. And this is called cyclops or water flea for Diphyllobothrium latum, first intermediate host, and Dracunculus medinensis. Guinea worm, Dracunculus medinensis. Great, 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 great. Yes, Divya, great. Nagarika, Rizwan, great. Amna. Next is, what egg? This is operculated egg. Operculated egg. You can see in all trematodes except schistosoma and diphyllobothrium latum. This is egg with polar mucus. Okay, it is having mucus plugs. Trichuris. And this is plano-convex. Kidney shape, entrobius. And clear shell. Clear shell, hookworm. Clear shell, hookworm. That's all, my dear. So one question from egg will come usually. Usually one question from microfilaria may come. Tail tip is having 2 nuclei, Burgia. Tail tip filled with nuclei, Lova. Tail tip no nuclei, Uchururia bancrofti. No sheath, no nuclei. Titan is Onchocerca. No sheath but with nuclei. It is Manzanella persistens or Manzanella streptocerca, but streptocerca hook-like. So Manzanella persistens. Make it easy. You concentrate these 3 people. 1, 2, 3. That is important. Next is green color, top 2/3 Aspergillus fumigatus. Yellow flave, full Aspergillus flavus. Black, always Aspergillus niger. Aspergillus niger. And please do not forget internodal rhizoid absidia. Where nodal rhizoid, rhizopus. No rhizoids in mucor. No rhizoids in mucor. No rhizoids in mucor. Next is, listen to me. This is broken ping ball appearance. All crushed ping ball. The same thing as recently 3 days before in this one. FMGE. Okay. Nemocystis. Nemocystis zerowasi. This is asteroid bodies. Asteroid bodies. Seen in Sporothrax. Sporotrichosis. And copper penny bodies. Chromoblastomycosis. And this is nodal rhizoid, rhizopus. Rhizopus mucormycosis. Mucormycosis. This is vertical branching. Acute angle branching is Aspergillus. Okay, I got the query. Good. Yes, it's called medullary body or sclerotic body, muriform body, finally copper penny body. Many are there. Okay, you remember everything. And this is spaghetti meatball appearance. Or banana grapes appearance. Spaghetti meatball. Another one is banana grapes appearance. You can see in tinea versicolor. Malassezia. Malassezia. This is spirule with endospore. Coccidioides. Spirule with endospore, coccidioides. This is figure of 8 appearance. Blastomyces. This is pilot wheel appearance, figure of 8 or snowman. Broad base budding cell, broad base budding cell. This is pilot wheel appearance, where you can get pilot wheel. Paracoccidioides, very good, very good. People blasting. Paracoccidioides, same confident, same way we need to answer in the exam. Don't get tensed in the exam. My only fear is your tension, not your preparation. I'm never fear about your preparation. Your preparation is 200%, I'm satisfied. But the calmness without tension, that is important. Without fear, without tension, we need to attend. That is important. Next is, what is this? This is called germ tube. Candida. Candida albicans mainly important pathogen. And drug resistant Candida is Candida auris. Drug resistant Candida is Candida auris. And this is India ink. Always think of Cryptococcus neoformans. Cryptococcus neoformans. Next is very important, exotoxins and their mechanism of actions. Tetanospasmin inhibit the release of GABA and glycine. It acts on the snare protein, which leads to spastic paralysis. Botulinum toxin cleave the snare protein, inhibit the release of acetylcholine. Flaccid paralysis. Diphtheria, ADP ribosylation of elongation factor 2, protein synthesis. E. coli, stable toxin, increase cyclic GMP. Labile toxin, increase cyclic AMP. And Shiga toxin, enterohemorrhagic E. coli toxin, usually acting on 60S or 28S ribosome, inhibit protein synthesis. Inhibit protein synthesis. 36 minutes, 30 seconds over. Okay, right. I'm seeing my monitor. Every second counts. Henderson-Peterson body molluscum. Negri body, everybody aware of that. Rabies. Lipschul's bodies, herpes. Taurus bodies, yellow fever. Bollinger bodies, foul pox. Gornary bodies is vaccinia virus. Vaccinia. Just you can remember. Even you are not writing also, just you can recollect. That's all. Because this is not the time to write, read, and already studied, just recollect. Streptococcus pneumoniae, selective medium, you can go for chocolate agar. or blood agar. It produces carom coin or Draughtsman colonies. Cornybacterium, diphtheria, mites, rarely they may ask. Tinsdale medium. Poached egg colonies. Legionella, BCYE agar, cut glass colonies. Haemophilus influenzae, Leventhal agar, iridescent. These are little rare forms. Actinomyces, even blood agar. It produces molar tooth colonies. Spidery molar tooth colonies. Cornybacterium diphtheria intermedius. Many mediums are there. You can remember macleoid or downy medium. Macleoid or downy medium. Frog egg colonies. Frog egg colonies. Now, frog egg colonies. So, disease associated, it is pig with Tinea solium. Pig is important. Pig bell, enterohemorrhagic E. coli, O157H7, pig meat, swine flu, Trichinella spiralis. Many are there. Many are there. Pig associated with many diseases. These are all important diseases. Neurocysticercosis, pig bell, everything. This is called beaver. And beaver fever. Otherwise called giardiasis. This is 9-banded armadillo. Mycobacterium leprae. This is monkey. Yellow fever. This is a reservoir. Monkey fever. KFD. Kaiser's forest disease. Great. Ashwini, Sonam, Kumari, Tanya. Everybody is beautifully answering. And one more. Monkeypox. 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 Birds. Parrot. Chlamydia psittaci. Psittacosis. This is pigeon. Pigeon dropping. You can get it in Cryptococcus. Next is bat. Bat. Rabies. Nipah. Ebola. Histoplasma capsulatum. Histoplasma capsulatum. Yeah, today night I will release some important topics in Telegram channel. And one more thing, my dears, Friday afternoon 2 to 5, I will be available in Telegram 3 hours. Whatever doubt you can post, just like that. You mark your doubts on page, use that 3 hours. Okay. On Saturday, full time I planned available in Telegram channel. Whatever doubt you have, within 20 minutes you will get the response. Maximum within 20 minutes you will get the answer. Not only you, the whole people get the answer. So feel free to contact me. Last push, I will be with you. Don't worry. Okay. I will be with you. So this is cat bite abscess. Pastorella. Cat bite abscess, Pastorella. Next is like parent. If my son is writing exam, definitely last one day I will be with him. They give moral support. That moral support I can give my kids. Don't worry. I'll took leave 2 days. Don't worry. So 2 days I'll be available only for you people. You feel free to post. Okay. Cat bite abscess. Next is cat scratch disease. Bartonella Hensley. Toxoplasma. These are major cat related infection. Major cat related infection. Okay, don't worry. Next is hemolytic uremic syndrome. Enterohemorrhagic E. coli. O157 H7. H7. Banworth syndrome, neuroborreliosis. Neuro. Hepatorenal syndrome, leptospirosis. Leptospira. Water canperinium, gonococci. Fitzhugh-Curtis syndrome, chlamydia. Gonococci. Many are there. Waterhouse-Fridtchen syndrome, meningococci. Meningococci. Great. Just you can recollect. Erythema infectiosum. Parvo B19. Erythema marginatum, group A streptococcus. Erythema nodosum leprosum, Mycobacterium leprae. Erythema migrans, moving rash, Lyme disease. You can get Borrelia burgdorferi. Erythema multiforme, herpes and mycoplasma. Erythema necroticans, lepra reaction 3. Erythema mycobacterium, lepra reaction 3, Mycobacterium leprae. Erythema arthriticum, Haverhill fever, Streptobacillus moniliformis. Streptobacillus moniliformis. Yeah, all eri. It's like mini DVT, that's all, don't worry. Associated diseases. Yes, what is it? This is called louse. Louse associated with epidemic typhus. Trench fever. And epidemic type of relapsing fever. Relapsing fever. This is called hot tick. Because you are seeing the mouth part, hot tick. Hot tick is vector for many people. Remember at least 5 to 6. Ehrlichia, Lyme disease, KFD, Babesia, Rocky Mountain spotted fever, Indian tick typhus, etc. Tularemia, many are there. At least remember as much as possible. This is called cone-nosed bug or kissing bug or cone-nosed bug. Assassin bug. Scientific name, triatom bug. Chagas disease, Trypanosoma cruzi, Chagas disease. And this is rat flea. mainly vector for plague. Another one is endemic typhus. Hymenelepsis diminuta, not for humans, animals. And sometimes coxilla for animals, not for humans. Don't worry. These two remember, sufficient. And this is sandfly. Sandfly vector for Bottonella bacilliformis, Leishmania, Chandipura virus, sandfly fever, Chandipura virus, bacilliformis, everything. Great, great, great. This is Aedes mosquito for at least 4 people. Dengue, yellow fever, chikungunya, dengue, yellow fever, chikungunya, Zika, all the people. Very good, very good, very good. Aedes. And this is block fly or similium fly. Onchocerca valvulus. Onchocerca valvulus. And this is mite. Mite is mainly vector for scrub typhus, rickettsial pox. Mite is vector for scrub typhus and rickettsial pox. Got it? Right. Next is food and pathogens. Chinese fried rice. My kids become happy if the question comes laddu question. Okay. Chinese fried rice. You can go for Bacillus cereus. Be serious. And canned food. Clostridium botulinum. Canned food, botulinum. Botulinum toxin, DDDD. Seafoods, Vibrio vulnificus. Seafood, Vibrio. Cheese, Listeria. Cheese, Listeria. Important. Food items. Definitely we may get some clue from food item. Directly they will not ask, it gives you a clue. Cool sore, impetigo. Cold sore, herpes. Oriental sore, leishmania. Hard sore, syphilis. Soft sore, chancroid. Haemophilus ducrei. Haemophilus ducrei. Haemophilus ducrei. Satellitism also in this PDF. Okay, dear, no problem. You want satellitism? Is no problem. Sakshi. I will write, otherwise I'll forget. Nowadays the aging is there, no. Because of aging, I forget many things. So I'll write satellitism to include. Now I will not. Okay, this pen I need to check. Good. I wrote it is in my thing. Satellitism. I wrote what to add. Okay, don't worry. Chancroid. Next is vaccine and strains. Varicella. Vaccine strain is this time yellow fever strain they asked in FMGE. Right. Listen. Varicella Oka strain. Varicella Oka strain. Measles. Edmundston Zagreb. Mumps Jarellin. Mumps Jarellin. Rubella. You have RA 27/3, yellow fever 17D, diphtheria Park William 8 strain. Diphtheria is Park William 8 strain. Okay. Now 54 minutes over. Always I used to finish 5 minutes earlier. That is always at least 1 minute earlier I'll finish. Now 4 minutes are there. So in the 4 minutes I need to talk to you because I know you are always the best. The one thing, only one thing you need to take out of the best from you. You already have the best with you. So next 3 days you have a sound sleep without panicity. Just to go through this. Don't discuss rarest thing among the friends. Better don't talk to friends. Because somebody has some particular syndrome. If you're not aware of the syndrome, you become depressed. Then you thought, I didn't study, I'm not able to remember. Sometimes the fear will be there. I can't remember anything. I studied it because of panicity. It's not mean that you are not remember. You remember. Only in the exam. In the exam, that pressure, the answer will come like anything. Flow. Okay. Because you will run only in the fear. If I say you run fast, you will not run. If one line is chasing, your running will be totally different. You become more than Usain Bolt. If one line is running you, chasing you in the forest, you will run like anything. Usain Bolt will not come to you, near to you. Same way, in the exam, your performance will be automatically increased. Now don't compare how. And always you dream. In the exam, I will be calm, quiet. I'll be calm, quiet. I'll keep myself calm. Exam will be easy. I will go and answer everything. I'll coming out of with happiness. You be little hallucinated, artificial hallucination. Be with artificial hallucination. That will help you. Same mood you will go, same mood you will come. Okay. Thank you. Single double standard trick I will tell ma. I will tell, put it in the, you please put your doubts in the telegram. I will read, I will answer all those things. Okay. Mostly by evening 7 o'clock I'll start my answering the things. Now I have some other job. No problem. Anyway, now the time is exactly 55 minutes. I'm closing. Thank you very much. God bless you. It's a gloves just for avoid heat. Touch gloves. This is a touch gloves. Nothing. Now happy? Yes. My blessings are always with you. Okay. My blessings are always with you. Be rock. Next 2 days I will be with you. It's promise. Okay. Thank you. Thank you. Thank you. God bless you. All the best. Do well. Don't waste your time.
Hey everybody, am I audible? Can you just write in the chat box that I'm audible, visible, then we'll start. Good evening everybody. Audible, visible. So what we'll do is I will be talking about systemic pediatrics, important for your NEET PG, and my name is Siddharth Sethi, and these are my social media accounts if you want to ask me any questions. So what I'll do is I will be talking about systems. We'll talk about all the important systems and the important relevant MCQs which come in your NEET PG exam. Okay, so let us first start with the most common question which comes in NEET PG, and all of you should be aware about a child with fever and rash. So here is a 2-year-old boy and he has fever, he has conjunctival inflammation, swollen palms and soles. So can you see swollen palms and soles? So I can tell you every exam of yours will have a patient, a child with fever and rash. Okay, and strawberry tongue. So strawberry tongue is very important. So remember, strawberry tongue is also seen in Kawasaki disease and scarlet fever. But how do you differentiate Kawasaki from scarlet? Remember, scarlet fever responds to penicillin very well. Okay, within 24 hours, fever comes down in scarlet fever. Okay, so all of you should know Kawasaki is the most common acquired heart disease in children.
in US, Japan and Chandigarh. Okay, so it is the most common acquired heart disease in children in US, Japan and Chandigarh. It's because of awareness. We'll talk about this. It's not overall. It's the most common medium size vasculitis in children. Overall nahi bola. It is the most common medium size vasculitis in children. Okay. Now it is all because of awareness. And this is Dr. Kawasaki from Japan, and you know today tsunami came in Japan. So it's all because of this Dr. Kawasaki who raised awareness about this disease in Japan. Okay, and he died during COVID. So all of you should be aware that why are we talking about this and why is it important for your exam is because coronary artery aneurysms are seen in Kawasaki disease. In 20 to 25% of Kawasaki, coronary artery aneurysms are seen. So guys, also remember, and I hope you all attended the back to basics lecture where I talked about MISC, multisystemic inflammatory syndrome in children with COVID. So even in COVID-19 in MISC in children, they also get coronary artery involvement. Okay, so exam mein they will take you to coronary artery aneurysms. So here is a left LED branch of the left coronary artery. This is the right coronary artery showing aneurysms. Yes, this is the most common cause of death in Kawasaki disease. Excellent. There are many questions in the chat box. Yes, so overall, the most common cause of death in Kawasaki is coronary artery related complications, aneurysms and complications. So why are we talking about this? Because we can prevent this. So remember, in each of your exam, you will definitely have a child with unexplained fever. So here is a child for fever for the last 5 days, and there are 4 out of these 5 criteria. Okay, so you have to know these criteria because this is classic clinical criteria. So this fits into Kawasaki. Okay, fever is the most important criteria, at least 5 days. And those who have attended my COVID-19 lecture, in MISI we say 3 days. In COVID-19, the multisystemic inflammatory syndrome, there we say 3 days. Now here it is 5 days. And 4 of these 5. Changes in the extremities, acute or subacute. So acute is erythema of the palm, soles, edema of hand and feet. Now this is a favorite question of NEET PG, that peeling of fingers and toes is seen in the 2nd to 3rd week of illness. Okay, so they may say, you know, when do you see peeling of fingers and toes? It is seen in 2nd to 3rd week of illness. A rash in multiple stages. Now remember, all of you, please listen to me carefully. This rash is not like chickenpox. It is not vesicular. Okay, favorite of NEET PG, favorite of INICET. Kawasaki में vesicular rash is not seen. Now conjunctival inflammation without exudate. So please remember, non-exudative conjunctivitis, erythema and cracking of lips, strawberry tongue may or may not be there, erythema of oral and pharyngeal mucosa. Now remember, even in PGI, you know, they commonly ask about this. It's a big unilateral cervical lymph node. 80% of these children have a big unilateral cervical lymph node. Okay, so remember this. So this is a very important diagram which Dr. Kawasaki made in 1967. So in 1967, you know, he discovered Kawasaki disease in Japan. So he said that Kawasaki disease has 3 phases: acute, subacute, convalescent. So can you see, all of you, fever? So you will get a child in your exam with fever, arthritis. Now can you see acute phase mein myocardial failure, myocarditis? Can you see thrombocytosis? So listen to me carefully. In MISI there is thrombocytopenia. So in COVID-19 there is thrombocytopenia. In Kawasaki there is thrombocytosis. So this is the difference. Okay, in Kawasaki, thrombocytosis. Okay, cool. Okay, now aneurysms are seen in the 2nd to 3rd week of illness. So remember, aneurysms are seen in the 2nd to 3rd week of illness. Desquamation is also seen in the subacute phase, and right in the end you see nail changes in the convalescent phase of Kawasaki disease. So why are we talking about Kawasaki? Because we can do something, everybody, to prevent the aneurysms, and the drug of choice is IV immunoglobulin. So remember, the drug of choice is IV immunoglobulin, 2 grams per kg. Okay. Now this reduces the risk of aneurysms to 4 to 6%. Okay. Initially we told you the risk is 20 to 25%. Now the risk becomes 4 to 6%. Okay. Okay. Cool. And along with this, we give aspirin, high dose aspirin, almost 80 mg per kg per day till the child is afebrile for 48 hours. Okay. Cool. Now all of you should know what is resistant Kawasaki also. First of all, remember 1 to 2% of patients Kawasaki disease may recur. Okay, so it may recur in 1 to 2% of the patients. It can be resistant in 10 to 15% of patients. Okay, so remember Kawasaki can be resistant in 10 to 15% of patients. Now what is resistant? Fever is persisting or it recurs within 36 hours of IVIG. So fever is persisting or it recurs within 36 hours of IVIG. So if fever is persisting, everybody, let me ask all of you, what would be your next step? What is the most common second line drug used in resistant Kawasaki? And Tarun is right in the chat box. We repeat IVIG. So the first step, if fever is still persisting or recurring, comes into the definition of resistant, we add IVIG again. You can also give methylprednisolone, infliximab, an interleukin 1 blocker called anakinra. You can also give cyclosporine, plasmapheresis, or cyclophosphamide. Okay, so these are the options we have in resistant Kawasaki. Now all of you, let me talk about the most common vasculitis in children. So all of you, exam में एक ऐसा बच्चा आएगा, fever and palpable purpura. You can see palpable, listen to me carefully, palpable non-thrombocytopenic palpable purpura. So platelet count is normal. So what will you think of if I say a child has, he just got up in the morning and his extensors, legs, shins were full of palpable non-thrombocytopenic purpura. So we call it as IgA vasculitis. So all of you, the new name is IgA vasculitis. So Dr. Kavya, in Kawasaki, we give aspirin till child is afebrile for 48 hours. So here is the immunofluorescence showing IgA deposition in the skin. Now remember, all of you have to remember, now the new name is IgA vasculitis. And this is the most common vasculitis overall in children. It is the most common small vessel vasculitis in children. It is the most common leukocytoclastic vasculitis. What do I mean by leukocytoclastic? Matlab WBCs are invading the vessel wall. Okay, so WBCs are invading the vessel wall. Okay, leukocytoclastic. Okay, now according to the European League Against Rheumatism, so in Europe there is a society for rheumatology called European League Against Rheumatism. So they define it as palpable purpura. There should not be any coagulopathy, no thrombocytopenia. So there is palpable purpura without thrombocytopenia and any one of these. Pain abdomen. This is a typical colicky postprandial pain. Typical colicky diffuse postprandial pain. Arthritis or arthalgia. Biopsy of any tissue shows IgA1 deposition or kidney involvement. Now we'll talk about kidney involvement today, because in your exam they always ask about kidney involvement. So kidney is involved in 30 to 50% of patients, within 6 weeks. So if a child has got, palpable purpura, within 6 weeks, most of them will get, almost 30 to 50% of them will get kidney involvement. Now, what do you see in kidney involvement? Some RBCs in the urine, just microscopic hematuria with or without proteinuria. So you may see some RBCs in the urine. Okay. They may have protein also loss in the urine. Now, if they get a lot of protein in the urine, nephrotic range proteinuria, then you do a biopsy. So if you see there is a lot of RBCs plus a lot of protein, we do a kidney biopsy, we give prednisolone and cyclophosphamide oral. We give oral cyclophosphamide with prednisolone. Now what do we see in biopsy? Mesangial proliferation. Mesangial expansion and mesangial proliferation in the biopsy. Now rarely, you may find a rapidly progressive kidney failure, rapidly progressive glomerulonephritis or rapidly progressive kidney failure. On biopsy you see crescents, and when you see crescents you have to give early steroid, high dose IV methylprednisolone and IV cyclophosphamide. We don't want crescents to fibrose, so we give IV steroids and IV cyclophosphamide. Now remember, your NEET PG examiners always ask you about what are the indications of steroids in HSP. Severe pain abdomen. Remember, severe pain abdomen. So this is NEET PG 2022, guys. 11-year-old child with severe pain abdomen, you give steroid. Remember, even for testicular pain, gonadal vessels are also small vessels. So even for testicular pain, gonadal vessels also, we give steroids. Of course, for severe kidney involvement, we give steroid. So हमने कहा severe pain abdomen or orchitis, you give steroids. Now remember, your examiners love to ask about classification of cyanotic heart disease. See, acyanotic is ASD, VSD, PDA. Acyanotic is mostly ASD, VSD, PDA. Now you should know how to classify cyanotic heart disease. With increased pulmonary blood flow, and I told you this in DVT also, all of you, and reduced pulmonary blood flow. Now remember, in increased pulmonary blood flow, there is truncus arteriosus. So there is a single vessel above the heart, that's truncus arteriosus. Transposition of great arteries has increased pulmonary blood flow. We'll talk about TGA today. Total anomalous pulmonary venous connection. So totally anomalous pulmonary venous connection has increased pulmonary blood flow. And also remember hypoplastic left heart syndrome. So if left heart is hypoplastic, so blood cannot come from your, there is pulmonary edema, blood cannot come to the left ventricle. So there is pulmonary edema. So then also there will be increased pulmonary blood flow. Now let us talk about total anomalous pulmonary venous connection. So the pulmonary venous blood is anomalously going to the right side. Supracardiac is the most common. Remember, 50%, the most common TAPVC is supracardiac. Okay, matlab pulmonary veins are joining the superior vena cava. Remember, this is a favorite question of your examiners. Remember, this is favorite question of your examiners. Figure of 8 appearance or snowman's heart. Figure of 8 or snowman's heart is supracardiac TAPVC. Can you see 8 here? So figure of 8 or snowman's heart. In infracardiac TAPVC, you see a ground glass lungs like RDS, like RDS has ground glass lungs. Okay. So ground glass lungs because of pulmonary venous hypertension. Okay. Ground glass lungs because of pulmonary venous hypertension. So all of you should know that the X-ray features of TAPVC can be of two types: supracardiac and infracardiac. Okay. Supracardiac is figure of 8. So you can see on your left is supracardiac, snowman's heart, cottage loaf, figure of 8. and on your right you can see ground glass lungs. Now this is another, this is the pattern of NEET PG guys. I can tell you, मैं बता रहा हूँ, एक एक्सरे आएगा congenital heart disorder. History will be a Dr. Manisha in the chat box. History will be of a cyanotic child. You can see this history on your screen. Cyanotic child. Now remember, supracardiac is less severe, so he's 12-year-old. Infracardiac will be just a neonate. Okay, so this is a typical X-ray. So in your exam you will get an X-ray and a clinical context. So you'll have a clinical picture plus the X-ray. Okay, cool. Now I talked about TGA. In TGA what happens is that the great vessels are transposed. So aorta is arising from the right side, pulmonary artery from the left side. So the great vessels are transposed. TGA is the most common cause of cyanosis in a newborn. Remember, TGA is the most common cyanotic heart disease in a newborn. और X-ray में क्या दिख रहा है? Egg on side. Can you see अंडा? It's like an egg on string. It's an egg on side or an egg on string appearance in TGA, transposition of great arteries. So we talked about, guys, plethora. Let's talk about oligemia, in which pulmonary blood flow is reduced. So if pulmonary blood flow is reduced with cardiomegaly, remember tricuspid atresia has left ventricular hypertrophy. Epstein's anomaly has a box or a balloon shaped heart. Remember, Epstein's has a box or a balloon shaped heart. So guys, remember, exam में एक ऐसा X-ray होगा, massive heart, and then they will talk about mother having a bipolar disorder, she is on lithium. Okay, so भूलना नहीं है, maternal lithium, Epstein's anomaly. Okay, similarly, maternal thalidomide causes phocomelia. So these common simple questions come in your exam. Okay, so maternal thalidomide, phocomelia. A box or a balloon shaped heart is seen in Epstein's. Massive cardiomegaly is seen in Epstein's. So what happens, if a mother is taking lithium? So what actually happens is that this tricuspid valve starts to bulge into the right ventricle. Okay, so there is downward displacement of the tricuspid valve into the right ventricle. And can you see such a big right atrium? So remember, the main problem in Epstein's is a large right atrium. The right ventricle has become atrialized, atria jaisa. The right ventricle has become atrialized. Okay. So we talked about oligemia with cardiomegaly. Now all of you have to remember oligemia with a normal size heart and a single second heart sound is seen in tetralogy of Fallot. This is called Fallot's physiology. So all of you need to know about TOF. We'll talk about TOF today. So oligemia with single second heart sound, normal size heart is Fallot's physiology. So you see tetralogy of Fallot. Now there are many other conditions which look like tetralogy of Fallot, like double outlet right ventricle with pulmonary stenosis, single ventricle with pulmonary stenosis, TGA with VSD with pulmonary stenosis. So they all look alike. Now guys, abhi just last INICET, they asked about what is the tetralogy in tetralogy of Fallot. What are the four components of tetralogy of Fallot? And the question was, the pulmonary stenosis is subvalvular. Remember, it is infundibular. Remember the word subvalvular. So mostly it is subvalvular, but pulmonary stenosis can occur at any part, but mostly it is infundibular subvalvular pulmonary stenosis. This is the most important component of tetralogy of Fallot. This leads to right ventricular hypertrophy. So remember, this leads to right ventricular hypertrophy. Aorta is overriding the septum, and there is a perimembranous VSD. So the fourth component is perimembranous VSD. Now because pulmonary stenosis is the most important component, so right side ka pressure increases and the shunt is right to left. Impure blood is going into the systemic. So guys, the most common cyanotic heart disease overall, listen to me carefully, the most common cyanotic heart disease overall and after the first year of life is tetralogy of Fallot. Now remember, X-ray तो आएगा ही, okay? लिख के दे देता हूँ मैं, okay? TOEF में they will ask this X-ray. Can you see a concavity here because of the pulmonary stenosis? ऊपर there is concavity और नीचे देखो there is the apex is uplifted. So it is giving a X-ray showing a boot-shaped heart, which is also called the coherence abort. And you know, exam में पूछेंगे, NEET PG में आया था 2018 में. What causes the boot? It is because of right ventricular hypertrophy. The apex is uplifted. So remember, the apex is uplifted. It is like this. You know, there is a concavity here up above, and there is a uplifted apex causing. It's looking like a boot. Coherence abort. Okay, guys, do read about cyanotic spells. A very commonly asked question. Now let me take you to recurrent pneumonia. Now again, you know, I can write it on the screen here. This question will definitely come in your exam on cystic fibrosis. So you have to know the life cycle of cystic fibrosis. Infancy में pancreatic insufficiency. So if you see a child with foul smelling bulky stools with respiratory problems, think about cystic fibrosis. Meconium ileus. An infant has not passed meconium. Guys, meconium ileus is pathognomic of cystic fibrosis. Look at the sodium, chloride, all their life. Sodium is low, chloride is low. Listen to me. Every time in cystic fibrosis, all their life, sodium is low, chloride is low. Now, allergic bronchopulmonary aspergillosis. Adolescents can have DIOS, distal intestinal obstruction syndrome. Distal intestinal obstruction syndrome, DIOS. Okay, and in adulthood, guys, they can have liver failure. Remember, liver failure, it is one of the indication for liver transplant in the West. And you can see CBAVD, bilateral absence of vas deferens and seminal vesicles. Bilateral absence of vas deferens and seminal vesicles. It means almost all men of cystic fibrosis are infertile. Almost all men of cystic fibrosis are infertile. Guys, in every class of mine, in every NEET PG revisions, DVTs, everywhere I talk about this. Important hai, okay? So even females can also be infertile of cystic fibrosis, but because of mucus issues. So this is a typical question, guys, which came in NEET PG recently. A 9-year-old boy. So what do you expect in a 9-year-old boy with cystic fibrosis? DIOS. Remember, sodium is not high. Sodium is always low all their life. Nowadays, rectal prolapse is rare. Remember, after we have started using pancreatic enzymes, so remember, rectal prolapse is rare in cystic fibrosis nowadays. It is rare. So देखो, सबको 3 बातें नहीं, 4 बातें याद रखनी. चलो नहीं, 5 बातें. Cystic fibrosis is autosomal recessive. Okay? Cystic fibrosis is autosomal recessive. Now, which is the most common mutation? Delta F508. Deletion of the phenylalanine at the 508 number position. Okay? So, it affects a chloride channel. Okay? CFTR, active chloride channel. There are more than 1800 mutations, but today I am talking about the most common mutation. Now, this most common mutation is called class 2 mutation. And what it does is, actually, it causes a trafficking defect. So, all of you know, protein is made up on endoplasmic reticulum, then it goes to the cell membrane and it makes the chloride channel. Now, here the problem is that the protein is not able to go to the cell surface and it causes a trafficking defect. Okay, so this is class 2 mutation. Okay, all of you. Sorry about that. If you can't, I'll just put it on the left side. Sometimes, you may not see this. Yeah, now you can see this. So this is, remember, this is class 2 mutation. And what is the treatment of choice? Now the treatment of choice is a combination therapy. We use 2 correctors and 1 potentiator. So there are 2 correctors, which correct the trafficking defect, teza-catheter and alexa-catheter. So there are 2 correctors, teza and alexa-catheter, and 1 potentiator. So eva-catheter opens the chloride channel for a longer period of time. So remember, eva-catheter opens the chloride channel for a longer period of time. Okay guys, cool? Yahan tak cool hai all of you? Can you just write in the chat box? Just write in the chat box. Cool. So that now I'll take you to the next system of endocrine. So remember, examiners will always ask you about newborn screening. Remember, we can diagnose disorders at birth by just 2 drops of blood on a filter paper by heel prick. So here we take a heel prick, 2 drops of blood on a filter paper by a heel prick on day 3 to day 5 of life. Day 3 to day 5 of life. Okay? Day 3 to day 5. Okay? Day 3 to day 5 of life. और सबसे इंपॉर्टेंट है TSH. सबसे इंपॉर्टेंट है TSH. Congenital hypothyroidism is the most common preventable mental retardation. क्या बोला मैंने? Most common preventable, because we can diagnose this early and treat this early. So ideally every baby in the world should get a TSH and T4. Okay? Now congenital hypothyroidism होता क्यों है? Because thyroid gland is not formed. So 85% of the times it is dysgenesis of the thyroid gland. So thyroid gland ही नहीं बना हुआ. Okay? Remember, it is not uncommon. It is 1 in 2000 live births, and it is more common in girls somehow. So this disorder is more common in girls. Mostly, we talk about boys, but hypothyroidism is more common in girls. So this was a recent NEET PG question where they asked if so cutoff of TSH is 20. If it's very high, remember, you should do a nucleotide scan. If it's very high, you should do a radionucleotide scan, okay, to look for the thyroid gland. So this is a radionucleotide scan, guys, and what you can see here is this is the normal thyroid. These are salivary glands. This is normal. You can see thyroid, and on your right side you can see dysgenesis. You cannot see any thyroid gland here. So dysgenesis of the thyroid gland. Okay, now let me talk about one more autosomal recessive endocrine disorder. Exam में एक बच्चा आएगा, okay, a 2-week-old with shock and ambiguous genitalia. Okay, so he has a penis. This child has a penis-like structure, but the scrotum are empty. Okay, नहीं stomach की बात नहीं कर रहे. Okay, we are talking about empty scrotum. A neonate in shock with penis-like structure and empty scrotum. Think about autosomal recessive CAH, congenital adrenal hyperplasia. Now, favorite question of your examiners, 90% of the times it's a block here, 21 hydroxylase deficiency. So remember, 90% of CAH is a block here, 21 hydroxylase deficiency. Can you see? So aldosterone is not formed, cortisol is not formed, and testosterone is high. Can you see? Aldosterone is not formed, cortisol is not formed, and testosterone is high. So if aldosterone is not formed, so sodium is lost, potassium is high. So hyponatremia, hyperkalemia, hypoglycemia. Now testosterone causes ambiguous genitalia in females and precocious puberty in boys. So testosterone causes ambiguous genitalia in females and precocious puberty in boys. So emergency में क्या करना है? Bolus of normal saline and hydrocortisone. So remember, the drug of choice, this is a Addison's crisis or a salt wasting crisis. So drug of choice is a normal saline bolus and IV hydrocortisone. Okay, you can later on give oral fludrocortisone also, but the drug of choice is normal saline bolus and IV hydrocortisone. And everyone, very good. 17-hydroxyprogesterone is the investigation of choice. You can see here 17-hydroxyprogesterone, which is also done in newborn screening also. So this is the classic presentation which you should know, guys. A child who comes to you in salt wasting crisis with ambiguous genitalia. Now guys, you cannot go to the NEET PG exam without talking about infantile spasms. Salam seizures. So a child comes to you with salam seizures. Salam like bilateral flexor contractions. And this is the typical EEG. Can you see all over the brain? You can see chaotic high voltage slow waves. All over the brain you can see chaotic high voltage slow waves. Okay, all over the brain. Now the drug of choice is intramuscular ACTH. So basically a steroid based therapy, intramuscular ACTH or steroids. Okay. Now only for tuberous sclerosis infants, remember the drug of choice is vigabatrin. So only for tuberous sclerosis infants, the drug of choice is oral vigabatrin. तो सबको याद रखना है. Okay, drug of choice for infantile spasms ACTH, drug of choice for hips arrhythmia ACTH, drug of choice for West syndrome ACTH. Okay, now in your exam they may show you a child who comes to you with a blank stare, a vacant blank stare lasting for less than 30 seconds. Think about absent seizures. A vacant or a blank stare lasting less than 30 seconds. Think about absent seizures. Common after 5 years. Can you see all over the brain? Every second there is a spike and wave, 3 hertz. Every second there are 3. Generalized 3 hertz spike and wave pattern is seen in absent seizures. And the drug of choice is ethosuximide. Remember, drug of choice is ethosuximide. Don't ask this again, okay? And just the last page of the day of systemic pediatrics. In juvenile myoclonic epilepsy, which is seen in juveniles, they commonly come to you with drops, myoclonic jerks. So a child comes to you with myoclonic jerks and GTCS. So an adolescent comes to you with myoclonic jerk. Remember, 90% of them present with GTCS. Okay, 90% of them present with GTCS. 1/3 of them can also have absent seizures. This is the most common generalized epilepsy syndrome in adolescents and young adults. Most common generalized epilepsy syndrome in adolescents and young adults. EEG shows polyspike and wave discharges. Can you see polyspikes and wave? Now just the last sentence, listen to me carefully. Now the Nelson's textbook, remember Nelson's textbook clearly says that for JME we start with valproate, but only for females. The drug of choice is levetiracetam. ध्यान से सुन लो. In females, the drug of, because of the hormonal side effects, the drug of choice is levetiracetam. Okay. Otherwise, valproate. If valproate is given, go for valproate. But exam में question ऐसे ही होगा, you know. If there is a concern, and this was a question in NEET PG last year, if there is a concern in females in juvenile myoclonic epilepsy, what is your drug of choice? Then it will be levetiracetam. Okay. Only vigabatrin, Dr. N, in the chat box. So that was all about systemic pediatrics, and I wish you all the best, guys. And I'll see you on the other side on NEET PG day. Once you get a good rank, I'll see you on the other side when you are a postgraduate and a super specialist. Thank you. All the best.
चलिए let's start again. So how's your Josh? How's your Josh? I hope it's high. It's high. It's high. तो अपना टाइम अपन खुद लाएगा. Right. Okay. Chalo, let's start, and I'll just do a quick revision of all the topics which have come recently in the past 3 to 5 years in NEET PG. Okay. Right. Chalo, let's start, Madi. Somewhere we got a question on hyponatremia with seizure in the previous year NEET PG question. So one thing that we need to go through again is how to calculate the total sodium deficit. So the total sodium deficit that we need to learn is by a formula that is desired sodium minus the actual sodium into a total body water that we have. For females, the weight into 0.5 is a total body water, and for the male it will be 0.6. Okay. The initial target to rise sodium is 4 to 6 milliequivalent in 6 hours, and then gradually it should be increased, and we should never overcorrect it beyond how much time? 10 to 12 milliequivalent per liter in 24 hours time. So why? Because we already know in case you have a rapid correction of the sodium being done, you will suffer with what? Osmotic demyelination syndrome, right? And use 3% saline only in symptomatic cases, not for everyone. Okay, so that's a basic rule of correcting sodium, right? And ODS is something that has been asked recurrently in the exam, that how does it really present? It presents with quadriparesis, and the patient is more or less drowsy at the time of ODS when it comes in, right? Okay, so if you want to know what is a term known as sodium or hyponatremia, in a patient with hyponatremia, don't forget the normal range that generally we have is running in between a range of 135 to 145 milliequivalent per liter. So that's the general normal range of sodium that we have. Okay. In case it dips down, and if the patient has hyponatremia, the initial symptom that we have is generally abdominal pain and vomiting. So this could be the initial symptom of hyponatremic patient. Then we'll have in the patient a lot of lethargy and fatigue that they generally have, followed by unconsciousness and comatose stage. And in that particular stage, we'll have a seizure disorder also seen in the patient. Okay. And what is ODS? Okay, you might have heard about OCD. Now, what is ODS? It is osmotic demyelination syndrome. So osmotic demyelination syndrome comes in when the patient is overcorrected for sodium at a value of more than 10 milliequivalent in 24 hours time. Okay. So let's see another topic, that is Graves' disease. Graves' disease is something which has been asked last time, that in that Graves' disease we have our thyroid receptor antibodies, and they are most specific for diagnosing Graves' disease anytime. And we have exophthalmos as a presentation there, and it is due to autoimmune orbital inflammation seen in the patient. Correct. The golden point that we need to learn in that, sometime patient is only hypothyroid condition with ophthalmopathy. So one thing as a rule that we know, that this hyperthyroidism generally presents with ophthalmopathy. So we have seen that in our clinics most of the time, patient initially may just come with ophthalmopathy, and then the clinical symptoms of hyperthyroidism would come in the patient. So will hyperthyroidism precede ophthalmopathy? Yes, it generally precedes, but sometimes there is a lag most of the time. Initially they have ophthalmic symptom, and then hyperthyroid symptoms would really come in the rest of the things. Okay. Right. So that's a quick recap of hyperthyroidism. Parkinsonism has been a regular topic in the exam. Please remember, Parkinson is a basal ganglia disorder. We have read this a lot in the exam, in the classes, that it presents with resting tremor, rigidity, and bradykinesia. And which part of the brain is actually affected is the substantia nigra pars compacta is somewhere
being affected. So whenever, please remember, there is a tremor, rigidity, bradykinesia, think about Parkinson and a basal ganglia lesion. Okay. Okay. So most of the questions which have been asked on Parkinson in NEET PG are quite straightforward. Now answer my question. In a patient of Parkinson, the first symptom which they generally present is, and what is the most essential symptom of Parkinson patient when they come to me with? Okay. So tell me two things. What is the first symptom and what is the most essential symptom? Yeah, we've discussed this in the class a lot of time. The first symptom is non-motor anosmia. Okay. And the most essential symptom is bradykinesia. Bradykinesia. Right. Okay. Tremor is the first motor symptom. Be careful in this question. If the question is just the first symptom, it has to be anosmia. But the first motor symptom, if they ask you, then their answer should be what? Tremors. Tremors. Right. Okay. Another important topic that we got in the exam of late was subacute combined degeneration. So B12 deficiency is going to affect what? The dorsal column, the corticospinal tract. Okay. So SCD or subacute combined degeneration has the involvement in the patient of the posterior column, corticospinal tract, as well as peripheral neuropathy. So let's see again. If the corticospinal tract is affected, patient will present with what? UML signs. Okay. If the patient is having posterior column disorder, there will be loss of vibration and proprioception. And angular stomatitis and all is due to B12 deficiency. So this is the classical triad that you should know. Angular stomatitis, UMN symptoms with posterior column symptoms. Okay, altogether is subacute combined degeneration, often due to B12 deficiency. Just a quick recap of what we read in the class. What is one disease that may mimic SACD? There is one myelopathy. There is one disease that may mimic SACD. Okay, tell me that. Which myelopathy? Clinically, I say clinically mimics SACD. Clinical features are almost the same. Anji, सांग मला जो मला माहिती नाही. Tell me something which I don't know. Hypocupric, less copper. Myelopathy is another topic that keeps on coming sporadically in the exam. Not TABIS, please. TABIS doesn't have corticospinal involvement. Okay. Okay. Right. So hypocupric myelopathy. Nahi baba. Dun, 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 dun. Oh, okay. So I'm here for revision. Quick recap. Okay. Hypocupric myelopathy is a clinical condition where copper is less due to excess of zinc supplement being given in the patient. We'll come to when someone is selling ALS. Oh my god. Okay. Chalo. Dementia of Lewy body, DLB, another very important topic. Herein the patient comes with visual hallucination, fluctuating cognition, and all the symptoms of Parkinson. What are we seeing inside the brain is alpha-synuclein inclusion. So it comes under a category of synucleinopathy. So please remember, when do you think Lewy body dementia? You think when the patient has early visual hallucination with symptoms of Parkinson. Okay. So just remember this topic, synucleinopathy. There are certain conditions where alpha-synuclein is deposited inside the brain that is going to create all the trouble. Okay. Yeah. So we have got in the list as dementia of Lewy body, one of them. Another one is elder brother Parkinson every time. Followed by what? One more disorder. Tell me. What is a disorder which actually has got alpha-synuclein inside the brain? Synucleinopathy. It's multiple system atrophy. Let me answer here. कुछ भी बोलोगे. Multiple system atrophy. Okay. Right. So just a comparison with systemic path that we have as taupathies. Disorders which have got tau protein inside the brain. Taupathies. Yes. So taupathy that we have inside the brain is Alzheimer, no doubt.
FTD second, third is PSP, and the third is corticobasilar degeneration or the CBD. Okay, good. So please remember this small rule in systemic path that we have got. Okay, chalo. Let's move in further to another topic that came in the exam was central diabetes insipidus. Please remember it happens when post hypocystectomy, loss of ADH happens. What are the classical features of central DI? You generally have a dilute urine and severe hyponatremia is seen. And for a patient with central DI, we may require lifelong desmopressin nasal spray. Okay. So central DI, please don't forget this topic. It can occur post hypospexectomy. Okay. Loss of ADH occurs. There is hyponatremia and dilute urine seen in the patient and they require lifelong ADH therapy. So there was a question previously in which they have done a hypophysiectomy in the patient, that is pituitary dissection, and the patient had all the parameters like this. Okay. Okay. Prolactinoma, another very important topic. Please remember, amenorrhea and galactorrhea together is a syndrome of hyperprolactinemia. First, always remember, please remember, first always think that whenever a patient comes to you with prolactinoma, the ideal treatment of choice is always a dopamine agonist. Okay. So if the shrinkage of tumor occurs, there is a normal size being attained in the pituitary tumor with also regression in the level of prolactin, surgery is not advisable. So the first line of treatment is always what? The medical line of treatment. Yes, the drug of choice award goes to cabergoline. Okay, but don't forget, in pregnancy, it is bromocriptine. Right. So if I ask you, what is a drug of choice for hyperprolactinemia, not OMA, in a fertile female? Please tell me. Anji, sang mala jo mala mahiti nahi. Tell me something which I don't know. Drug of choice for fertile female with hyperprolactinemia. This has been a NEET question for you. Always consider the one which is having a better track record, that is known as the bromocriptine. Yes, good. And what about fertile males? Drug of choice for hyperprolactinemia for fertile males. Tell me. थोड़ा दिमाग लगाओ. Fertile male. Yes, cabergoline. Good. So they might change the language in the question. Please be careful while answer. Don't just read the word fertile and go ahead with it. Okay. DK, another very small important topic. It's a triad of hyperglycemia with ketonuria and metabolic acidosis, right? The first line of treatment is always IV fluid, and then we give regular insulin to the patient. So don't forget the flip therapy. Fluid, insulin, and then P. What is P? Potassium. Okay. Never start insulin before the IV fluids in DK and monitor the potassium closely in the patient. Please remember, potassium comes at the end, but in case the patient is hypokalemic in DK, don't forget, please always consider fluid therapy and then insulin. In case the patient is hypokalemic, correct the potassium and then start insulin. Otherwise, the patient will go into hypokalemia. Acanthosis nigrans. Yes, this has been a question. It comes where? In metabolic syndrome. In obesity and insulin resistance together, you have a acanthosis nigrans, a skin kind of a velvety pigmented axillary skin lesion. Okay, so what is acanthosis nigrans? It's a cutaneous sign of insulin resistance. Right. Okay. So there was a question that was based on this. A patient came with dropping mouth, inability to close the eye. Is what? A element kind of a facial palsy. Please do remember this. In element, the whole face is affected. In UMN, what is paired? The forehead is paired. Okay, so we know this fact already from the classroom teaching. If I have a patient in whom one side of the face is totally gone off, it's LMN. If we have a patient in whom only one side of the face and that too the lower half is gone and the forehead and the eyelid are spared, it's what kind of a paralysis of the facial nerve? UMN kind of paralysis. Okay. Migraine attack. What are the features of migraine attack? It's an acute headache with photophobia and nausea. Don't forget this. Right? Treatment. To stop, we can give sumatriptan. Triptans are always the first line to abort a migraine attack. Please remember this rule. So the first line in management of in a patient of migraine is always to give triptan, and they are the ones which are going to abort the acute attack. Right. So there was a question again on Parkinson. There was a question on Parkinson that was regarding the Parkinson treatment. Right. So please remember, yes, MAO-B inhibitors like siligilin or even rasagiline are used in early treatment of Parkinson because they are seen to be neuroprotective and they decrease atrophy and delays the need for levodopa in the patient. Okay. If a patient comes to me with Parkinson disease, I will start the patient on what? Levodopa. Should I start with levodopa alone? No, always I'll add something J-Viro combination. What is that? Carbidopa. Correct? Along with that, I'll always add in my patient what? A MAO-B inhibitor. Always add it because it will delay the atrophy in the patient and further progression in the disease. Okay. Always remember, there is a doubt in the chat box. If the patient becomes hypokalemic during sugar correction in DK by insulin therapy, should I stop insulin? Yes. Generally, when you want to give potassium therapy in a patient of DK, please remember the rule. In case your patient's serum potassium that you have seen in the EBG sample is somewhere between below 3.5 milliequivalent per liter at the time, any time, please no insulin. And what do you need to give? Yes, the potassium to the patient first. Potassium has to be given at a good dose of almost 40 to 80 milliequivalent per liter. In case it comes in a normal range, that is between 3.5 to 5.2 or 5.1, yes, still I'll give potassium to my patient at a lower dose, maybe 1 to 20 milliequivalent per liter. In case it is above 5.2 or even at 5.2, no potassium is required, only insulin is required. Okay, so anytime it dips below 3.5, stop insulin, start giving potassium first. Okay. So this has been another question. Hemiballismus. So don't forget hemiballismus. I've taught this a lot in the classroom teaching. It's a flinging wild unilateral movement due to lesions seen in the contralateral subthalamic nucleus. Okay, so the lesion is in the left, the right side of the body will find it there. Okay. TBM. TBM is something very basic, simple. The CSF finding in TBM shows me a high protein, low glucose, lymphocyte, and a cobweb clot will be seen. So there was an image in the exam recently in which a cobweb image was shown. The CSF sample was resting in the test tube, and the lower part has some sediments over there. Okay, so don't forget the golden point. Cobweb in the CSF is a TBM hallmark. And what should I look in for imaging? Always what? The basal exudates. Okay. And at the end, don't forget Hira Thakur, Zaher wali kheer, the legendary topic, yes, Mr. Brown or the Brown-Sequard syndrome. Okay, you are going to get something on this. In a patient with Brown-Sequard, please remember the spinothalamic is affected at the level of the lesion on the same side, below the level of the lesion on the opposite side. At the level below the level, posterior column is affected on the same side. At the level of the lesion, LMN on the same side, and below the level of the lesion, UMN on the same side. So this is the direct topic which is going to come in the exam, Mr. Brown-Sequard syndrome. Okay. And a word on the brainstem syndromes that we do get. So please remember the rule in brainstem syndrome. In case you have a third nerve palsy, third cranial nerve palsy, okay, always consider what? A midbrain syndrome, because midbrain is a house for third nerve. Okay. The next thing that you need to know is my patient having some kind of weakness or not. If weakness is present in my patient with a third nerve palsy, somewhere in the midbrain, the anterior part is the ventral part is involved there, and that is known as a Weber syndrome. Okay. In case the weakness is not there with the third nerve palsy, we always look for ataxia. Okay, ataxia. In case ataxia is there, yes, you have to look at the kind of ataxia they're suffering. Like, is there a contralateral ataxia or is it ipsilateral ataxia? If it is a contralateral ataxia, we have the red nucleus involvement, and we call this as the Claude syndrome. Claude syndrome. Ipsilateral ataxia is a North-Nagel syndrome. And don't forget, Weber and Claude together becomes both of them together what? The Benedict syndrome. The Benedict syndrome. Okay. And in the MCQ, anytime you have got a 6th nerve palsy or a 7th nerve palsy, think about pontine lesion, pontine syndrome. Okay. Yes. So 6th nerve, 7th nerve, pontine lesion. So going like this: third nerve, midbrain syndrome; 6th nerve, 7th nerve, nucleus is in pons, so it's a pontine syndrome. Then we need to look at the patient's weakness is there or not. Yes. If weakness is there with 6th and 7th, yes, we consider it as the very famous Millard-Gubler syndrome. Millard-Gubler syndrome. Millard-Gubler syndrome. Right? Okay. Along with that, if we have in our patient involvement of medial lemniscus and the medial longitudinal fascicle, that basically relates to that relates to your Fovley syndrome. Right? Then we have a syndrome in which the cranial nerves are involved. In case your patient's 12th cranial nerve is involved, 12th nerve is involved, so we consider the lesion is where? In the medulla. Okay. So 12th nerve, corticospinal involvement with medial lemniscus involvement is a medial medullary syndrome. Jarine syndrome is another name for that syndrome, medial medullary. Okay. And then of course 9th and 10th is involved. Then we have a lesion in the lateral medulla. So 9th and 10th involvement cranial nerve means a lateral medullary or the Wallenberg syndrome. Okay, right? Along with that, if you have involvement of spinal lemniscus and the 5th cranial nerve, spinal nucleus, and of course the sympathetic trunk. So all together is a Wallenberg syndrome. Okay. Right. आता है. So I've not gone into every topic. देखो भाई, this is a marathon. Okay. And we are going to only touch upon the topics which have come in the last 4-5 years very regularly. And just to end it up, sum it up, don't forget about myasthenia gravis.
myasthenia has been a sporadic topic at a lot of places. So in myasthenia, please remember, the first symptom that we generally get in our patient is a ocular symptom. Okay, remember this word, ocular. Apart from this, don't forget the investigative modalities. First, we'll always do an INICET test. If that is positive, I'll go in for detection of the acetylcholine receptor antibodies. In case they are negative, then I'll go in for higher investigative modality, that is single fiber EMG. In case my acetylcholine receptor antibody are positive, yes, it's a case of what? Myasthenia gravis. Yes, and don't forget the drug of choice for myasthenia anytime is my friend. Who? Pyridostigmine. And of course, conditions apply. We have to consider the patient for what? Immunosuppression. And in the long run, as a cure, maybe to remove the symptoms and to basically remove the treatment part also, you're going to consider for what? Thymectomy. So these are the important topics which have been asked in the exam regularly. So please go through them once, and it's unnecessary at this moment to touch upon something which you really don't know. Okay. Chalo, there are so many things, but when it comes to exam, तो अपना टाइम अपन खुद लाएगा. And finally वो दिन आ गया. Yes, NEET PG is about to come. Let's see it happens on time this time. And all the best. Stay calm, cool. Don't venture into something that you really don't know. Try to know something and revise something that you already know. Okay. So tension is inversely proportional to number of days for exam. Tension is very high. Okay. So just go through the previous notes that you have with you. And that's it. Okay. Thank you.
Good evening, everyone. I hope you have prepared well for your upcoming examination. In this session, we will be seeing the most important questions regarding biochemistry. In biochemistry, they use 2-3 very important tools. One, that it is volatile subject. Another second point is there are overlapping terminologies. If you have malate, there will be malonate something, and most of the students, they get confused between these terminologies. So the important point here is, for the last minute revision, you have to revise biochemistry first and foremost. Complete revision, thorough revision is not required at last minutes, that is in the last few weeks. We are focusing now especially on the most important topics, right? So when we say most important topics, that includes glycogen storage diseases, sphingolipidosis, competitive, non-competitive enzyme inhibition. Under carbohydrates, gluconeogenesis is very important. We usually get a question on galactosemia. We usually under proteins, we will see a question on tyrosine, phenylalanine and tryptophan. Under lipid metabolism, LPL, lipoprotein lipase, hormone sensitive lipase, these are important terminologies. Then lipoproteins, anything can be asked. They can ask a question on LDL, HDL, but usually by and large we will have questions only on, we will see questions only regarding LPL, hormone sensitive lipase, like that. Vitamins, everything is important. Somehow over the last 3-4 years, vitamins has gained the most weightage. So for vitamins, everything is very important. Under electron transport chain, there is a slide which we will be seeing today as well. And that slide is that slide is regarding the electron transport chain and oxidative phosphorylation inhibitors. In this particular session, I have divided the whole biochemistry under different subheadings. Let's get started. First is carbohydrates. Under carbohydrates, the glucose transporters. Whether it is bidirectional glucose transporters or unidirectional glucose transporters, everything is important. Particularly under bidirectional glucose transporters, we have GLUT2 and GLUT4. GLUT2 has a higher Km and GLUT4 has a lower Km, as can be seen in this given slide. In addition, where are they situated? GLUT2 is present on the liver, pancreas, kidneys, small intestine. GLUT4 is present in the skeletal muscle, adipose tissue and heart. Somehow GLUT4 has been repeatedly asked over the last 2-3 years. Particularly, it has been asked in skeletal muscles. However, anything pertaining to GLUT2 and GLUT4 can be asked, and out of the two, insulin dependent is GLUT4. We have insulin dependent is GLUT4. The insulin independent is GLUT2. Now, usually when you see this terminology, insulin dependent, insulin independent, it is on this is interchangeably used, but what they want you to know is that they are using it only for GLUT2 and GLUT4. Other glucose transporters, it doesn't matter whether they are insulin dependent or independent. You have to know that GLUT2 is insulin independent and GLUT4 is insulin dependent. Another important topic, gluconeogenesis. Most important topic under gluconeogenesis is its rate limiting enzyme, that is fructose 1,6-bisphosphatase. It is a counter enzyme to PFK1, which is the rate limiting enzyme for glycolysis. What are the allosteric activator for this enzyme? Citrate. Allosteric inhibitor, fructose 2,6-bisphosphate and AMP. Also, if there is a question regarding gluconeogenesis, another can be which will decide the gluconeogenic capability of the cell, then the answer is pyruvate carboxylase. Pyruvate carboxylase. Now, this pyruvate carboxylase is the enzyme which is doing the first step in the gluconeogenesis. If this enzyme is there, अगर ये enzyme है तो gluconeogenesis होगा. What enzyme decides gluconeogenic capability is pyruvate carboxylase. And this is the most important slide under carbohydrate metabolism, the glycogen storage diseases. Everything here is important, whether it is the enzyme, the type of disorder or the clinical features. Everything is important. Von Gerk's disease, glucose 6-phosphatase deficiency. There is a type 0 glycogen storage disease also, that is glycogen synthase defect. Now, in Von Gerk's and Cory's, there is similar clinical features, but the enzyme defect is totally different. In Von Gerk's, it is the enzyme defect of glucose 6-phosphatase. In Cory's disease, it is the defect of liver and muscle debranching enzyme. Now, in glucose 6-phosphatase deficiency, and how will you differentiate it from Cory's? Both will present with hypoglycemia, both may hepatomegaly can be seen, both can have ketosis. But if you see in the question lactic acidosis and hyperuricemia, then it is Von Gerk's disease. If it is not mentioned or if their levels are normal, then it is Cory's disease. So by and large, that can be the criteria for deciding. However, if they have some other history which is suggestive of Von Gerk's disease, if they are mentioning anything except this, right, that also we have to take into account. Out of glycogen storage diseases, everything here is important. I cannot choose between them. Pompey's, enzyme defect, lysosomal acid maltase, glycogen ka accumulation will cause death in a child of less than 2 years of age. Then Anderson's, also known as amylopectinosis. It is a branching enzyme defect. Hepatosplenomegaly, accumulation of branching enzyme with few branch points. This also caused death within 1 to 5 years of age. Then we also have HERS disease. HERS is deficiency of the enzyme liver phosphorylase. This is a well tolerated disease. By and large, patient might not even know that he or she is suffering from HERS disease. Taruis is muscle and RBC ka PFK1 defect. This is poor exercise tolerance. If you see this and there is a picture of glycogen storage disease, what will be your answer? Think. I am giving you only this and I am just giving you a hint that it is between glycogen storage disease. It is myoglobinuria, cola colored urine or dark colored urine, because there is not enough of energy coming from the breakdown of muscle glycogen. So it will come from the breakdown of myoglobin, the proteins in the muscle, and that will result in rhabdourine. This galactosemia, another very important topic, has been asked so many times. Classical galactosemia is the enzyme defect galactose 1-phosphate uridyl transferase defect. It results in oil drop cataract as shown. Images can be given, enzyme can be asked, the clinical picture of poor feeding, or as soon as breastfed is given to the child starts vomiting, diarrhea, liver failure, all those things can be mentioned. Then alcohol. Everything about alcohol metabolism is important. Ethanol to acetaldehyde to acetic acid, everything here is important. When ethanol is converted to acetaldehyde and then to acetate, you need enzymes, alcohol dehydrogenase and acetaldehyde dehydrogenases. These enzymes require zinc. These are zinc dependent enzymes. Everything for alcohol metabolism is important. There will be high NADH to NAD ratio. बहुत ज़्यादा NADH is formed when ethanol is consumed, and this will shift the reactions in a direction that NADH gets consumed. For example, more of pyruvate will be converted to lactic acid. So the reaction shifts in a direction in which pyruvate gets consumed. Under lipid metabolism, the most important topic is actually lysosomal storage diseases, the sphingolipidosis. There will be a question related to any of these enzymes and disorders and clinical features. This you have to remember. Everything here is important. Then Gauchers, out of them also, Gauchers, there will be accumulation of glucocerebroside, low blood platelet count. The lethargy is due to anemia, hepatosplenomegaly, skeletal abnormalities can be seen. There is erosion of long bones, and successful ERT is available for Gaucher's disease. Of all the sphingolipidosis, ERT is possible theoretically for everything, but practically it is seen for Gaucher's and for Fabry's, of which Gaucher has a very high success rate. Now, all these sphingolipidoses are autosomal recessive condition except Fabry's. Fabry's is the only X-linked disorder. If you see this is a repeat question. So many times it has been asked, what is the enzyme defect? It is beta glucocerebrosidase. What will accumulate? Glucocerebroside, crumpled tissue paper appearance, wrinkled tissue paper appearance. Very important question. Then Niemann-Pick. It is an autosomal recessive lysosomal storage disease. All of these are lysosomal storage diseases. All of them are autosomal recessive except Fabry's. Enzyme defect, sphingomyelinase. Accumulating compound, sphingomyelin. Two key clinical features, hepatosplenomegaly and cherry red spot on macula. On biopsy, you will find the foam cells. So that is the characteristic of Niemann-Pick. So if you see something like this, this is a foamy histiocyte, and here you will find cherry red spot on macula. Tay-Sachs. Tay-Sachs is a disease of GM2 ganglioside accumulation due to hexosaminidase A enzyme defect. You will find here onion skin lysosomes. Now, even this presents with cherry red spot on macula, but there is no hepatosplenomegaly seen. Under lipoproteins, everything by and large is important. Particularly two most important enzymes is lipoprotein lipase and hormone sensitive lipase. Chylomicron, VLDL, LDL and HDL. Now, chylomicron has a very high lipid content. Lowest lipid content is in HDL. HDL has a very high protein content, because of which it has maximum electrophoretic property. The concentration of the various fatty acids, triacylglycerol is as this. You will find that chylomicron is rich in exogenous or dietary triacylglycerol. VLDL is rich in endogenous triacylglycerol. LDL is rich in cholesterol. HDL, particularly there is a variant of HDL known as pre-beta HDL that is rich in phospholipids. Under one more thing additionally to this, you have to revise type 1 and type 2 hyperlipoproteinemias. In type 1 hyperlipoproteinemia, it is deficiency of the enzyme LPL, lipoprotein lipase, which requires a must activator ApoC2. In type 2 hyperlipoproteinemia, it is LDL defect. It is LDL receptor defect. This receptor has two binding sites, one for binding of ApoE, another for binding of B100. E is normal, सिर्फ mutation of B100 occurs. Now, अब होता क्या है, क्योंकि B100 is mutated and the only lipoprotein which has B100 is LDL. So LDL will increase in circulation. That is why type 2 is associated with coronary artery disease. In type 1, triacylglycerol will increase and that is associated with pancreatitis. Eruptive xanthomas, mainly in type 1 and mainly in type 3. Tendon xanthomas, mainly in type 2. Under protein metabolism, anything related to phenylalanine, phenylketonuria, tyrosine, tryptophan, these three are most important aromatic amino acids. But nowadays, there is some questions on sulfur containing amino acids also, cysteine and methionine. So do not miss on cysteine and methionine while revision. But kahi pe bhi tyrosine, tryptophan, phenylalanine is coming, that is all important. Then, if you see a symmetrical dermatitis, that is pellagra dermatitis, it can be due to tryptophan deficiency seen in Hartnupp's disease. So, if you see symmetrical dermatitis, it is Hartnupp's disease. Alkaptonuria, homogentic acid oxidase defect. Tyrosinemias, all tyrosinemia, 1, 2, 3, all of them are important. They are all poor prognosis. One is fumarate acetoacetate hydrolase defect. 2 is tyrosine transaminase defect. 3 is para-hydroxyphenylpyruvate hydroxylase ka defect. Any of these, if defective, will result in 1, 2, 3 in that order just we said. Now, tyrosinemias are by and large poor prognosis and they cause hepatocellular carcinomas. Now, this is a characteristic pellagra-like rash. See that it is always symmetrical. If somebody is having rash on this side, similar rash is seen on this side as well. Then, ochronosis. It is associated with alkaptonuria. It can be shown like this, which is cartilage getting blackened, or skin discoloration like this, ochronosis, or it can be sclera discoloration. All of these are due to accumulation of homogeneticic acid, which is converted to benzoquinone acetate, Benzoquinone acetate is black in color. Homogeneticic acid to bichara colorless hai. So it does not form black precipitate. But when it accumulates, benzoquinone acetate is formed, that is black in color. Then under enzymes, I want to discuss just two things. Competitive, this will be there in the examination. You can either get a graph or they can tell you about the values of Km, whether the Km is increasing or Vmax is same, whatever is happening to Km or Vmax. But in the examination, if you see a cross is for your competition. And if in the examination you see a V is for victory. So competitive enzyme inhibitor, Km will increase, Vmax remains same. Now in this graph, you will see V, and V is for victory for non-competitive enzyme inhibition. When there is victory, there is no competition. So this is non-competitive enzyme inhibitor. Km same, Vmax will decrease. Vitamins में हर चीज important है. It is very difficult to decide in vitamins. So I have chosen the most important image-based questions for vitamins. This is hemorrhagic disease of newborn. This is an internal hemorrhage shown due to vitamin K dependent deficiency of carboxylation of factor 2, 7, 9 and 10. इसके अलावा भी प्रोटीन्स होते हैं जिसको विटामिन के डिपेंडेंट कार्बोक्सिलेशन चाहिए. Like we have vitamin K dependent carboxylation, gamma carboxylation for protein C, protein S, osteocalcin, osteonectin. Then if this kind of an image is given and I give you history जहाँ पे patient को I say that it is having measles like rash and patient को Koplik spots is seen, which is confirmatory of measles. Which vitamin you will give? It is vitamin A supplementation. Vitamin A is used in even in the treatment of ALL. So it is a anti-carcinogenic hormone as well. Then the illustration here shows that there is clear cytoplasm due to lipid accumulation as a result of A-beta lipoproteinemia. Now this is a patient who is not able to form B48 and B100. B48 is required by which lipoprotein? Yes, you are right, it is formed by chylomicron. So chylomicron will not be formed. That means agar chylomicron nahi bana to fat soluble vitamins will not be absorbed. So it is deficiency of any of A, D, E, K. Kabhi bhi there is malabsorption. Anything which affects the intestinal gut will cause less of chylomicron or defect in chylomicron formation. As a result, vitamin A, D, E and K will not be absorbed. Then vitamin D synthesis. The most important enzymes are present in liver and kidney. The photolysis step does not require any enzyme. It will convert 7-dehydrocholesterol directly to cholecalciferol. Active form, you know, it is 1,25-dihydroxy cholecalciferol. Deficiency will cause rickets in adults, osteomalacia. Scurvy is due to deficiency of vitamin C requiring for the enzyme prolyl hydroxylase. Prolyl hydroxylase को दो चीजें चाहिए, and that is vitamin C and iron. So this vitamin C and iron, if deficient, particularly vitamin C deficiency, will cause scurvy. Poor wound healing is also associated with vitamin C and along with vitamin A. These two are associated with poor wound healings. If there is beriberi, that is due to peripheral neuropathy. Wet beriberi complicated with edema. Then chillosis, that is at the angle of mouth there will be cracking, and that is chillosis. B2 deficiency. Symmetrical dermatitis occurring at the neck region, Castle's necklace, and this is vitamin B3, also known as nicotinic acid. Then B12 is required for 3 enzymes, 2 of which are most important, which we have shown here: homocysteine methyltransferase and methyl malonyl CoA mutase. Besides this, there is a third enzyme, that is leucine amino acid mutase. This also requires vitamin B12. So B12, another very important vitamin, deficiency causes subacute combined degeneration. This is a segment of a spinal cord showing demyelination of both posterior and lateral column. Then hypersegmented neutrophils also are seen with vitamin B12 deficiency. Hyperpigmented knuckles are also seen with vitamin B12 deficiency. Spina bifida seen in a fetus, in a newborn whose mother was deficient in B9 or folic acid. Then under nucleotide metabolism, gout is important. Causes of gout is important. PRPP synthase overactivity. Gout can occur due to von Gierke's disease. HGPRTase deficiency, Lichnihan syndrome itself is important. Then it can occur due to, gout can be seen due to renal failure, somebody who is having cancer, overproduction, under excretion. But how will you diagnose this? You will take a synovial fluid aspiration and you will see it under light. If under light you see monosodium urate crystals, that will confirm your diagnosis. Lichnihan, important especially for the last 2-3 years. You see a question: X-linked disorder, mental retardation, characteristic self-mutilation behavior. There will be accumulation of hypoxanthine and guanine because the enzyme HGPRTase is deficient. Under molecular biology, there is a interest for PCR. You have to know the prerequisites for PCR. 5 prerequisites: magnesium, DNTP, Taq polymerase. We also need DNA primer. And what am I missing? The most important thing. Copy karoge kiska? Double stranded DNA. You have to have a double stranded DNA. Then these steps: denaturation, annealing and extension, and this keeps on rotating again and again. Then we have blotting techniques. Blotting mein last mein you will see it, you will blot it on nitrocellulose filter paper and then you will see it under X-ray. Southern blot for DNA, northern blot for RNA, western blot for proteins. Microarray, there is a recent interest in microarray from the question point of view also. Particularly this uses a hybridization technique. You have small chips, microarray, small wells, which is each chip has multiple wells and each well is having an oligonucleotide primer already attached to it. Whatever you want to study, you put inside it and then you will see whether it binds or not. Agar bind kar gaya, that means it will give some signal, right? Depending upon what we are seeing, what the oligonucleotide is, the signal will be given. But what it uses is important, that you will around 20 to 25 nucleotides will bind and give a signal, and that is microarray. So what technique it uses? Hybridization. Of complementary DNA. Cloning, you will have a recombinant DNA, chimeric DNA. A small part of the DNA will be the original DNA and a very small part will be introduced in it, which will be the new or the DNA of interest, or which will have the gene of interest. And under electron transport chain and oxidative phosphorylation, this is the most important slide. Complex 1 ka inhibitor, rotenone, amobarbital, also known as emital or phenobarbital, pyridine A. Then we have complex 2 ka inhibitor, that is malonate. Complex 3 ka inhibitor, antimycin, there is British anti-leucite. Complex 4 ka inhibitor, is cyanide, carbon monoxide, azide, and hydrogen sulfide. Complex 5 FOF1 का inhibitor oligomycin, particularly remember this one, and complex ATP ADP translocase. Once the complex 5 forms ATP, it will be translocated outside by this translocase, and this is inhibited by trictyloside and boncreic acid. In addition, we also have uncouplers, that is DNP, you have chlorcarbonyl polypeptide, that is polyphenol derivatives. These are also uncouplers. Out of this, remember particularly 2,4-dinitrophenol and 2,4-dinitrocresol. These are synthetic uncouplers. Natural uncouplers mein you will find thyroxine, long chain fatty acid, and most importantly thermogenin, which is present in brown adipose tissue. With this, we have covered the most important topics from the previous years. I wish you all the best. Thank you.
Wish you all a very good evening, guys. Just let me know if audio video is both phone. All good, right? Can we start a session? Great, guys. Great, guys. Great. Good evening, guys. Good evening. Oh my God. Waiting for your class since yesterday. Thank you so much. एक तो ये देख, एक तो आ जाता है, शुरू करो, कर रहा हूं भाई. इतनी शीघ्रता मत दिखा. ज्यादा शीघ्रता दिखाएगा तो शीघ्र पतन भी जल्दी होगा. Right? Done, guys. चलो, without wasting any time, let's start a session. We'll start with a good note. Let's start, guys. Let's start, guys. Everybody. सर सिर दर्द हो रहा है, गला दबा दूंगा फटाफट. चल स्टार्ट करते हैं सेशन का. बड़ी इमेजेस, डायग्नोसिस, फटाफट. लेट्स स्टार्ट. गुड इवनिंग ऑल ऑफ वन. थैंक यू सो मच बाबा, थैंक यू सो मच. ले लो लेट्स फटाफट. विच आर्टीरियोस्क्लेरोसिस. स्मार्ट लग रहे हो आज तो. पागल लगते वो हैं जो होते नहीं हैं. एवरीबॉडी फटाफट बोलते चलेंगे, टाइम वेस्ट नहीं करेंगे. विच आर्टीरियोस्क्लेरोसिस. हाइलीन आर्टीरियोलोस्क्लेरोसिस. थैंक यू सो मच बड़ी, थैंक यू सो मच. विच हाइपरटेंशन. बेनाइन हाइपरटेंशन. आप सबको पैथोलॉजी आती है. वी नीड टू बी श्योर. एक एक मिनट में डाल करेंगे. नेक्स्ट देखो बॉस. विच आर्टीरियोस्क्लेरोसिस. दिस इज अनियन अपीयरेंस. सो अनियन स्किन अपीयरेंस इज सीन इन मैलिग्नेंट हाइपरटेंशन. हाइपरप्लास्टिक आर्टीरियोलोस्क्लेरोसिस. जितनी एनर्जी मेरे में उतनी एनर्जी तुम्हारे. फटाफट चलने दो. राइट. डन गाइस, डन. एवरीबॉडी. विच स्टेन इज यूज्ड हियर. मैम आई विल स्पीक इन इंग्लिश ओनली. Only the problem is I don't know how to address Karamjale in English. If you know the English of Karamjale, do let me know. I'll be using that. I'll be more happy to use that. Stain, TTC stain. Pale areas means the infarcted areas. The session will go in English, right? Done. Next में देखो. Nodular thickening of temporal artery. I'll go with giant cell arteritis. Can you tell me the most specific symptom? Jaw claudication. Jaw claudication is the most specific symptom. Done, boss, done, boss, done. Let's look at the next one. Everybody, बता दो मुझे lungs में मिले. If you see cavitary lesions in the lungs, along with this special nose, saddle nose, I need your help. Cavitary lesions and saddle nose both are characteristic feature of Wagner's या Wagner's granulomatosis. लिखते चलेंगे. You don't have to write so quickly. Energy आपकी मेरी should be parallel, should match. Come on, which antibodies? CN का antibodies. Remember क्लास में पढ़ाया था 3C CN का cavitary lesion treat by cyclophosphamide. Right? Done. Next पे आते हैं. Everybody, what is this liver called as? Nutmeg liver. Red yellow is here. Nutmeg liver seen in chronic venous congestion liver. That is right heart failure. Chronic venous congestion liver. चलने दो. Do let me know if you have to reduce my speed. Everybody, now lungs biopsy, decrease cardiac output, dyspnea. And lungs के अंदर brown macrophages दे रखे हैं. My dear friends, lung biopsy पे brown macrophages. My diagnosis will be heart failure cells. So this is called as hemosiderin-laden macrophages seen in chronic venous congestion lung. So CVC lung में we have heart failure cells. CVC liver में we have nutmeg liver. Very good. Next पे आते हैं. Look at this image. Which stenosis? 5-year-old. History of sore throat. Elevated PR interval. Fish mouth stenosis. With this special nodule. सबको पता है RHD है. So it has to be Aschoff nodule. फटाफट बता दो अब क्या फेफड़े निकाल के बताऊं. Aschoff nodule and fish mouth stenosis both are feature of rheumatic heart disease. Then let's look at the vegetations now. एक मिनट बताते चलेंगे. Caterpillar cells and Hitchcock cells. Guys, Hitchcock cells are seen in again acute RHD. Caterpillar cells. Then vegetations है एक मिनट में. Small size vegetations along the line of closure. अरे rapidly will go boss everybody. RHD. Medium size along the line of closure will go with NBTE. Sir, this much large bulky vegetation, I'll go with infective endocarditis. अरे साहब both upper and lower cusp. Doctor साहब both upper and lower cusp. I told you lip man sac endocarditis. A man will hold your lip both upper and lower. Right? Done है. बढ़ते रहेंगे. पूरी पैथोलॉजी पढ़ाऊंगा in 30 minutes. So make sure you are there with me. Next, athlete collapsing on the field, increased ejection fraction. और इतना hypertrophied muscle है बॉस. इतनी banana shaped cavity है. अरे करम जलो बता दो diagnosis. HOCM. All the thickened mass with a banana shaped cavity, it has to be HOCM. अरे ये न्यूक्लियर दिख गया बॉस. It has to be boxcar nuclei. विदा लिखते चलो. Boxcar nuclei seen in HOCM. हमें पता है boxcar is HOCM. पर अगर निंजा स्टार आ गया तो I will remember. निंजा स्टार is in DCM. दिल मत तोड़ना. DCM की जीन भी बता दो. जब मैं नहीं थक रहा तुम भी नहीं थकोगे. DCM में टाइटिन जीन इज म्यूटेटेड. देयर इज म्यूटेशन ऑफ टाइटिन जीन. डन करते हैं. बता दो भैया. हिस्ट्री ऑफ साइकोलॉजिकल स्ट्रेस है और भैया एक जापानीज स्पॉट दे दी गई है. आई विल गो विथ व्हाट? टाकोसुबो कार्डियोमायोपैथी. लिखना नहीं है. आई एम श्योर यू नो दिस. सब कुछ आता है आपको. टाकोसुबो. एवरीबडी, व्हाट इज दिस अपीयरेंस? विच एन्यूरिज्म? अरे सर दिस इज ट्री बार्क अपीयरेंस. पर मुझे बताओगे क्या? हमें सब आता है. हम एग्जामिनर को पढ़ा के आ जाएंगे. ट्री बार्क अपीयरेंस इज सीन इन विच एन्यूरिज्म? सिफिलिटिक एन्यूरिज्म. क्लास में पढ़ाया था 3T ट्रिपोनिमा पैलिडम टर्शरी स्टेज ट्री बार्क अपीयरेंस. लिखते चलो, टाइम वेस्ट नहीं. कोई पढ़ेगा सब लिखेंगे. हिस्ट्री ऑफ वीजिंग, डिस्पनिया ऑन एक्सपोजर टू डस्ट. व्हाट आर दिस पिंक नीडल शेप्ड क्रिस्टल्स? Pink needle shaped crystals are charcot laden crystals. I want you to answer me. Charcot laden crystals are made up of. मैंने कहा था 4 है तो तुम भी एक नीडल नंबर याद रख लो. 4 के साथ 10 याद रख लो. गैलेक्टिन 10. 4 के साथ 10. गैलेक्टिन 10 4 गल्ला करिए प्यार दिया देन व्हाट आर दिस स्पाइरल्स कॉल्ड एज कर्शमैन स्पाइरल्स दिस आर कर्शमैन स्पाइरल्स और मैंने कहा था एवरीबॉडी कम ऑन दिस ब्लैक लंग this is diagnosis is anthracosis and if you remember dust cells are seen dust cells are black macrophages फटाफट मुझे बता दो लंग बायोप्सी पे ब्राउन मैक्रोफेजेस है that are hemosiderin laden macrophages heart failure cells lung biopsy पे black macrophages है I'll go with anthracosis called as dust cells next पे चलेंगे everybody lead pipe industry pleural thickening and NEET PG's favorite brown dumbbell shaped bodies मैं नहीं time waste कर रहा I know systemic pass से 10 to 15 questions will be there and you won't waste even 10 to 15 seconds on those questions I can promise you that बढ़ते रहेंगे ferruginous bodies this is just to tell you that how I've compiled everything in systemic path right here and I'm sure all of you remember this is just to raise your confidence you know everything भैया dyspnea with bilateral hilar lymphadenopathy what are these bodies called as सर रहने दो सर हमें पता है टाइम मत वेस्ट करो आप हमें सिस्टमिक पैथ पढ़ाओगे मैं अपनी पे आ गया मैं आपको पढ़ा दूंगा सिस्टमिक पैथ ज्यादा हीरो मत बनो पढ़ा के एवरीबॉडी व्हाट आर दिस बॉडीज ब्लू वॉल्स ऑफ कैल्शियम दीज आर शोमैन बॉडीज एस्ट्रॉइड बॉडीज शोमैन बॉडीज बोथ आर फीचर ऑफ sarcoidosis sarcoid यही एनर्जी keep that energy high guys next question which lung cancer sir which lung cancer सर मुझे ग्लैंड फॉर्मेशन दिख रहा है तो मैं एडिनोकार्सिनोमा में जाऊंगा सर अगर उसने आईएससी पूछ ली तो आई विल रिमेंबर मोस्ट स्पेसिफिक आईएससी ऑफ एडिनो इज नेप्सिन मैंने टैन बताया था टीटीएफ एएल के नेप्सिन रिमेंबर नेप्सिन इज फॉर एडिनोकार्सिनोमा नेक्स्ट सर सब कुछ ब्लू दिखे तो सर सब कुछ ब्लू दिखे तो मैं स्मॉल सेल कार्सिनोमा पे आऊंगा आईएससी सर आपने अच्छे से पढ़ाया था साइनेप्टोफाइसिन इट्स अ न्यूरो एंडोक्राइन ट्यूमर साइनेप्टोफाइसिन क्रोमोग्रानिन बॉम्बे सिन CD56 दिस ईयर एफएमजी एग्जाम क्वेश्चन कोई तो बता दो मुझे स्मॉल सेल कैंसर का पैरान्यूप्लास्टिक सिंड्रोम डायरेक्ट क्वेश्चन दिस ईयर एफएमजी दे कैन रिपीट दिस इन नीट पीजी इट हैज टू बी SIADH मैंने कहा था ना सारे एस फीचर सेंसिटिव साइनेप्टोफाइसिन एंड SIADH पैरानियोप्लास्टिक सिंड्रोम है नेक्स्ट पे आते हैं सर रीनल सिस्टम पे आया सर मैं रीनल सिस्टम में मुझे क्या दिख रहा है हिंट दे रखी है चाइल्ड विद कोला कलर यूरिन और मुझे कैसा हम्प दिख रहा है मुझे दिख रहा है सब एपिथेलियल हम्प सर क्या मुझे टाइम वेस्ट करना है अरे अ चाइल्ड विद कोला कलर यूरिन एंड सब एपिथेलियल हम्प सर क्या बात कर रहे हो सर मैं इस पे टाइम वेस्ट करूंगा आई विल गो विद PSGN इन द एग्जाम सर आई विल गो विद PSGN इन द एग्जाम सर नेक्स्ट क्वेश्चन सर एडल्ट विद एक्यूट ऑनसेट रीनल फेलियर और मुझे ये दे रखा है टूटी हुई बेसमेंट मेम्ब्रेन आई कैन सी रप्चर ऑफ बेसमेंट मेम्ब्रेन सर आपने हमें अच्छे से पढ़ाया था सर R फॉर रप्चर R फॉर RPGN R for rupture R for RPGN राइट डन देन गेंसन अगर ये इमेज दिख गई सर मुझे नहीं पता मैं चांद तारे तोड़ के लाऊंगा क्या नहीं पर सर ये वाला चांद मैं पहचान लूंगा सर इफ आई सी क्रिसेंट फॉर्मेशन आई विल अगेन गो विद RPGN इन द एग्जाम RPGN इन द एग्जाम सॉर्टेड है नेक्स्ट पे चलते हैं एवरीबॉडी देन फर्स्ट इमेज इज नॉर्मल सेकंड इज इफेसमेंट एवरीबॉडी ये इफेसमेंट अगर बच्चों में दी जाए इफेसमेंट ऑफ पोडोसाइट्स इन चिल्ड्रन आई विल गो विद मिनिमल चेंज डिसीज सेम इमेज फ्रॉम एडल्ट्स आई विल गो विद मेम्ब्रेनस ग्लोमेरुलोपैथी MG-पैथी right effacement is given first one is normal to compare to help you to remember in child minimal chain disease same is in adults especially history of malignancy hai so I'll go with MG-पैथी डन है नेक्स्ट पे आते हैं और रे एडल्ट विद मैलिग्नेंसी एंड प्रोटीन यूरिया एडल्ट विद मैलिग्नेंसी हिस्ट्री आ गई हम सबने अच्छे से पढ़ा है मैंने ट्रिक से पढ़ाया था MG-पैथी कैन यू प्लीज टेल मी व्हाट इज दिस अपीयरेंस कॉल्ड एज डार्क लाइट एरिया आई एम वेटिंग फॉर योर रिस्पॉन्स फटाफट मुझे बता दो दिस इज स्पाइक एंड डोम अपीयरेंस एंड स्पाइक एंड अरे वेरी गुड गाइस अरे वेरी गुड गाइस दिस इज MG-पैथी यू गाइस आर ब्रिलियंट दिख रहा है मुझे फाड़ के आने को पूरी तैयार डन है MG-पैथी मेम्ब्रेनस ग्लोमेरुलोपैथी जब इतना अकड़ रहे हो बता के तो प्लीज थोड़ा सा और अकड़ जाओ ये बता दो ना कौन सा अपीयरेंस दिख रहा है व्हाट इज दिस अपीयरेंस कॉल्ड एज When you see 2-2 basement membrane, guys, 2-2 basement membrane means which appearance? Tram track appearance. Everybody, tram track appearance is the feature of, मैंने कहा था 2-2 membrane है तो membrano proliferative glomerulonephritis. अरे brilliant guys, membrano proliferative glomerulonephritis. 2-2 basement membrane, membrano proliferative glomerulonephritis. अरे मैंने कहा था history of HIV है और focal part pink दिखे, focal part दिखे. Sir, I will go with FSGS. एक छोटा सा पार्ट, पूरा एंटायर ग्लोमेरुलस इज नॉर्मल, अ फोकल पार्ट इज पिंक, दिस इज फोकल पिंक फाइब्रोसिस, फीचर ऑफ FSGS. FSGS सर, डायबिटिक पेशेंट दिया हुआ है और पिंक पिंक कलर के नोड्यूल दिख रहे हैं सर, डायबिटिक पेशेंट पिंक पिंक कलर के नोड्यूल मिल रहे हैं कि दिस इज किमल स्टील विल्सन नोड्यूल और नोड्यूलर ग्लोमेरुलोस्क्लेरोसिस. नोड्यूलर ग्लोमेरुलोस्क्लेरोसिस. अरे यार क्या कर दिया तुमने, आग लगा दी, बुझने में देना थर्ड तक. क्विमल्सन वॉल्सन नोड्यूल. नेक्स्ट पे आते हैं सर, हिस्ट्री ऑफ मलार रैश है सर, और मुझे ना ऐसे ना वायर के लूप्स दिख रहे हैं. हिस्ट्री ऑफ मलार रैश है एंड आई कैन सी वायर लूप लीजन. सो 1 मिनट में प्लीज मुझे बता दो, आई वॉन्ट यू टू रिस्पॉन्ड गाइस. वायर लूप लीजन विच क्लास? अरे विच क्लास? Class wire alphabet, 4 alphabets. This is class 4. Class 4 lupus nephritis, nodular glomerulosclerosis. हाँ, this response. No, you don't have to write. Just keep on writing. Just keep on typing. Ready. This will raise only your confidence. I have to got confident in you. I'm sure. फाड़ के आओगे. WTF. बस यही चाहिए था बॉस. History of malignant hypertension. 3 days back, FMGE exam. Students only said one thing. सर आवाज आ रही थी, चीख रहे थे आप हमारे एग्जाम में. करम जले, ये है आंसर. नीट पीजी में सेम होगा. प्लीज रिमेंबर malignant hypertension. What is this appearance called as? मेरी आवाज कानों तक जाने दो. एग्जाम में यही आवाज आएगी, फ्ली बिटन अपीयरेंस, मैलिग्नेंट हाइपरटेंशन. बट अगर इमेज है जहां पे व्हाइट ग्रैन्यूल्स दिख रहे हैं, दिस इज हिस्ट्री ऑफ बेनाइन हाइपरटेंशन है, देन दिस इज कॉल्ड एज लेदर ग्रेन किडनी. दिस इज कॉल्ड एज लेदर ग्रेन किडनी सीन इन बेनाइन हाइपरटेंशन. मैलिग्नेंट में फ्ली बिटन किडनी, बेनाइन में लेदर ग्रेन किडनी. और रे सर, सिराइल पाइयूरिया है और ये इमेज दे रखा है. 1 मिनट में बता दो, काय तो कुट्टी कुट्टी करने का, कुट्टी नहीं करने का, पुट्टी करने का, पोट्टी नहीं, पुट्टी करने का. तो दिस इज पुट्टी किडनी. फीचर ऑफ ट्यूबरकुलोसिस, स्टाइल पाइयूरिया की हिस्ट्री है. दिस इमेज इज गिवन, यू विल गो विद पुट्टी किडनी. डन है. नेक्स्ट किडनी. ब्रेस्ट कैंसर पे आ गए सर. ब्रेस्ट कैंसर सर, प्यूडी ऑरेंज है सर. प्यूडी ऑरेंज, कैन यू टेल मी? टाइम टू इंप्रेस मी गाइज. प्यूडी ऑरेंज इज सीन इन इन्फ्लामेटोरी कार्सिनोमा. इन्फ्लामेटोरी कार्सिनोमा. प्यूडी ऑरेंज मोस्ट कॉमन इन्फ्लामेटरी कार्सिनोमा. नेक्स्ट इमेज देख के मुझे बता दो, अरे व्हाट इज दिस पैटर्न कॉल्ड एज? मैं नहीं लिखूंगा, यू विल राइट फॉर मी. व्हाट इज दिस स्पेशल पैटर्न कॉल्ड एज? सर दिस इज इंडियन फाइल पैटर्न. दिस इज इंडियन फाइल पैटर्न. अरे बता दो विच कैंसर. आई एम नॉट वेस्टिंग टाइम ऑन दिस. This is lobular breast carcinoma. People have studied from me, they know this. Lobular breast carcinoma, SBI Bank. Signet ring cells, bilateral breast tumor and Indian file pattern. Indian file pattern. तो फिर ये भी बता दो बॉस, what are these cells called as? These are signet ring cells. I'm sorry, I can't go slowly. I don't want you to waste time on systemic path. You have all other remaining 18 subjects to waste time on. For systemic path, 10 to 15 questions sorted है. There will be at least a single word where you will hear my voice. अरे ये टिक कर बॉस, ये लिखा एग्जाम में. Signet ring cells. Everybody come on. Signet ring cells स्टमक में मिले तो write it down for me. मैं नहीं मानूंगा तुम्हें आता है. Diffuse gastric carcinoma. Signet ring cell ओवरी में मिले तो Krukenberg tumor. डन है. नेक्स्ट पे आते हैं. और सर इतना क्लियर एरिया सर, ब्रेस्ट कार्सिनोमा की स्लाइड है. दिस मच क्लियर एरियाज. दिस इज ऑल म्यूसिन. सो दिस इज ऑल्सो नोन एज म्यूसिनस कार्सिनोमा और कोलोइड कार्सिनोमा. बस बॉस यही आग लगानी है. दिस इज कोलोइड कार्सिनोमा. चलने दो, तुम्हारा मन है नहीं है, मैं पढ़ा के मानूंगा फटाफट. 45 ईयर ओल्ड फ्रंटल लोब मास. कौन सा ट्यूमर है? ये बटरफ्लाई ट्यूमर है. याद करो, स्नेक एंड बटरफ्लाई इज फॉर ग्लायोब्लास्टोमा. राइट, डन. नेक्स्ट देख लो. अरे स्नेक भी आ गया. करम चलो, कौन सी नेक्रोसिस आ गई? सर्पेंटाइन नेक्रोसिस आ गई. फीचर ऑफ ग्लायोब्लास्टोमा. दिल मत तोड़ना, पेलिसेडिंग इज ट्रू और सूडो? सूडोपेलिसेडिंग सर सर्पेंटाइन नेक्रोसिस है, सूडोपेलिसेडिंग है. आई एम नॉट वेस्टिंग टाइम ऑन दिस. दिस इज ग्लायोब्लास्टोमा. बटरफ्लाई एंड स्नेक, यस G5 पॉजिटिव ग्लायोब्लास्टोमा. तो सर अगर इमेज आ गई, हिस्ट्री ऑफ टिनिटस और वर्टिगो आया, and this is true palisading. Can you please tell me what are these true palisading wali bodies called as? These are Verruque bodies. History of tinnitus and vertigo hai, Verruque bodies hai. Boss, I am not wasting time on this, boss. This has to be schwannoma, which is schwannoma has pseudo palisading, true palisading. True. Remember true palisading 2 3 B C and SC. ट्रू पेलिसेडिंग. BC बेसल सेल कार्सिनोमा, SC फॉर श्वानोमा. आग लगा दी तुमने. चलो नेक्स्ट है चाइल्ड विद सेरिबेलर मास एंड दिस आर इमेज गिवन. व्हाट आर दिस पिंक रोड शेप्ड इंक्लूजन्स कॉल्ड एज? पिंक रोड शेप्ड इंक्लूजन्स आर कॉल्ड एज रोजेंथल फाइबर्स. सर रोजेंथल फाइबर है. यू गिव अ गर्ल रोज टू स्लीप विद हर ऑन pillow. It is called as pilocytic astrocytoma. Can you tell me which ISC it is positive for? Any glial cell tumor will be positive for GFAP. आग लगा दी. नेक्स्ट पे चलते हैं. फीमेल विद हिस्ट्री ऑफ हेडेक. अरे पर्पल पिंक राउंड बॉडी. सर आई एम नॉट वेस्टिंग टाइम ऑन दिस सर. लास्ट ईयर नीट PG. Samoma bodies in the brain. Sir, I'm not wasting time on this. Meningioma hai boss ye. Meningioma hai boss ye. Let's go to the next one. Arre sir, 45 year old male, frontal lobe mass and seizures. Frontal lobe mass and seizures and what do you see? Arre perinuclear clearing hai sir. Around every nucleus I can see. I can see what? Fried egg appearance boss. Sir, I can see small capillaries, sir. Chicken wire capillaries, sir. सर फ्राइड एग अपीयरेंस चिकन वायर कैपिलरीज. अरे सर अब और क्या दोगे सर? अंडे देना रह गया, वही दे दो. तो मैंने आपको क्लास में पढ़ाया था. दिस इज अंडे वाला सेल. ओ फॉर अंडा. अंडा विल कम, अंडा मीन्स एग. एग विल कम फ्रॉम चिकन. सो एग एंड चिकन इज फॉर ओलिगोडेंड्रोग्लायोमा. फाड़ दी. नेक्स्ट किसकी नहीं पेपर की? चलो मेरी नहीं, रोजेट्स. फटाफट बता दो. पिंक ल्यूमेन है. पिंक ल्यूमेन है तो ट्रू है या सूडो है? ट्रू है या सीडो? 1 मिनट में बता दो सर. अगर मुझे पिंक ल्यूमेन दिखेगा तो ये दीस आर सूडो रोजेट्स. सर मुझे ना सिखाओ, मैं आपको पढ़ा दूंगा. होम में राइट रोजेट. वैसे भी आपके बच्चों को हम ही पढ़ाएंगे सर. होम में राइट रोजेट्स सीन इन. होम में राइट रोजेट सीन इन men syndrome. I told you men are all liars. Medulloblastoma, Ewing sarcoma, neuroblastoma. Men are liars. Home right rosettes are pseudo rosettes because they have a pink lumen. But sir, if they give you this lumen, then it has to be empty lumen, white lumen. It is Flexner Wintersteiner, sir. This has to be Flexner Wintersteiner, sir. And अरे हमें ना बताओ सर, हमें अच्छे से पता है. We will find in the option. The answer has to be retinoblastoma. Answer has to be retinoblastoma. Done है. Next पे आ जाओ. अरे from one beautiful organ to another beautiful organ. नहीं, testis है, not beautiful. Depends on the taste. So testicular tumor, history of undescended testis, and again fried egg appearance. मुझे वैसे भी आपको पता है undescended testis में most common testicular tumor with the fried egg appearance. Again, I can see perinuclear clearing, sir. I can see pink fibrous septa, sir. Tell me, boss. It has to be seminoma. दिल मत तोड़ना, सेमाइनोमा का मुझे बता दो. ISC मार्कर. I told you. कलरफुल किट पहन के विच डेट को? 3rd-4th अक्टूबर को. किससे मत मिलने जाना? नाना जी से. सी किट ऑक्ट्री फॉर नैनो जी. दिस इज seminoma. This is seminoma, right? Tumor marker. There are 3, but out of these 3, beta HCG, PLAP and L. ये तो मत भूल जाना, पाप लगेगा. LDH level. Tumor marker is LDH and specific ISC C-KIT, OCT34 and NAN-OG. Done है. बॉस नेक्स्ट पे देखो. अरे सर डे फीवर डिट्टो सेम इमेज वाज आस्क्ड एवरीबॉडी. बाल और टीथ दिख रहे हैं. दिस हैज टू बी टेराटोमा, सर. I don't know why this sir is coming like this. I had FMG class today. The way that girl was asking, I think I have replicated that, you know. The girl was asking the same question. Every break she used to come and say, sir, ये वाला क्वेश्चन बताओ ना. सर आई थिंक आई हैव रेप्लिकेटेड दैट इन मी, मेरा वही सर निकल रहा है बार बार। बड़ी कम ऑन, ट्यूमर मार्कर, सेंट्रल ब्लड वेसल, सेंट्रल ब्लड वेसल सराउंडेड बाय ट्यूमर सेल, सेंट्रल ब्लड वेसल सराउंडेड बाय टू ट्यूमर सेल्स। अरे सर कौन सी बॉडीज है बॉस है? दिस आर शिलर डुअल बॉडीज। यस एवरीबॉडी, मैच्योर्ड डायरेक्टोमा, डर्मोइड सिस्ट, ओवरिटिस डर्मोइड सिस्ट, राइट? डन है बॉस, डन। तो शिलर डुअल बॉडीज, ट्यूमर सीन इन यॉर्क सैक ट्यूमर। कम ऑन गाइस, यॉर्क सैक ट्यूमर का ट्यूमर मार्कर, सर ट्यूमर मार्कर इज अल्फा फीटोप्रोटीन। आई टोल्ड यू, रिमेंबर यॉर्क सैक का सैक, कम ऑन यॉर्क सैक का सैक, सैक फर मूड मत बनवाओ सर, मैं मूड बनवा रहा हूं, करमजल अभी नहीं, पढ़ाई पे 3 अगस्त के बाद, ये सब 3 अगस्त के बाद है। आफ्टर 3 अगस्त, सैक ट्यूमर, शिलर डुअल बॉडीज, अल्फा फीटोप्रोटीन एंड चिल्ड्रन, इट्स द मोस्ट कॉमन ट्यूमर इन चिल्ड्रन, राइट? डन गाइस, डन। नेक्स्ट पे आते हैं। अरे सर, सर छोड़ो, अब तो मैम की ओवरी आ गई, मैम की ओवरी में पिंक ल्यूमन है, मैम की ओवरी में पिंक ल्यूमन है। एवरीबॉडी कॉल एक्सनर बॉडीज, कॉल एक्सनर बॉडीज, आईएनआईसीटी में आता, वेरी लाइकली टू कम, ग्रैनुलोसा सेल ट्यूमर ओवरी, कॉल एक्सनर बॉडीज, पिंक ल्यूमन वाली बॉडीज। सर ब्रेन से है तो इट इज होमेराइट रोजेट्स, सर इफ दिस इज इन द ओवरी इट हैज टू बी कॉल एक्सनर बॉडीज। मुझे फटाफट बता दो, कोई तो इंप्रेस करने वाला है जिसने ये आंसर किया। सर हो गया सिलेक्शन, फटाफट बता दो मुझे, ट्यूमर मार्कर ऑफ ग्रैनुलोसा सेल ट्यूमर ओवरी, एनीबॉडी? वेटिंग, इट इज इनहिबिन पॉजिटिव। I told you, right? Inhibit calling your ex-girlfriend 99 times for coffee. ISC, we all know CD99. CD99 in brain has to, in bone has to be Ewing. CD99 in ovary has to be granulosa cell tumor ovary. Done है. Next में आ जाओ. अरे this year, day before yesterday, FMGE exam question. मैंने कहा था लबों से लबों को मिलाओ, पर ऐसे लबों को मत मिलाओ, क्योंकि ऐसे लबों को बनाओगे तो क्या हो जाएगा? PJ syndrome. PJ syndrome, I told you, remember the name, perioral melanosis, jejunal polyps, and कौन सी जीन है बॉस? PJ में कौन सी जीन है? It has to be STK11 gene mutation, has to be STK11 gene mutation। देखो करमजली कैसे हंस रही है, एग्जाम में आ जियो देवी तो हम भी हंस लेंगे तुझे देख के। चलो नेक्स्ट पे। अरे सर, दिस इज क्रिसमस ट्री पैटर्न, दिस इज आर्बोराइजिंग ट्री पैटर्न। और मैंने कहा था क्रिसमस पे ही सेंटा ने कौन सी कार गिफ्ट की थी? जैगुआर। सो प्यूट्स जैगुआर सिंड्रोम, जीन हमने लिख ली है, इट इज STK11 जीन म्यूटेशन। सर आगे चलते हैं, सर हमें सब आता है, टाइम वेस्ट मत करो। सर मैल एब्सॉर्प्शन सिंड्रोम है, पेशेंट डायरिया के साथ आया है सर, और मुझे एक कैंथोसाइट्स दिख रहे हैं, डायरिया के साथ आया है, एक कैंथोसाइट्स मिल रहे हैं। सर बता दो ना प्लीज, इट हैज टू बी ए बीटा लाइपोप्रोटीनीमिया। डायरिया विद ए कैंथोसाइट द ब्लड हैज टू बी ए बीटा लाइपोप्रोटीनीमिया, राइट? डन है। कौन सी जीन? बेटा नहीं हो सकता। करमजिली ने क्या करवाया था अपना? MTP। नेक्स्ट में आते हैं सर, डायरिया का पेशेंट है, मुझे पास पॉजिटिव पिंक मैक्रोफेजेस दिख रहे हैं, पास पॉजिटिव पिंक डायरिया के साथ आया है। 1 मिनट में बता दो, इफ यू कुड रिकॉल दिस थिंग ऑल्सो, ट्रस्ट मी यूर ऑन राइट ट्रैक, ट्रस्ट मी यू आर ऑन राइट ट्रैक। डन है बॉस। नेक्स्ट विप्पल्स डिसीज। आगे चलते हैं बॉस, नेक्स्ट पे। एवरीबडी अगेन डायरिया का पेशेंट है सर, नॉर्मल विल्लाई, ये नॉर्मल विल्लाई है, बट अगर मुझे विल्लाई की फ्लैटनिंग दिख जाए तो आई गो विद, कम ऑन, विल्लाई एट्रोफी दिख जाए तो देन आई गो विद व्हाट? सीलियक डिसीज। कैन यू टेल मी द सीलियक डिसीज की एंटीबॉडीज? आई होप यू रिमेंबर, हमने क्लास में पढ़ा था, गेट एंटीबॉडीज, एंटी ग्लाइडिन, एंटी एंडोमाइसियल and anti-TTG antibodies. So 3 antibodies, all these are IgA antibodies, glidin, endomysial and TTG antibodies. Done है boss, done है। Next में sir thyroid cancer पे आगे sir, there has to be one question on thyroid cancer. Guys, first of all, अरे sir, this is orphan NEI nuclei sir, orphan NEI nuclei दिख रहा है। Can you please tell me the route of spread? This year INICET question, route of spread is lymphatic route। palpable कौन से lymph node? cervical lymph node sir, this is palpable cervical lymph node boss। it has to be follicular carcinoma, orphan NEI nuclei, best prognosis, remember all the P feature, palpable lymph node, psammoma bodies, pseudo inclusion, prognosis best, most popular, post radiation. All P wala feature is for papillary carcinoma. Can you tell me the gene involved? Yes, it occurs because of BRAF gene mutation. It occurs because of post lymphatic route. Sir, thyroid mass है, मुझे सब कुछ पिंक पिंक दिख रहा है, बेबोदिया गल्ला पिंक पिंक, और थायराइड अगर पिंक पिंक दिख जाए, so everybody, amyloid in thyroid means only one cancer, that is medullary carcinoma thyroid. You have to impress me. Medullary carcinoma thyroid tumor marker is calcitonin. It has to be calcitonin. Right? Done hai. Then done. Next पे आता है everybody. Last images. Can you tell me the right as hematogenous route? Follicular carcinoma thyroid. Remember, it has hematogenous spread. That will bring us to the last slide. Brain से है. Everybody, history of senile dementia. And this flame shaped filaments. This flame shaped filament are neurofibrillary tangles. These flame shaped filaments are neurofibrillary tangles. And मेरे भाइयों, मुझे बता दो, neurofibrillary tangles are these flame shaped filaments. This is seen in Alzheimer's disease. Flame shaped filament is Alzheimer's disease, right? This is neurofibrillary tangle, history of senile dementia. It has to be, yes, made up of tau protein. Very good, guys. Tau protein. This is neurofibrillary tangles. Here you guys are brilliant. Last image. We'll end up on a high note. Come on, guys. History of bradykinesia and pill rolling tremors. Sir, pink nuclei hai. Around the pink nuclei, there is a perinuclear halos. Pink nuclei, around that there is a perinuclear halos. These are which bodies, boss? Lewy bodies. Diagnosis क्या करके आऊंगा, boss? It has to be Parkinson disease. They will integrate pathology with the medicine. They'll get pill rolling tremors hai. They will have this Lewy bodies cells with the pink nuclei along with the perinuclear halos. As you can see, nucleus is pink in color, but this perinuclear halos. This is Parkinson disease for you. Sir, thank you very much. Sir, all the best. Sir, जितना confidence मुझे तुझ पे है, I'm sure you'll have to amplify that for you. Trust me, the response that you're telling me, जो आंसर आया ना, trust me, एग्जाम में भी बनेंगे. Thank you so much, guys. That is all from my side. Thank you so much. No last minute advice. थोड़ा सा टाइम रह गया है. Only advice of this office for coming 2-3 days is only advice is, अब पढ़ने से कुछ नहीं होगा बॉस, अब पढ़ने से कुछ नहीं होगा. Just remember, surround yourself with positive people now. वो सब्जेक्ट पढ़ो, the one you like. वो सब्जेक्ट उन लोगों के साथ रहो. सराउंड योरसेल्फ विद पीपल whom you like the most. टॉक टू योर पेरेंट, टॉक टू योर गर्लफ्रेंड. ये वो टाइम है जब अपनी गर्लफ्रेंड से आप सारे करोगे तो इट इज अलाउड. Anything that makes you happy, do that thing. God will not judge you for the next 3 days कि आपने एग्जाम से पहले कितनी मेहनत की है. It's for the last 6 months, जो लास्ट 1 साल से जो आपने तपस्या की है, that will help you out. Trust me, एक क्वेश्चन गलत नहीं होगा सिस्मिक पास से. That is all from my side, guys. Thank you very much. God bless you. Keep that energy high. Next sir is waiting for you, guys. So much love. बहुत सारा प्यार. Thank you so much. Bye bye, guys. God bless you. Bye.
Good evening, everyone. So we'll be now discussing the physiology important topics, must know areas, right? So I'm Dr. Kamal Jindal. Let's start with the first thing. Yes. So journal physiology, body fluid measurement. Let's quickly recap the indicators or the dyes which we are using for total body water. Remember, we are using DAT, right? DAT, right? So this is, yes, very good evening, everyone. Just half an hour more, right? And I know you are exhausted, but just half an hour. Yes, very good evening. Yes. So ECF, sucrose, inulin, mannitol, and N is sodium. Sodium thiosulfate, sodium thiocyanate, right? Cyman. Yes, very good evening. Volume up, okay. Just getting it done. Yes, then we have ICF. For ICF and interstitial fluid, I'm going to do it indirectly. Interstitial extras, the intracellular fluid will be, yes. Very good evening, very good evening. Yes, ICF would be total body water minus ECF, right? For plasma volume, remember they are definitely going to give you albumin. Albumin is a plasma protein, radioiodine labeled albumin. Yes, please rejoin, radioalbumin labeled albumin. For interstitial fluid, ECF, I need one and another one from plasma volume, right? Then for RBC, remember 51 chromium, 32 phosphorus, 59 iron. Let's move to the simple figure, but this can be again repeated. This is a figure showing simple diffusion versus facilitated. How do you recognize it? In facilitated, we have the Tmax, right? Remember, both of them do not require energy, right? Yes, absolutely correct. Then moving on to, yes, both of them do not require energy. Facilitated requires carriers, right? Carrier mediated. Let's quickly recap. Simple diffusion for respiratory gases. Yes, respiratory gases, all lipid soluble substances including lipid soluble hormones. Facilitated mainly for GLUTs, glucose transporters, amino acid transporters, urea transporters. Absolutely correct. Let's move on to active transport. So long list. Primary active, also known as first degree, direct breakdown of ATP. ATP used directly, right? Not indirectly. Indirectly is secondary active. Indirect use of ATP. That means dependent upon primary active, right? Let's start with the first one. Sodium potassium ATPase, hydrogen potassium ATPase, hydrogen ATPase. Remember the location of these two. Definitely you all know. Just a recap. Yes, remember the location. Where are they present? I cells in the collecting duct, intercalated cells, and parietal cells of the stomach, right? Parietal cells of the stomach. Moving on to circa, that is for relaxation of the muscle. Secondary active, we have the co-transports to remember. PCT. Voice is not clear. Rajveer Singh, please rejoin once more. Yes, please rejoin once more. Voice is absent. I am also listening to the feed. It's clear. Yes. So we have the secondary active in PCT, sodium with glucose, amino acids, phosphates, lactate. Remember the important one, multiple times have been asked, SGLT2. Thick ascending limb, sodium potassium 2 chloride. In intestine, remember sodium glucose, SGLT1. No, Dr. AJ, just please rejoin. Voice is okay. I'm listening it to the feed myself. Yes. Only 2 subjects are left. Yes. So just let's concentrate. Thyroid, very, very important. Sodium iodide symporter. Remember the other locations of the sodium iodide symporter: salivary glands, stomach, placenta, intestinal epithelial cells. Yes. And gestational breast. Counter transport, remember sodium hydrogen exchanger, and myocardial cells, sodium calcium exchanger. That's right. ECF and ICF, very important table. Let's quickly recap. Yes, which is the only thing which is same in both ECF and ICF? Osmolarity. The only one which is same, right? Then major cation. This has been asked. They can ask it again. Sodium versus potassium, right? Most osmotically active ions, sodium and potassium. Major anion, chloride more than bicarbonate. Which is the only thing which is higher in ECF, pH. pH is higher in ECF, right? Then phosphates are more in ICF, much more. Proteins are more where? ICF, right? So which is the only thing which is same in both the compartments, osmolarity or osmolality? Which is the thing which is more in, yes, ICF, phosphates, proteins, which is the only thing which is more in ECF, pH, 7.4 versus 7.1, right? Moving on to feedback systems, another very, very important topic, positive versus negative. Remember, negative, whatever is happening, we are trying to reverse it. We are trying to normalize, to maintain homeostasis, stabilizing in nature. Most of the feedbacks are negative in nature, including your baroreceptor, endocrinology, right? Everything is negative. Positive, remember the mnemonic CLAPS, CLAPS. CLAPS stands for calcium induced calcium release, clotting cascade, LH surge, lactation, action potential, opening of sodium channels, activation of pancreatic proenzymes to their main form, and decompensated shock, right? These are the only examples of positive. Let's move to feed forward. Feed forward control, also known as anticipatory, anticipates the disturbance. I am making the corrective change before the disturbance sets in, much before, prevents the change in variable. What are the common examples? Increase in heart rate and respiratory rate before the start of exercise. Remember the term anticipatory tachycardia. Anticipatory tachycardia due to psychic stimulation. That means I tell you after 5 minutes from now you have to do spot jogging for me. Suddenly your heart rate starts to shoot up, although you haven't started to do any exercise per se, right? Anticipatory tachycardia, role of cerebellum in movements, salivary secretion in anticipation of food, cephalic phase. Thermoregulation, remember, is an example of, again, both, it is both negative and feed forward. It is both negative and feed forward. Remember that, both negative and feed forward. Nernst equation, very important one. Moving to nerve physiology now. Nernst potential of an ion is, what is Z? Z is valency. Z is valency of the ion, valency. In the numerator, always take higher concentration. In the denominator, always take lower concentration of the ion, right? So always remember, you have to keep in mind the ions are moving from which direction to which direction. Suppose this is the cell and I'm talking about chloride. Chloride is more in the ECF, less in the ICF. If this membrane becomes freely permeable, what is going to happen? The chloride will start to move in. If chloride starts to move in, what kind of charge will develop inside? Negative. What will negative charge do to my chloride? Repel. When electrical gradient becomes equal and opposite to concentration gradient, movement of chloride stops. 4 values you have to remember. Nernst potential of sodium plus 61, chloride minus 70, potassium minus 90, calcium plus 125. Please remember, Nernst equation is used to calculate Nernst potential of the ion, but Goldman-Hodgkin-Katz equation is used to find out the RMP, right? Equation I'm showing you here, even if you don't remember it, please remember that GHK is used to calculate RMP and Nernst equation is used to calculate Nernst potential. Please don't confuse the two, right? Very commonly asked question. Moving on to phases of action potential, very well known to most of us, right? What happens here? A to B, yes, A to B, depolarization happening due to sodium influx, depolarization. B to C, repolarization happening due to decreased sodium influx, increased potassium efflux, right? C to this point, this is after depolarization, after depolarization. Remember, in after depolarization phase, we have less potassium efflux. And finally, the last phase, hyperpolarization, restoration of the RMP due to slower closure of the potassium channels, right? Also, they can ask you at which point I've already written for you at which point the sodium is closest to its Nernst potential. Naturally, the answer can only be one, B point. Why? Because Nernst potential of sodium is around plus 61. At which point it is closest to potassium. Please have a look over here. Again, excellent picture. Potassium is, yes, minus 90. D point would be closest to potassium, right? These are repeated questions. They can be asked again. Moving to membrane conductance for sodium and potassium. This has been asked 3 times in last 5 years. So which ion is fast to open, fast to close? Only this much you have to remember. Fast to open, fast to close. Which one is slow to open and very slow to close? So this one is potassium. This one is sodium, right? Membrane conductance superimposed on action potential. Yes, I can see all the right answers. Very good. Now fiber classification. Let's zoom this and quickly recap it. 2 types of classification written just in front of each other so that you can remember. Yes, A alpha, A beta, A gamma, A delta. Remember the important ones I'm highlighting for you once more. Proprioception, somatic motor, right? Then remember fine touch, motor to muscle spindle. They don't have any fiber corresponding in Lloyd and Hunt. Also multiple times asked, fast pain versus preganglionic autonomic, right? C fibers, remember, are unmyelinated for slow pain, warmth and cold both. So cold sensation is carried by A delta and C, warmth only by C, right? Then also remember postganglionic sympathetic. Yes, when I apply pressure with fibers have susceptibility in which order? So with pressure, the susceptibility is A, B, C. What question they can ask you? Saturday night palsy, right? Then hypoxia. Hypoxia is BAC. Hypoxia is BAC, back. And then we have the LA, local anesthetics. Please, no controversies here, although ABC is the best answer, right? ABC, A gamma, A delta, A alpha is same as A beta, then B and C, right? ABC. Remember this. Yes, very good. Absolutely correct. Moving on to sarcomere picture. I'm showing you both the pictures once more. This is the picture when the muscle is in relaxed state. This is the picture when the muscle is in contracted state. What happens? The width of I band decreases. Yes, I band decreases, H band disappears, M line becomes prominent, but the A remains same. The A remains same. A is unchanged. A band stays the same. Yes, everyone is correct here. I'm looking at the chat. I can't see a single wrong answer. Wonderful. So you're all raring to go, right? Moving on to the EM picture, electron microscopic picture. How will I identify in the exam? Yes, just see this. The lighter area is always the I band. Lighter area is always the I band. This is the lighter area. Adjacent would be always darker. In the middle of the I band, we have which line? We have Z line. Then in between two consecutive Z lines, we have what? Sarcomere. That means if this entire is the A band, in the middle of the A, we have the H band, and in the middle of the H, we have the M line. So how will I approach the question? I will always start with the lighter band, right? That is easier to identify. One quick question to all of you, quick one. Yes, फटाफट answer देना है quickly. Which is this protein? Which is this protein, sir? Quickly. Which is this protein? Quick. Yes, which is this protein? Sarcomere length, Dr. Devendra Chavan, 2 to 2.2 micron, right? Normal. Yes. Yes, very good. As I'm moving from lateral to medial, ZAHM. That's right. This is which protein I'm asking you. This is which protein? That's right answer. Perfect. This is titin. Remember, mutation of titin or titin can cause, yes, dilated cardiomyopathy, tibialis muscular dystrophy. Very good. This is titin. Om Prajapati, actin nahi hai. This is titin. Titin protein is the largest protein, connects M line to Z line. M to Z line, right? Yes, that's right. Moving on to excitation, contraction, coupling. Let's recap this. I've written for you so that we can quickly do it. Yes, just see this. So as you see this, now you will realize excitation, contraction, coupling is electromechanical coupling. Please remember this. Action potential arrives at the sarcolemma. Just keep on visualizing, you know about it. Conducted into the T-tubule. T-tubule has DHPRs. DHPRs behave like voltage sensors. They sense the change in voltage, they move away. As they move away, calcium comes out. From where to where? Terminal cisterns to sarcoplasm. This is calcium coming out. Calcium is coming out, right? Yes. Duchenne muscular dystrophy adrenal, that is due to the dystrophin protein. That is dystrophin. Becker's and DMD. Becker's and DMD. Yes. DMD absence, Becker's deficiency, right? So this is calcium exits out. Important question. Which calcium is responsible for contraction in skeletal muscle? Let's quickly recap. Which calcium is responsible for contraction in skeletal muscle? Kindly remember, only ICF in skeletal muscle. Both ICF and ECF in cardiac and smooth. Both ICF and ECF in cardiac muscle and smooth muscle, right? Calcium induced calcium release occurs in which muscle? CICR occurs in smooth and cardiac. Calcium induced calcium release does not occur in skeletal muscle, right? So please remember these important ones. Circa is the common pump for relaxation which works everywhere, right? Everywhere. Circa is the common pump, primary active. But in smooth muscle, remember, we have additional mechanism, which is the mechanism for relaxation apart from Circa. Can you recap? Apart from Circa, which is the pump for relaxation in smooth muscle. Anything extra we are using? Circa and NCX, sodium calcium exchanger in cardiac muscle. Then Circa and activity of myosin light chain phosphatase in smooth muscle, right? Please remember these extra points. Contraction relaxation is a must know, must. Circa is everywhere, absolutely right. Moving on to renal system, determinants of GFR. Figure is already drawn for you. Let's quickly recap. Determinants means 4 pressures which can regulate GFR. MLCP, Anshita, MLCP, myosin light chain phosphatase. NCX is sodium calcium exchanger. Yes, net filtration pressure, how do I calculate? This has been asked multiple times in last 4 years. Hydrostatic pressure in glomerular capillary, pushing pressure, pushing. Oncotic pressure in the glomerular capillary, pulling back. Hydrostatic in the Bowman's, again trying to push the fluid back into glomerular capillary. Oncotic in the Bowman's, trying to push it out. So net filtration pressure is 45 minus 25 minus 10 plus 0. That means net filtration pressure is 10 millimeters of mercury. GFR is KF into net filtration pressure. What is KF? KF is ultrafiltration coefficient or constant, product of permeability of the glomerular capillaries and total surface area of the glomerular capillaries, right? Remember, they can ask you when will the GFR increase or decrease. So if I'm increasing the hydrostatic pressure in glomerular capillary, GFR increases. If I'm decreasing hydrostatic pressure, GFR will decrease. If I'm increasing the oncotic pressure, GFR will decrease. Just follow the directions. If there is a patient of ureteric calculus, hydrostatic pressure in Bowman's capsule increases, what will happen? GFR will decrease. If by chance there are more proteins in the Bowman's capsule, GFR will increase, right? So this is a PET question, calculation based as well as conceptual question, right? Moving on to tubuloglomerular feedback, a very important mechanism for auto-regulation of GFR. Let's quickly recap. What is the feedback? Tubules are exerting a feedback on glomerulus or glomeruli. How do they do that? Whenever we have increase in GFR, there is more sodium chloride load or filtration, which is sensed by, very important question, macula densa. Macula densa is mainly in early DCT, although it starts from the distal part of thick ascending limb of loop of Henle. If I want to reabsorb more sodium chloride in DCT, is it primary active or secondary active? Remember, I require NCC, sodium chloride cotransporter, secondary active. So I'm going to break down more ATP, I get more adenosine, right? I'm highlighting key ones for you here. Adenosine will act on A1 receptors. A1 causes release of calcium Calcium causes constriction of afferent arteriole, GFR decreases. What type of feedback? Sir, what type of feedback? Negative feedback. This is negative feedback, right? It is negative feedback. Yes, negative feedback. Second degree means secondary active. Then can you recap? If there is decreased GFR, what happens? One line answer quickly. Decreased sodium chloride delivery to the DCT. Yes, quickly tell me one line, quick. Decrease delivery to DCT. Sense by macular densa again. What will it release? Yes, what will macular densa release? More nitric oxide. What will nitric oxide do? More afferent arteriolar dilatation. What will happen to GFR? Increases. So please remember, with increase in GFR, adenosine acting on A1. With fall in GFR, it is nitric oxide. Very good, absolutely correct. Let's move on to two standard pictures. One of them can easily come up in exam. One is the clearance curve. So I think all of us know whose clearance is always constant. Inulin, neither reabsorbed nor secreted, right? Let us say this is A. This is, let's say, B. This is C. This is D. Who has a clearance less than inulin? All reabsorbed solutes. Commonly, they will give you the glucose. Which one is completely secreted at a low concentration? Para-aminohippuric acid at less than 20 milligram per deciliter is completely secreted. Yes, absolutely correct. So this is pH, which is only partly secreted. Partly secreted is creatinine. Can you recall for me what is this? Quickly, quick answer. What is this? This is the plasma concentration up to which the clearance remains 0. Yes, what is this? This is the plasma concentration up to which the clearance of glucose remains 0. Yes, quick answer, quick. This is... No, Tmax nahi hai, Twinkle, this is not Tmax, this is plasma concentration, renal threshold of glucose, right? You know the standard value, 180 milligram per deciliter. Please remember this, they can ask you this as well. Moving on to, yes, another one. This time what they are showing you, curves show the percentage of the filtered load remaining in the tubular fluid at various sites along the specimen or along the nephron, right? So by specimen they say in the nephron, right, and tubule. So let's start with the first one. Who is again going to be remaining at the same percentage of filtered load? Again the answer is same, none other than inulin. Yes, in venous blood, that's right. We are taking sample from the veins. Which one will touch 0 in the proximal tubule? Yes. That means as it is freely filtered, it is 100% reabsorbed in the proximal tubule. It is touching 0. So A is none other than, yes, what is A? A can be glucose again, which is a more commonly asked one, or A can be amino acids, right? Glucose or amino acids. Then moving on to B. Yes, what is B? B is creatinine. No. How can B be creatinine? Creatinine is secreted. B is something which is not reaching 0 in proximal tubule. It is reaching 0 after distal tubule. So what is B? B is bicarbonate. Remember why it is not reaching? Because it is 85% reabsorbed in the proximal tubule. It is 85% reabsorbed in the proximal tubule. Yes, and D is again having initially very high percentage of the filtered load, then it reaches a plateau. Why? D is para-aminohippuric acid. Somebody was saying creatinine. I can make creatinine like this. This could be my creatinine. That means slightly above the inulin line. Why? Because it is secreted in the PCT. Then its concentration will be plateau, right? So this is para-aminohippuric acid. Yes, that's right. Moving on to plateau potential and pacemaker potential, another two very important one. Let's recap. Most of you should be able to tell me quickly. Phase 0, depolarization is due to, yes, sodium influx, very important. Phase 1, potassium efflux. Which channels? TROP and DROP, transient rectifier, outward potassium channels. Transient rectifier, outward potassium channels. Then we have plateau. Plateau is due to calcium influx. Please remember the name of the channel, slow calcium channel. That's right. And finally we have the DROP, delayed rectifier, outward potassium channels, right? Most likely they will ask you 0 and 2. These are the favorite ones, right? 0 and 2. 0 and 2. I can ask you a question like this. Which is the only phase in which the sodium permeability is maximum? Remember, phase 0. Which is the phase in which calcium permeability is maximum? Phase 2, right? Slow calcium channel. Absolutely correct. Moving on to pacemaker potential. When I look at pacemaker potential, phase 0, depolarization phase, it has multiple reasons. Opening of funny sodium channel, also known as NaH, also known as NaHCN, hyperpolarization, cyclic nucleotide gated channels. Then we have calcium transient channels, and then decreased potassium efflux. Once I reach the firing level, I will have phase 0. Phase 0 is due to calcium L. What is calcium L? Long lasting calcium channels. Then we have phase 3, potassium efflux, which is none other than always repolarization. Yes, the main one out of the funny sodium, transient calcium, which has the maximum contribution is transient calcium. Remember that. This has the maximum contribution, maximum role, or maximum contribution, right? Please remember this. This has not been asked till date. It can be asked, right? Maximum role in phase 4 is of calcium transient, not funny sodium. Yes, calcium transient, right? Very important. Moving on to hemodynamics, let's quickly recap the laws. Ohm's law. Yes, you already know about it. What is Ohm's law? Q is equal to delta P upon R. This is the blood vessel. Pressure P1, blood is coming in. P2 is the pressure inside, delta P upon R. Q is blood flow. P is pressure gradient. R is resistance. Velocity of flow is inverse to total cross-sectional area. Remember that. Poiseuille-Hagen's law, very, very important. Q is delta P into pi by 8 into 1 by eta into R4 upon L. Over here, you have to remember relationship between blood flow, radius and length. Definitely a numerical based topic, right? Then remember, from the same formula, I can also write R is equal to 8 eta L upon pi R4. So please look at relationship of resistance and radius inverse to the 4th power, right? Normally the flow is laminar or turbulent. Remember, normally the blood flow is laminar, it is silent. But when the blood flow becomes noisy, it starts producing noise, which is known as turbulent blood flow. So turbulent blood flow is responsible for all the sounds you hear, whether it is physiological or pathological. Yes, Laplace law. Laplace law, remember, Reynolds number has to be more than 3000. That's right. P into R upon 2. This is for cylindrical. Yes. P into R upon W and P into R upon 2W. So the first one is for cylindrical structures, right? Which one has negligible wall thickness, which is this relationship for capillary, right? Which is for this one, any other blood vessel. This is my ventricle and this is my alveoli, right? Alveolus. So very important. Moving on to cardiac cycle. Cardiac cycle, this is a representation of the Wiggers diagram. They can ask you that which valve opens or closes where. This is point A, this is B, this is C, this is D, right? Remember the mnemonic. Mam Coco, Mam Coco, right? What is Mam Coco? Mitral valve, first event in the cardiac cycle, closes. Aortic, O for opens. Aortic closes. And finally, mitral valve opens, right? This is the order for remembering the sequence and closure of valves. Then coming back here, PAQR1CXT2V3Y. This is the mathematical formula to memorize the cardiac cycle, right? We are just following the easy dictum here, right? So electrical events are followed by mechanical. Remember P wave, atrial depolarization followed by atrial contraction, right? QR, ventricular depolarization followed by closure of the valve. Which valve? Mitral valve. First the valve will close, kindly remember that is why S1. Then only I will have IVC, right? X is the X descent which will occur in ejection phase. Second is S2, yes, second heart sound. V is venous filling, IVR. And as soon as, remember, venous filling of atria occurs, after that I will have third heart sound followed by Y descent. Let's recap the Hindi mnemonic. पान की दुकान पे QR कोड स्कैन किया, एक सिगरेट जलाई, एक्सरे में T2 की फाइंडिंग आई V3Y, राइट? लेट्स रिकैप. पान की दुकान पे PA, QR कोड स्कैन किया, 1C, एक सिगरेट जलाई, X एक्सरे में T2 इज सम रैंडम गाय, उसका नाम है, T2 की फाइंडिंग आई V3Y, राइट? पान की दुकान पे QR कोड स्कैन किया, एक सिगरेट जलाई, एक्सरे में T2 की फाइंडिंग आई V3Y. Yes, S1 after R because peak of R wave denotes apical depolarization, right? Left ventricular pressure volume loop. Quickly recap. What does this point denote? EDV. What does this point denote? ESV. What does the width of the loop denote? Stroke volume, right? What does this denote? Isovolumetric contraction. What is this phase? Ejection phase. Can I say rapid or slow ejection, sir? Answer is no. There is nowhere time to be seen. C2D, IVR, then ventricular filling phase, right? I can ask you in the exam, can you calculate ejection fraction from the loop? The answer is yes, a big yes. If this is the line joined over here, this is the line joined over here, what does this point represent? Remember pulse pressure, because this is opening of aortic valve, this is the highest point, difference between the two, pulse pressure, right? So remember these things, very important. You can calculate ejection fraction, you can calculate stroke volume, you can calculate the pulse pressure as well. So lots of valid information. I can ask you in the exam, systole starts from where, ends where? So this is the beginning of systole, this is the end of systole. So systole is from A to C. Then I can ask you what is the extent of diastole? Diastole extent is from C to A, right? C to A. Moving on to the next one, Frank-Starling law. Remember, normal curve is curvilinear. Curvilinear means it increases as the initial muscle length increases of the ventricular muscle. Then there is a plateau because maximum stretchability of the ventricle has been achieved. at the same preload, if in comparison to the normal, the cardiac function is increased, most likely this is a case of increased myocardial contractility. How can I increase the myocardial contractility? So we have given digitalis, one of the most common ones they will ask you, right? Apart from this, sympathetic nervous stimulation. Decreased cardiac function can occur post myocardial infarction, right? Post myocardial infarction. Moving on to some cardiovascular reflexes. First, we are starting with baroreceptor. Let's quickly recap. These are most important ones if you ask me. Most important. Person was in standing posture, he goes into supine. Mean arterial pressure increases. This is my carotid sinus, main baroreceptor. This will stretch more. If it stretches more, more firing rate of the baroreceptors. Ninth nerve mainly, but also 10th nerve. Why mainly ninth nerve? Carotid sinus is the main baroreceptor, 5 times more sensitive. Information goes, excites nucleus of tractus solitarius, NTS. What will happen? It will stimulate the CVLM, which will inhibit the RVLM. So there is decreased sympathetic outflow. That means less of sympathetic nervous stimulation. Other name for CIC, cardiovagal inhibitory center, also known by the name nucleus ambiguous. Nucleus ambiguous. This causes increase in vagal or parasympathetic stimulation. What will happen? You know the answer very well. This will cause decrease in heart rate, decrease in stroke volume, vasodilation. This will cause only decrease in heart rate because vagal fibers do not innervate or sparsely innervate ventricle. What is the product of these three things? Cardiac output. What is the product of these two? MAP. Has the BP been normalized? The answer is yes. Please remember the right order. They can confuse you that first the CVLM is stimulated or the RVLM. First CVLM is stimulated and RVLM is inhibited. Finally, which is the first to normalize? Remember, heart rate has a dual control. Heart rate has a dual control, so always normalizes first. Yes, nucleus ambiguous. Moving on to CVS other reflexes. Mary's law. Heart rate is inverse to blood pressure. Most commonly they will ask you is Bainbridge and Bazol-Jarisch. Multiple times repeat, can come again. Sudden increase in blood volume increases heart rate. Right, commonly on giving rapid IV fluid transfusion. Bazol-Jarisch, remember the names, injection of substances such as serotonin, capsaicin, phenylbugonides and viratridine. It can cause hypotension and bradycardia, right? Remember, same reflex can also occur in post myocardial infarction patients as well due to accumulation of toxic metabolites, right? Moving on to the central nervous system, we have the rapidly adapting or the phasic receptors. Remember the key ones here. The Pacinian corpuscle is for deep pressure, also known as poking sensation. Most sensitive. Meissner's is for slow vibration. Fast vibration means up to 800 cycles per second. Slow is up to 80 cycles per second. Texture topognosis is study of the surfaces. Yes. So PC has messy hair or Miss PC has hair, right? Remember that. Hair and organs. Please remember, best stimulus for Meissner's is moving touch. Most numerous is Meissner's. Hair and organs, light movements on the hairy skin. Again, it would be moving touch, but on the hairy skin. Let's understand the Braille one as well by moving on to slowly adapting. Yes. Again, just recap. Merkel disc. 2-point discrimination. Best answer, remember, is the Merkel. The reason is Merkel disc has the Smallest receptive field. No, there is no background noise. Please concentrate. Smallest receptive field. Best answer, remember. Smallest receptive field, right? That is why best answer for 2-point discrimination and the even Braille is Merkel. Kindly remember that. For Braille, we require both Meissner's and Merkel, but best answer is Merkel. Then best stimulus is point stimulus. Point stimulus means this is a pen, I am touching my hand with the tip of the pen, right? That is point stimulus. Corners, margins, edges, you understand, right? Ruffini's ending, remember best stimulus is stretch on the skin. Crude touch and pressure, C mechanoreceptors. Joint capsules, joint and position sense. They are superficially located. Then moving on to thermoreceptors, remember temperature, they detect any temperature of the object placed on the skin. Nociceptors, pain ones. Let's do a quick recap of the figure. They can ask you this histology slide and they can corroborate with anatomy, which is this receptor which is present like this. The answer would be none other than Meissner's. Why? These are dermal pegs. These are dermal pegs present in the glabrous skin, non-hairy skin, right? Pexinian corpuscle, onion skin appearance, right? Onion skin appearance. Remember, Merkel has egodome receptor. Egodome, why do we call? Because the slightly raised epidermis, right? Egodome. Moving on to stretch reflex. Again, let's recap. This is just a figure showing you anomaly which we are doing, that a knee jerk. What is the stimulus? Change in muscle length. Who is going to judge? Muscle spindle. Which are the afferents? 1A and 2. Which are stimulated more? 1A more than 2. Why? Because as I strike with a hammer, the response is immediate. 1A means dynamic responses are more during the stretch reflex, much more than static responses. Where is the synapse? Ventral horn, which is the efferent A alpha. What will I do? Muscle contraction. Number of synapses? Only 1. This is also known as deep tendon jerk, myotactic reflex, and monosynaptic reflex. These are the names of the same one. Let's move to inverse stretch. Inverse stretch reflex is triggered, please remember, not with a passive stretch, but either an increase in muscle tension or powerful or forceful stretch. Receptor is Golgi tendon organ. Afferents are 1B. Now the problem here is the first synapse is on this inhibitory interneuron. This inhibitory interneuron releases glycine, which is going to inhibit this A alpha. So will the muscle contract? No, muscle is going to relax. How many synapses? 2 synapses, 1 and 2, right? Bisynaptic. What are the other names for this? Autogenic inhibition. Autogenic inhibition. Why do I call it autogenic inhibition? Because the muscle is relaxing itself to prevent the rupture of the tendon, right? Also known as bisynaptic or disynaptic reflex, right? Remember that. Golgi tendon reflex is another name. Moving on to the cerebellum. So when I talk about cerebellum, the first thing is, remember the nuclei, 4 pairs of deep cerebellar nuclei. As I am moving lateral to medial, I have 4 pairs of deep cerebellar nuclei. Don't eat greasy food, or doctors eat good food. But in humans, E plus G has been combined to give me nucleus interpositus. Let's quickly recap. Oldest portion, flocculonodular lobe. It is the one which is receiving both the afferents and efferents from vestibular nuclei. Role, postural balance and eye movements. Which is this one? Neocerebellum or cerebrocerebellum. Role, planning and programming of movements. It will receive afferents from cerebro, motor, premotor, cortical areas. Efferents via dentate. Then spinocerebellum, motor coordination. It has two parts. Vermis, medial most lobe, paravermis intermediate. Naturally, the vermal efferents will exit out via which nucleus? Fastigial. The paravermis efferents will exit out via which nucleus? Interpositus, right? Both are receiving unconscious proprioceptive information from the axial muscles, vermis, distal muscles and limbs, paravermis, right? A histology slide to recall the things. In the cerebellar cortex, we have the outer molecular layer, basket and stellate. Remember, Purkinje layer, Purkinje cells only gives the output to the deep cerebellar nuclei, DCN. What kind of output it would be? Inhibitory output, inhibitory. Only granule cell is excitatory, only granule, right? Which fibers, quickly write the answer in the chat box, which fibers enter via inferior olivary nucleus and directly bring the excitatory input to the Purkinje cells? Climbing fibers or mossy fibers? Yes, Purkinje cells project to deep cerebellar. Which one? Quickly, quick recap. Remember, they can give you a histology question by showing you this slide. This is a Purkinje cell being shown. Purkinje cell. It is going to project to deep cerebellar nuclei. Remember, climbing fibers pass through inferior olivary nucleus. Absolutely correct. That's right. Some important nuclei of the hypothalamus. Hunger, thirst, rage, aggression. Ventrolateral. Ventrolateral. Satiety and reward. Ventromedial. Heat gain, heat loss. Remember that. Very important question. Person is exercising in hot weather. He is sweating a lot. Which area of the hypothalamus has been activated? Either they will give you anterior or pre-optic nuclei. Posterior, heat production, shivering, cold weather. Sexual activity, anterior most and posterior most portion, circadian rhythm, suprachiasmatic. In the males, we have additional area, piriformis or piriform cortex, additional area only in males. Neurosecretion, supraoptic ADH, paraventricular oxytocin. Yes, so we are done with up till here. Now the remaining part will be done by the other faculty. He will just be starting in a while. So thank you so much. You have studied a lot. I can totally relate to it, and my best wishes are with you. Please don't panic in the exam. If you don't know one or two questions, just leave them, move ahead, and please try to do your best and take a good night's sleep. I know it is easier said than done, but please give your best, and Almighty is with you, right? Best of luck. God bless you all. And then remember, what matters most is how you see yourself, right? So if you don't think that you have the potential, you will not be able to do anything, right? So God bless you all. Take care, right? My best wishes are with you. Thank you so much for patient listening. Thank you.
Is it visible? Yes. Okay, I'll cut the call. Yeah. Good evening, guys. Is it visible? Good evening, doctors. Can you hear me? Am I audible? Yeah, very good. Good. So, people, let's revise the 4 topics: respiratory physiology, GIT, endocrine, and miscellaneous. Good evening, doctors. Good evening very much. And out of these 4 topics, the question zone is respiratory physiology. That has been asked so many number of times, and that's practically the most important topic you have to be putting your best focus on. That's respiratory. And other topics, GIT, endocrine, and miscellaneous has yielded limited numbers of questions. So much of our time will be invested in RS and very few time will be invested in GIT, endocrine, and miscellaneous. Let's make this half an hour count. So let me start with respiratory physiology, guys. And the very first topic you got to be clear about is going to be lung volumes and capacities. To begin with, the very first word you got to be knowing is this: when a thorax is at rest, when a lung is at rest, the volume of air filled in the lung will be called as functional residual capacity. And when it comes to functional residual capacity, the volume of air which will be in the lung when the lung is at functional residual capacity is going to be 2.5 liters. Got it? And this air will be 2.5 liters of air, and that's going to be functional residual capacity, doctors. Remember. Now, every single lung volume can be measured by spirometer, and the question goes here: what is the lung volume that cannot be measured by spirometer? We have 3 lung volumes that cannot be measured by spirometer, and Dr. Anshita, very good. Residual volume, functional residual capacity, and please do add one more capacity as well, and that is going to be total lung capacity, which also cannot be measured by spirometer. If these volumes cannot be measured by spirometer, what other technique we will be using to measure these volumes? Number 1, it's going to be nitrogen washout method. Number 2, helium dilution method. And number 3, whole body plethysmograph. Very good. These 3 methods, nitrogen washout, helium dilution, whole body plethysmograph, will be used to measure residual volume first. If we could able to measure residual volume by these 3 methods, we can able to measure FRC. From there, we can able to measure total lung capacity. And that's lung volumes and capacity, doctors. Good. Now, the next question is going to be on Dalton's law, which is also going to be alveolar gas equation. Pretty simple question, but you just need to know the parameters, that is all. Doctors, let me be clear in this question. You are not going to get questions based on calculations. Don't worry. You need to know the numbers. You need to know the parameters. What are the parameters you got to know? If it is going to be Dalton's law or alveolar gas equation, this will be used to measure partial pressure of a gas in blood. Partial pressure of any gas in blood. The question will usually focus on oxygen. All these years, the question was on oxygen alone. So don't worry about other gases. Just ignore it. It is going to be oxygen. Number 2, other parameters. What are all the parameters you will be focusing on? In order to calculate partial pressure of a gas in blood, the first parameter you are going to focus is going to be something called as fraction of inspired oxygen. In the air or in the gas the patient is inspiring, what percentage of that air or gas is oxygen? If it is going to be room air, if it is going to be atmospheric air, it is going to be 21%. If it is going to be a gas from an oxygen cylinder, the entire gas will be oxygen, and hence it is going to be 100%. So the first word is going to be fractional gas concentration that differs from room air to oxygen cylinder. 2 words. If it is going to be room air, it is going to be 21%, and 21% will be represented by 0.21. It is 21 by 100, isn't it? If it is going to be cylinder, it is going to be 100%. So 100 by 100, it is going to be just 1. Remember that one point. And number 2, the other parameters are going to be barometric pressure. PB refers to barometric pressure, which will usually be 760 millimeters of water. And the next parameter is going to be pressure of water vapor. We have to deduct the water vapor pressure from the barometric pressure. So usually it is going to be the pressure of water vapor will be 47 millimeters of mercury. Barometric pressure will be 760 millimeters of mercury. The air we breathe in will be diluted with water vapor, and hence we got to subtract this 47 from 760. And we have a parameter called partial pressure of carbon dioxide, and the denominator for that is going to be R. Doctors, this itself is a separate entrance question. R stands for respiratory quotient, also called as respiratory exchange ratio, which will be calculated with carbon dioxide production as a numerator and oxygen consumption as the denominator. So this tells you for how much of oxygen we breathe in, how much of carbon dioxide is going to get produced. That ratio is what is called as respiratory quotient, also called as respiratory exchange ratio. So question number 1. What are the parameters you will find in calculation of alveolar gas equation? Or what are the parameters you will find in calculating Dalton's law? The parameters are: number 1, fractional gas concentration; number 2, barometric pressure; number 3, water vapor pressure; number 4, partial pressure of arterial carbon dioxide; number 5, respiratory exchange ratio. These are the 5 parameters you need to be knowing, plain and simple. Coming to calculation of partial pressure of oxygen in atmosphere. Doctors, do not worry, you will not be taken to this calculations which involves decimals and everything. Just simply do not worry. What I need you to remember in your brain: partial pressure of oxygen in atmosphere is going to be 150 millimeters of mercury. That is all. Now, when this oxygen is being taken in, the value will be diluted with water vapor. We'll come to that in a moment's time. Before that, let us be clear with partial pressure of oxygen. If a patient is breathing from an oxygen cylinder, which is nothing but 100% oxygen, so the FiO2, fraction of inspired oxygen concentration in the cylinder breathing, is going to be 100%, and the value comes down to 1. Substituting the barometric pressure and water vapor pressure, it is better you be remembering this one number, guys: 40, which is nothing but partial pressure of arterial carbon dioxide; 0.8, which is going to be respiratory quotient. And between these two values, I want you to be very specifically remembering respiratory quotient, which is a recent past year entrance question, and the number is 0.8. We will be consuming oxygen and we will be producing carbon dioxide, and the ratio is going to be 0.8, because every time when we consume oxygen, this will be somewhat about 250 ml of oxygen consumption per minute, and we will be producing 200 ml of carbon dioxide per minute, and this ratio is going to become 0.8. all right, and please remember respiratory quotient is 0.8 because the ratio is 200 ml by 250 ml. got it? And moving on to the value, when it comes to partial pressure of oxygen in a patient who is breathing through oxygen cylinder, the value is going to be, it is going to be 663 millimeters of mercury. I just need you to be clear at this one value. Do not remember, just because the patient is breathing oxygen cylinder air and the atmospheric pressure is 760 millimeters of mercury, do not expect and do not think and do not pick 760 millimeters of mercury as the right answer. It is wrong. Your answer needs to be 663 millimeters of mercury. That is all. Now this is going to take you to just one more point. What do you expect? The partial pressure of oxygen in a high altitude. At atmospheric pressure, it is going to be 150, which means every time when the patient goes to high altitude, the value must be lesser than 150 millimeters of mercury in high altitude, guys. That is one set of questions in RS. That's going to be alveolar gas equation and Dalton's law. And moving on to gas levels, guys. These numbers you must be familiar with. When it comes to gas numbers, just be clear, guys. I need you to be remembering these numbers because we had questions in INICET, we had questions in NEET as well based on these numbers. So let's be clear with ourselves. Partial pressure of ATM refers to atmosphere, and the value is going to be 150 millimeters of mercury before the air is being moisturized by water vapor. After humidification, after moisturizing, the value comes down to somewhat about 140 millimeters of mercury after addition of water vapor. When it comes to partial pressure of oxygen in alveolus, capital A indicates alveolus because the oxygen will be continuously extracted by the incoming RBCs. The value will be dropping to 104 millimeters of mercury in alveolus. When it comes to artery, just because the blood that enters the left atrium will be admixed with venous blood coming from bronchial veins, there will be again admixture of carbon dioxide, and hence there will be a drop in oxygen tension, and arterial blood oxygen comes down to 95 millimeters of mercury, and this oxygen will be delivered to the tissues, and after tissues getting extracting all these oxygen, how much of oxygen will be remaining in venous blood, and the value will be only 40 millimeters of mercury. Please remember, this is not the value of oxygen in ml, this is oxygen tension. I'm talking about the pressure of oxygen, remember that. And moving on to carbon dioxide. How much of carbon dioxide will be present in venous blood? Doctors, any answers? How much of carbon dioxide is present in venous blood? It is V. It is going to be V, guys. So it is going to be 46 millimeters of mercury. Yeah, please remember, venous blood carbon dioxide is 46. And coming to alveoli, carbon dioxide is going to be 40 millimeters of mercury. Guys, remember, venous blood carbon dioxide is going to be 46, alveolar carbon dioxide is 40 millimeters of mercury. Atmospheric carbon dioxide is going to be practically close to 0 millimeters of mercury. It's very, very less. And capital A refers to artery. Arterial carbon dioxide is going to be again 40 millimeters of mercury. All right, that's good. That's good. Very good, people. Just be clear in these values. So when it comes to gas level, just be clear that you need to be sharp at this one value, guys. Venous carbon dioxide is 46 and it is not 40. All right, that's good, guys. So I hope you are clear in the gas levels. Now, yeah, that's good, guys. That's good. Moving on, when it comes to Fick's law, which governs the rate of diffusion. When it comes to movement of gases, specifically Fick's law, three words utterly important. Number one, Fick's law is directly related to number one, it's going to be concentration gradient. More the concentration gradient, faster the rate of diffusion. Number two, it is directly related to surface area. Broader the surface area, faster the rate of diffusion. And that is a question in anesthesia. When you administer anesthetic agents or inhalational anesthetic agents or gases to your patient, why would you ask your patient to take a full deep breath? For one reason. With maximum inspiration, every single alveoli will be expanding to its maximum dimension. That increases the surface area and that directly increases the rate of diffusion, the speed with which gas moves across the alveolar membrane. And obviously, it is going to be indirectly related to thickness of membrane. And please remember, every time the membrane gets thicker and thicker, the rate of diffusion falls. That's three parameters you got to be clear with. Right. And twinkle, 760 millimeters of mercury is partial pressure of twinkle. That is not partial pressure. That is going to be total atmospheric pressure. Please remember, partial pressure is a pressure exerted by one gas in a mixture. 760 millimeters of mercury is a value for total atmospheric pressure. Please make a note of it. And doctors, the next point we are going to discuss is going to be about diffusion coefficient. This word has been asked in disguise. Lot many subtle expressions were given in the past year exam question. What is diffusion coefficient? This is a mathematical equation or constant that speaks about two parameters. Number one, lipid solubility, and number two, square root of molecular weight. I don't need you to bother about this square root of molecular weight and all. You will not get a question based on calculation in this parameter. Don't worry. What else you need to know? You need to know the fundamental, you need to know the formula, that is all. When it comes to diffusion coefficient, please remember this is determined by two parameters. The first one is lipid solubility. Now the second one is molecular weight. In another language, you can call the molecular weight as radius of the molecule or size of the molecule. Practically speaking, when the radius of molecule increases or size of the molecule increases, you will have a drop in diffusion coefficient. If there is a drop in diffusion coefficient, you will have a drop in rate of diffusion as well. So that's going to be the relationship, guys. Please remember. So if the radius increases or size increases, diffusion coefficient drop, rate of diffusion also drops, guys. Good. I mean, fantastic answer. It is directly related to lipid solubility. Very good. It is determined by lipid solubility, guys. Now moving on. Obstructive as well as restrictive lung disease, you will be getting questions on two different types of parameters. Number one, FeV1 by FVC ratio, that's a separate kind of question. Number two, this flow volume loop, that's a separate kind of questions. Now people, how will you get to know what is obstructive lung disease, what is restrictive lung disease? You are very well clear about the answers. The ratio, if it is less than 0.7, it is clearly a case of obstructive lung disease. If the value is going to be 0.8 or sometimes even greater than 0.8, if you find these two values, this is a clear-cut case of restrictive lung disease, the first differentiating point. Number two, doctors, let me give you one more point here. We had a question in NEET 2023 based on this one graph. Now, there is an algorithm with which you have to follow and you have to decipher. When you see this kinds of graph, guys, you need to take into consideration just one and the first and foremost point, that there is going to be drop in peak expiratory flow rate. All right, the normal peak expiratory flow rate is going to be 8 to 11 liters per second irrespective of the gender. All right, irrespective of the gender, be it a male or female, it doesn't matter. The normal peak expiratory flow rate is going to be 8 to 11 liters per second. The first indication that tells you that this is an abnormal graph and not a normal graph is this. If there is going to be any sort of bloody abnormality, you will find a drop in peak expiratory flow rate. This will not go all the way up to 8 liters per minute. Be it a obstructive lung disease or be it a restrictive lung disease, you will find a drop in values, guys. All right. So in these conditions, the blue line represents normal. So this is going to be 8 liters per second, 8 liters per second. This is normal graph. And if you find a pathophysiology, the hallmark feature is this: the value will be less than 8, the value will be less than 8. So every time when the parameter comes to less than 8 liters per second, and this tells you that the curve is not normal, it is going to be an abnormal graph, and your diagnosis begins from this point onwards. It's going to be drop in peak expiratory flow rate. And number two, as you guys were saying, the shape of the graph. Doctors, you can clearly see if it is an obstructive lung disease, there is going to be coving or there is going to be a huge amount of concavity. Now, beyond that, when it comes to the clear value, the most essential straightforward point to make your diagnosis is this. You have to look at this one parameter, and this is going to be called as inspiratory vital capacity. Now just be clear, when it comes to inspiratory vital capacity, the green line will be very close to normal if it is an obstructive lung disease. Let me be clear, the inspiratory vital capacity is very close to normal in obstructive lung disease, whereas if it happens to be a restrictive lung disease, you will find a tremendous drop in the inspiratory vital capacity, and this itself is a very short point to make the differentiating point between whether it is an obstructive or restrictive lung disease, guys. All right, let me be clear and let me tell you this point once again. If it is a restrictive lung disease, you will find a tremendous drop in the inspiratory vital capacity. The whole graph will be shortened out. And the next point, which is going to be very definitive for restrictive lung disease, is this: there will be a drop in lung compliance value. All right, and that's how you are going to differentiate between obstructive as well as restrictive lung disease, guys. Moving on, alveolar dead spaces. People, when it comes to alveolar dead space, you need to know what creates alveolar dead space. The first entrance point on alveolar dead space is pulmonary thromboembolism. It is generated in pulmonary thromboembolism conditions. Second entrance point, what is the V by Q ratio in alveolar dead space? And the answer is going to be infinite. Why there is an infinite V by Q ratio in alveolar dead space? Because ventilation will be normal in alveolar dead space, whereas perfusion will be zero. So there will be a normal ventilation but zero perfusion, and this leads to infinite V by Q ratio. And the third question, what is the measuring technique when it comes to when it comes to alveolar dead space? How are we going to measure alveolar dead space? You cannot measure alveolar dead space directly. You first have to calculate physiological dead space. You know this. You first have to calculate physiological dead space. That can be done by carbon dioxide washout method, which is also called as Bohr's method. And then you have to calculate anatomical dead space. That can be done by nitrogen washout method, also called as Fowler's method. So once you calculate physiological as well as anatomical, and then you got to subtract anatomical from physiological, and that is going to give you the value for alveolar dead space, guys. And that's dead space, doctors. Very good. It's going to be ventilation but no perfusion. Good. Moving on to lung complaints. People, lung complaints will be measured by change in lung volume as the numerator, and the denominator will be changing pressures, transpulmonary pressures. All right. Change in lung volume by change in transpulmonary pressure will give you the value for compliance. The normal value for lung compliance alone is going to be 200 ml of air per centimeter of water transpulmonary pressure. This is normal compliance of lung. If you take up compliance of total respiratory system, that includes chest wall as well as rib cage. Since it is two structures, it is going to require more effort, and the compliance drops to 110 ml per centimeter of water. So please remember, if the question is about lung complaints, your answer must be 200. If your question is going to be, total thorax, your answer must be 110 ml per centimeter of water. All right, Twinkle. ARDS and alveolar dead space. No, Twinkle. ARDS is different. Alveolar dead space is different. They are not one and the same. When it comes to respiratory distress syndrome, this indicates a severe kind of hypoxia. In that huge deficit in oxygen delivery to tissues, patient will go for tremendous respiratory effort. This ARDS can be because of anything. It may be because of foreign body obstructing entire airway. This may be because of complete surfactant deficiency leading to alveolar collapse. This may be because of severe COPD and emphysema, where there is going to be no oxygen delivery to the capillaries. So ARDS can be generated by any mechanism, but the point is this: there is a severe drop in tissue oxygenation, and this makes the patient to fight for breath. The patient will gasp for breathing. There is a air hunger. There will be a tremendous respiratory effort. That's respiratory distress syndrome. When this respiratory distress syndrome remains for a prolonged period of time, the patient will end up in respiratory failure and arrest. All right. So respiratory distress is a stage before respiratory arrest. All right. So that's the difference, Twinkle. All right. Praveen, which lobe of liver has zero perfusion? Praveen, is that liver or lung, Raja? Praveen, which lobe of lung has zero perfusion? I think that is your question. Priyanka, type on respiratory. Yeah, exactly. Very good, Priyanka. Good. Praveen, can you bit clear your doubt here? All right. So let's keep moving on till Praveen gets his doubt clear. Let's keep moving on, guys. Yeah. Moving on to the graph here. When it comes to the graphical expression of change in pressure by change in volume, you will have a normal graph at the center, and every time there is going to be emphysema, there is going to be a increase in compliance, and when it comes to restrictive lung disease, there will be a drop in compliance, guys. So you have to pick the upward tilt of graph when it comes to emphysema, and when it comes to lower tilt of graph, it is going to be restrictive lung disease. All right. Praveen and Rachika, I'll come to this doubt once we finish RS, guys. All right. Yeah. And moving on to lung volumes. When it comes to lung volumes, at low lung volume and high lung volume, you will be asked about two questions. What happens to surface tension? What happens to compliance? We'll address this question. At low lung volumes, the subject will be having very, very low surface tension, and the lung will be having superb compliance. When it comes to high lung volumes, it is going to be completely opposite. At high lung volumes, there is going to be much increased surface tension, and there is going to be much reduced compliance. So just be clear, these parameters are going to be opposite when it comes to compliance as well as surface tension in low lung volume as well as high lung volume. And coming to hysteresis, you know that the graph for inspiration and the graph for expiration is going to be different. This is not going to be one and the same, and the difference is going to be called as hysteresis. The question is all about the reason for hysteresis, and the answer is going to be surface tension, guys. Good. Moving on to oxyhemoglobin dissociation curve. In what situation the curve gets shifted to right as well as left? Now people, let's first take up the condition where the curve gets shifted to right, and what do you call as right shift of oxyhemoglobin dissociation curve? This is clearly manifested by P50 value increasing more than 27 millimeters of mercury, and the conditions are going to be drop in PO2, increase to PCO2, and there is going to be acidic pH, increase to temperature, anemia, increase to 2,3 bisphosphoglycerate, exercise, and high altitude. Quick, and which one do you call as, what effect are you going to call when there is acidosis, guys? If there is going to be acidosis, it will be considered as Bohr's effect. So please remember, Bohr's effect is nothing but acidosis causing right shift of oxyhemoglobin dissociation curve. Pratyush, it's going to be less affinity, Raja. If it is going to be right shift, the affinity is going to be less. Alright, it is going to be a less affinity situation. It is not a high affinity situation. And coming to left shift of oxyhemoglobin dissociation curve, where P50 value is going to be less than 26 millimeters of mercury, where the affinity is going to be increased. This is going to be high affinity state. It is going to be high affinity state. Increased partial pressure of oxygen will be shifting the curve to the left, and this effect is called as Haldane's effect. I repeat, this effect is called as Haldane's effect, guys. Here it is, Haldane's effect, and this is also associated with decreased carbon dioxide, decreased temperature, alkalotic pH, fetal hemoglobin, myoglobin, as well as carbon monoxide poisoning. So these are the conditions which is going to be shifting the curve to the left, guys. All right, fine. And ventilation perfusion ratio is infinite in which part of normal lung? And Praveen, all right, guys, just be clear. When it comes to normal lungs, you guys need to be very clear in this one topic, people. There is going to be apex, and there is going to be a point. There is going to be a point where 10 centimeter above, 10 centimeter above midpoint of heart, 10 centimeter above midpoint of heart, and there is going to be basal part of lung. So there are three different regions you got to be familiar with, and when it comes to these three different regions, you will be calling from apex all the way to midpoint of heart. This region is going to be called as zone 2. Please remember, doctors, please remember, this is called as zone 2, and zone 2 is going to be manifested with waterfall effect. This is going to be manifested with waterfall effect, where there is going to be no pulmonary blood flow. There is going to be no pulmonary blood flow during diastole. There is going to be no pulmonary blood flow during diastole of right ventricle, but there will be a pulmonary blood flow. There will be a normal pulmonary blood flow, and this is going to be happening only during RV systole. So there will be pulmonary blood flow only during right ventricular systole, and doctors, this effect is what is called as waterfall effect, and this is manifested from apex of lung all the way to 10 centimeter above midpoint of heart. And after that region, all right, after that region, from this point all the way to the base of lung, we are going to call this region as zone 3, which means there will be a pulmonary blood flow. There will be pulmonary blood flow for systole as well as for diastole, and this is going to be zone 3. So in normal lung, you will have only two zones. One is going to be zone 3 and the other one is going to be zone 2. And what is going to be zone 1? Usually zone 1 will not be present in normal lungs, because when it comes to zone 1, there will be absolutely no pulmonary blood flow irrespective of right ventricular phase. Be it systole of right ventricle or diastole of right ventricle, there will be no pulmonary blood flow. This is not present in normal physiology. Zone 1 is only present during positive end expiratory pressure mechanical ventilation. Alright, so this is what is going to be zone 1, guys. So for God's sake, remember the difference between apex of lung and zone 1. It is not one and the same. Apex is a different concept, zone 1 is a different concept. Alright, I hope you are clear in this one concept. Now people, when it comes to normal physiological conditions, there will be nothing called as infinite V by Q ratio when it comes to normal physiology. You will get infinite V by Q ratio. Alright, V by Q ratio will become infinite only in alveolar dead space only, which is because of pulmonary thromboembolism. And just be clear in that one point, guys. All right, fine, that's perfect. Moving on to gastrointestinal physiology, it's pretty simple topics, guys. I hope your doubts have addressed. All right, yeah, moving on, people. When it comes to slow wave, which is also called as basal electrical rhythm, first question, what cell is responsible for slow wave? And the answer is going to be Kagel cells. Where will you have the slowest basal electrical rhythm? Answer is cecum, and the frequency is 2 movements per minute, 2 electrical fluctuations. All right, the fastest basal electrical rhythm is seen in duodenum, and the frequency is going to be 12 movements per minute. Where will you have no basal electrical rhythm, which is absent BER? The segments are esophagus as well as proximal stomach, guys. All right, Please remember, in these two regions there will be no causal cells, and that's going to be the reason why there is no basal electrical rhythm. And moving on to neurotransmitters, we have two types of neurotransmitters in myelinic plexus. Excitated neurotransmitters are acetylcholine and substance P. Inhibitory neurotransmitters are vasoactive intestinal polypeptide and nitric oxide. And moving on to hormones influencing HCl production. The hormone that increases HCl production is going to be gastrin, and the hormone that decreases HCl production is going to be 2 in numbers, secretin as well as incretins, guys. All right, fine. And that's going to be the hormones influencing acid production. The last question in GIT is this: expression of GLUT transporters. GLUT1 is present in RBC, cornea, placenta and neurons. GLUT2 hepatocytes, basal membrane of proximal convoluted tubule and enterocytes. GLUT3 is present only in neurons. GLUT4 is present in adipocytes as well as skeletal muscle cells. Out of all, you know that GLUT4 is going to be insulin dependent glucose transporters, guys. Alright, so that's going to be GIT. And moving on to endocrine people, you got to be familiar with at what time growth hormone secretion, cortisol secretion takes place. Growth hormone secretion happens at midnight. You will find the curve for growth hormone secretion increasing by 12 a.m. So if you watch for a curve and the time is given in the x-axis, exactly at 12 a.m. midnight, you will find increase in growth hormone secretion, and that's going to be one very important clue to identify what is the graph, and the answer is going to be growth hormone if it is associated with 12 a.m. increase. Alright guys, and there is another point where the growth hormone secretion increases, and this is also associated with exercise. So whatever the graph says, if you find a hormone increasing during exercise and increasing at 12 a.m. midnight, definitely the hormone is going to be growth hormone, guys. And coming to cortisol secretion, let us take up the same kind of graph, and now this is for cortisol, guys. When it comes to the graph for cortisol, it's going to be pretty plain and simple. You are going to find an increase in cortisol by 4 a.m. and by 7 a.m. and 8 a.m. and all, the cortisol level peaks. Alright, this is going to be 4 a.m. This is going to be 7 a.m. and this is going to be 12 a.m. So by midnight, 12 a.m. and all, there will be very profound drop in cortisol levels, and that's cortisol secretion, guys. Alright, fine. Twinkle, cortisol secretion increases by hypoglycemia. Very good answer, very good. Amen. Yeah, 8 a.m. peak or 7 a.m. peak, both are right answers. And coming to Jod-Basedow phenomena, plain and simple. Every time you increase the administration of iodine, increased administration of iodine will lead to increase in synthesis of T3, T4. This effect is called as Jod-Basedow phenomena, and the exact opposite effect. When it comes to increased administration of iodine, the stimulus is going to be the same. Now this time it is Wolff-Chaikoff effect, but this time there is going to be a drop in synthesis of T3 and T4. This effect is called as Wolff-Chaikoff effect, and this is because of inhibition of the enzyme thyroid peroxidase. Coming to counter-regulatory hormones. The counter-regulatory hormones are 3 Gs essentially. What are counter-regulatory hormones? The hormones that comes into secretion during hypoglycemia or to combat hypoglycemia. During hypoglycemia or to combat hypoglycemia, to get the blood sugar level back to normal, we will be seeing secretion of some hormones, and that's going to be number 1. And the clue is going to be 3 Gs. The first hormone is going to be glucagon, that is going to come into the picture, is going to be glucagon. The second hormone is going to be growth hormone. And the third hormone is going to be glucocorticoid, which is nothing but cortisol. If these 3 Gs cannot able to bring the blood sugar level up, then the fourth superior hormone comes in, and doctors, that's going to be epinephrine. And that's counter-regulatory hormone which comes into secretion when hypoglycemia happens. And finally, when it comes to hormones on mammary gland, what is the effect of each and every hormones on mammary gland? The effect of estrogen is to increase the growth of alveolar ductules, alveolar duct, and this is also called as lobulo-alveolar duct. And the word you need to be remembering is going to be this one: ductal structures are increased by estrogen, number 1. Number 2, this is also going to increase growth of stroma. And when I say stroma, this includes fats as well as blood vessels. So the word stroma includes fats in the mammary gland as well as blood vessels in the mammary gland. That's going to be the action of estrogen, guys. And coming to the action of progesterone. Progesterone is going to be involved in growth of lobulo-alveolar units. It involves in growth of lobulo-alveolar units, guys. And coming to prolactin, prolactin doesn't involve in growth of anything, whereas prolactin is involved in synthesis of milk. So let me be clear, increase in lobulo-alveolar unit growth, just be clear here. And coming to prolactin, this is going to increase secretion. In another word, this is going to increase synthesis of milk. Production of milk is augmented by prolactin, and coming to oxytocin, this is involving in ejection of milk. So 4 different hormones and 4 different action on mammary gland, and that's going to be one last question when it comes to endocrine, guys. Moving on to miscellaneous topic, you just have just one very important topic, and that's going to be temperature regulation. Anterior nucleus of hypothalamus, also called as preoptic nucleus of hypothalamus, it has got one function which is involved in sensing warmth. It senses extra temperature in body, and anterior nucleus of hypothalamus is going to be involved in promoting cooling effect of body. It promotes cooling, it senses warmth. All right, first entrance question, what does it senses, what does it promote? Number 1, it senses warmth and promotes cooling. How does it promote cooling? 2 actions in sequence. Number 1, it is going to be, the first one is going to be vasodilatation. That's going to be the very first action. And number 2, sweating. And if you see both these choices, vasodilatation and sweating, in your exam questions, your first answer must be vasodilatation and the second answer must be sweating, guys. And the opposite stands true for posterior nucleus of hypothalamus, but this time posterior nucleus is going to be involved in sensing. It senses cold, and posterior nucleus is going to be involved in promoting warmth. So it's going to be exactly opposite. It senses cold and it promotes warmth. Now, how does it promote warmth, guys? The first mechanism is going to be vasoconstriction. The first mechanism is going to be vasoconstriction. The second mechanism is going to be non-shivering thermogenesis, also called as chemical thermogenesis. That's going to be the second mechanism. And the third mechanism and the last mechanism is going to be shivering. And people, when it comes to non-shivering thermogenesis, just be clear in this one word. Non-shivering thermogenesis involves one hormone and one enzyme. The hormone involved in non-shivering thermogenesis is going to be epinephrine, and the enzyme which is going to get activated by epinephrine is going to be called as thermogenin. And it is this thermogenin which is going to involve in uncoupling of oxidative phosphorylation, and thereby the energy which is available will be converted to thermal energy, and that leads to body heat production, guys. Doctors, it is precisely 7:30 and that completes our discussion. I hope you had a glimpse and idea of the most important crucial topics in RS, GIT, Endo, as well as this one, thermoregulation and miscellaneous topic, guys. I wish you sincerely all the very best. May God bless you all. May you have a successful exam, and I hope your dreams comes true. May God bless you all, guys. Thank you very much. And this completes the session. And in case if you got any doubts, please do text me in WhatsApp or Telegram. I'll do my best to address your doubt, guys. Thank you very much, guys. Thank you so much.
Chat. Hi, good evening. Welcome to this NEET marathon session. The exam is like few days away, so I'm sure you are well prepared and You must be knowing all the things which we are discussing, and that will be a very good sign for the exam. Okay, so I guess the audio video is clear. Okay, so let's quickly, will not discuss too much. You know all these things. So first let's discuss the important things from the trauma. Trauma is one topic which you will definitely get in your exam. Collection of blood in the thorax, that is known as hemothorax. Okay, there will be on examination there will be decreased breath sounds, there will be dull note on percussion. X-ray pay, you will see something like this. You will see the blunting of the costophrenic angle, so because of the fluid collection. But these days, even for hemothorax, the investigation of choice is E-fast, extended fast. So in the hemothorax, in the extended fast, you will see that between the lung and the liver, generally there is nothing, just a thin diaphragm is there. This black color thing is the fluid. Okay, something like this you see in the fast also. In the abdominal fast, you will see the collection between the liver and the kidney on the right side, and spleen and the kidney on the left side. So this is the E-fast showing the collection between lung and liver. That is for hemothorax. The treatment is putting the ICD. And indication for surgery, I'm sure you know, more than 1500 ml of blood immediately if it comes, then you put the ICD, or if it is more than 200 ml every hour for next 2 to 4 consecutive hours. And remember, in thorax, when we do a thoracotomy, mostly it is anterolateral thoracotomy. Yes, the ICD is generally 28 to 32 French. And what is the site? Site is this, 4th or 5th intercostal space, just anterior to the mid-axillary line. Also, you should remember there is a triangle related to this, which is known as triangle of safety. Okay, pectoralis major, the lateral border, latissimus dorsi, the anterior border, and a horizontal line at the level of nipple that usually falls in the 5th intercostal space. Yes. Okay. Next condition, again more important in fact than hemothorax. Can you see, this is the lung, this is also the lung, but this jet black thing is the air, and this is known as pneumothorax. Pneumothorax, clinically instead of dull note you will see the hyperresonant or the tympanic note. Hyperresonant or the tympanic note. And on E-fast, see, seashore sign is a feature of normal, and in pneumothorax you will see barcode or stratosphere sign. Barcode or stratosphere sign is what you will see in pneumothorax. Okay, no problem in identifying the images. Seashore, I told you, it is like the sand kind of beach appearance, and that beach is washed away by the ocean in pneumothorax. Okay, so these are the signs you will see in the M mode. In the B mode, you will see loss of sliding. Okay, this is in the B mode, this is loss of sliding sign. Now, what I want you to emphasize here is, I have seen, despite doing it multiple times, there is still mistake. If it is a simple or a close type of pneumothorax, you can observe if there is no respiratory distress, and if there is respiratory distress, you put ICD. In an open type, the first thing you will do is a 3-sided occlusive dressing. 3-sided dressing, and after that you will put the ICD from a different area. Okay, that is okay. And the most important and the most dangerous one is the tension pneumothorax. So how will you know it is tension? What are the hints in the question? There will be hypotension, or there can be distended neck veins. Distended neck veins. Okay, type of obstructive type of shock. So the first
thing here you will do is you will put a needle followed by ICD. And the site of putting needle in children, it is second intercostal space, mid clavicular line. In adults, it is same as putting ICD, that is the fifth intercostal space, mid axillary line. Okay, and remember, while putting the ICD, it doesn't matter whether it is hemothorax or pneumothorax, the direction of the ICD is superiorly and posteriorly. Okay, so I'm writing here ICD direction, irrespective of hemo or pneumo, superiorly and posteriorly, because that is the most dependent position, superiorly and posteriorly, whether it is hemo or pneumo. Next condition, can you see fracture of minimum 2 or more consecutive ribs leading to this kind of paradoxical movement? I am sure you know this is flail chest. A minimum 2, fracture of 2 or more than 2 ribs, paradoxical movement. And the treatment, basically, if there is no respiratory distress, oxygen by mask and analgesia. Analgesia, that is epidural catheter you can put for analgesia. But if there is respiratory distress, then you intubate the patient and put the patient on intermittent positive pressure ventilation mode to keep the alveoli open. Okay, look at this X-ray. A very basic information I will tell you. Patient is having a polytrauma 15 days back, and now the patient has come with the respiratory distress. Look at this chest X-ray, 15 days back a trauma, and now the patient is having respiratory distress. You can see the lung, and there is this asterisk is showing there is some intra-abdominal content which has gone inside the thorax because of the traumatic diaphragm injury. Diaphragm injury. Okay, so if you are suspecting diaphragm injury, what you are not supposed to do not put a ICD, no ICD. Treatment is you have to do surgery. You can get a CT scan, diagnostic laparoscopy gives the better information. Surgery is the treatment for diaphragm injury. Okay. Now see, this is EFAST. What are the sites where you'll put the probe? Generally, this is the sequence. The first you put in the epigastric area to see for the cardiac tamponade, then in the right and left hypochondrium, and finally in the pelvis. So this 2, 3 and 4 is to look for the fluid collection, and minimum 100 ml of fluid should be there so that it can be visible on FAST. And if you start putting the probe in the thorax also, then it becomes EFAST. Okay, now let's see this. See this. FAST ka role in trauma. Unstable patient. Just see. You go for FAST. If it is positive, go for surgery. If it is negative, either you can repeat FAST or you can go for diagnostic peritoneal lavage, also known as diagnostic peritoneal aspiration, or you can find some other causes of hypotension. Stable patient. FAST. If it is positive, because patient is stable, you can go for CCT, which is investigation of choice. If FAST is negative, but you are still suspecting because of the patient's pain and the other thing, you can still get the CT scan. FAST is negative, abdomen looks okay, the patient does not have tachycardia, then you can observe also. It's not that each and every patient of the trauma you need to get CT scan. Okay, so FAST is the first investigation, and if it is unstable and you can take the patient to the OT. Unstable patient, for the better delineation of the injuries, you can get a CT scan done. Now, I'm sure you know in the radiology, have just trying to show you some normal structures on a CT scan. Just see this, although it is mentioned also. Vertebra, aorta. Okay, you can see this is the upper cut. Okay, you can see the liver. You can see the stomach, you can see the spleen, this is the aorta. Little bit more down if you go in the cut, you will see more things, vertebra, aorta, this is the right kidney, liver, gallbladder, okay, these are the bowel loops, you can see, look, pancreas also, this is the spleen, this is the left kidney, okay, normal structures. If you go more down, now the liver is gone, you can see the kidneys in a much better view. If you go more down, you can see this psoas muscle, the lower part. Okay, more down, you can see the bladder also. So these are the normal CT cuts as you go below and below. Okay, vital stable CCT is the next thing. Okay, Dr. India. Okay, so if the patient only omentum is coming out, these days the surgery is not recommended, you can get a CT. Now see this CT and tell me what is the problem. In this CT, liver and other things are okay. This is the spleen and there is injury, so this is splenic trauma. So if the patient is stable, grade 1, 2, 3, non-operative management, grade 4 or 5, you'll go for surgery. Surgery means splenectomy. But in case of a child, all the stages, all the grades in child, in children, splenic preservation. Splenic preservation. And suppose the CT shows like this, if there is contrast extravasation. Contrast extravasation means there is some little bit of bleeding is still happening. So in these cases, you go for therapeutic angioembolization, selective angioembolization. Okay, see another CT. Can you see liver trauma? Liver trauma, stable, all the grades, whether it is grade 1, 2, 3, 4 or 5, non-operative management. Non-operative management. Unstable patient, you will do the surgery, exploratory laparotomy, and you try to control the bleeding. How you can control the bleeding? Push, plug, Pringle or packing, perihepatic packing. Okay, these are your 4 P's. 4 P's. Yes, I said CT for the momentum question. This is kidney injury, kidney trauma, unstable, go for surgery, remove the kidney, nephrectomy. Stable patient, grade 1, 2, 3, non-operative management. Grade 5, nephrectomy. Grade 4, depending on case-to-case basis, you can do conservation also, you can go for nephrectomy also. Single shot IVP, Anushka, nowadays there is no role. I mean, that is, I'm kind of non-practical when you do a single shot IVP in unstable patient. No trauma center, no centers, they have the facility of single shot IVP in a patient who is unstable. Okay, unstable means just take out the kidney. Okay, and in case of stable, CCT will give you more information than single shot IVP. So single shot IVP, you can say that there is no role as such. Okay, one shot IVP is nobody is doing. Okay, I'm talking about the practical thing. Damage control surgery. Damage control surgery recently also in the FMGE exam last week, what, like 3 days back, this was the question, and they asked very simple. Hematoma is increasing, that is grade 4. Okay, any expanding hematoma, Sanakhan is grade 4. And if the patient is stable, you can do angioembolization and you can control the hematoma. Okay, so you can control the hematoma. Phase 0 is pre-hospital. Before the patient reaches the hospital, damage control resuscitation, don't give too much of fluid, start early blood transfusion, injection tranexamic acid. Phase 1 is abbreviated surgery, 30 to 45 minutes, control the bleeding, limit the contamination. I can see that it is not very nicely seen, but still you know the things. Phase 2 is then the patient goes to the ICU. There you fight with the lethal triad, that is hypothermia, acidosis, and coagulopathy. Phase 3 is the definitive second surgery, where you will do the definitive repair because now the patient is physiologically much better. And if it is not possible to close the abdomen in phase 3, then phase 4, after few days, you can do the abdominal wall closure. Okay, so this is damage control surgery phases. Now the head trauma, I'm sure few things you know. Say this is the CT showing very classical EDH because of the injury to the middle meningeal artery. Okay, biconvex shape. This hematoma can't cross the suture line, but it can cross the midline in the frontal and occipital area. Second picture shows very classical concavo-convex type of opacity, that is SDH. The reason is bridging veins or the communicating veins, and it can cross the suture line, but it cannot cross the midline because in the center it will form the falx cerebri. Can anybody tell me the diagnosis of this patient? Waiting for your reply. This is subarachnoid hemorrhage. That can be either because of trauma or that can be because of Barry aneurysm. Now see, in the Barry aneurysm there is definitely a role of nimodipine. Okay, but in trauma also many people they give nimodipine. So if they ask which drug, nimodipine, a calcium channel blocker which prevents the vasospasm. Yes, very good, very nice. This is chronic SDH. Okay, the appearance will not be hyperdense, it will be hypodense or isodense, and this chronic SDH you should suspect in elderly people and if the patient is taking anticoagulant. Okay, chronic SDH, very nice. Okay. Okay, one new thing I am going to tell you, I maybe some of you are knowing this. This type of lesion is known as Morel-Lavalley lesion. Basically called as Morel-Lavalley lesion. So what is Morel-Lavalley lesion? This is a type of closed degloving injury. Closed degloving injury mostly because of blunt trauma. Okay, so basically the skin, the subcutaneous tissue and the fat, it gets separated from the underlying muscle. There is a hematoma in this area. Skin and the subcutaneous tissue get separated from the underlying muscle. So that is closed degloving injury because of the blunt trauma. Common areas where it can occur is around the hip joint, in the gluteal area, in the thigh. These are the common areas where you can see the Morel-Lavalley injury. Yes, Saurabh, closed degloving injury, very nice. Okay. One more thing I wanted to tell you. I mean, as I can see that you are prepared very nicely. So, can anybody tell me, where should I write? Somewhere. Okay, here only I'll write. What do you understand by non-accidental injury? Non-accidental injury. NAI. Anybody has any idea about this non-accidental injury? Non-accidental injury is basically, you can say this is another name for battered baby syndrome or child abuse. Okay, child abuse is a smaller term. I mean, abuse can be seen these days, especially in the society we live, in extreme of ages. Okay, in child abuse, like it can be seen in elderly people also who are living with their kids and they don't want to have them. I mean, they don't want to have living with them. So there are instances whether the people can report about this. Okay, so what is this? Like, how will you suspect that there is a non-accidental injury or child abuse? See, when there is delay in seeking treatment. Injury has happened 3 days ago and now the parents are bringing the kid. Okay, after waiting for 3 days. Delay in seeking treatment, different history. You asking the history from the father, he's saying something else. Mother is saying he fell from the stairs. Father is saying he fell from the bed. Different history. Then you will see the different injuries at the different stage of healing. You can see one fresh injury. You can see some bruise, somewhere around the neck, in the wrist. You can see the areas. Then there are certain fractures which are suspicious. Okay, so what are the fractures suspicious of non-accidental injury? Yes, somebody said correctly. Metaphyseal fracture or the bucket handle fracture, rib fracture, sternum fracture, vertebra fracture. There is one non-parietal skull fracture. Non-parietal skull fracture. Definitely you should treat the person, but at the same time you have to inform this to the the concerned authorities. Like in the hospital, you can inform to your MS or dean. They will further tell for the other maybe the child care services and the elderly people services. Okay, so you have to report these things. Okay, this question was also asked like 2 days back in the FMGE exam about the blast injury. Primary blast is because of the overpressure tympanic membrane, lung, intestine. In intestine, it is the cecum which is the most common site because this is quite filled with the air. Secondary blast injury is because of any penetrating injury. Tertiary blast injury is blunt, and if there is traumatic amputation. So if there is a crush injury, see what was the question asked in the FMG, that after a blast a building fell on a person and there is a crush injury in the limb. What type of injury is this? This will be a tertiary blast injury. Quaternary is like any kind of burn or inhalational injury. Quinary blast injury is radiation, infection, long term. Yes, mannitol is in fact the drug of choice given to the head injury patient to decrease the ICP, but if the patient is also having associated hypotension, then you give hypertonic saline. No hypotension in head trauma, mannitol is the fluid of choice. GCS, I'm sure this is one thing which you cannot miss before the exam. Eye opening, spontaneous 4, to voice 3, to pain or the pressure 2, and if there is no eye opening, it is 1. Non-testable is also added. Verbal response if the patient is oriented 5, confused 4. Speaking in words 3. Producing sounds 2, if there is no verbal response 1, non-testable is there if the patient is already intubated. Obeys command 6, localize the pain 5, withdrawal that is same as normal flexion. Abnormal flexion is the upper body goes into the flexion, the lower limb are in extension. If the upper body is also in the extension, that is extension, all the extensions are abnormal, so that's why extension. 1 is no motor response and T is non-testable. If the total is 8 or less than 8, because of the low muscle tone, there are very high chances that the tongue will fall backward and causes airway obstruction. So you don't want that to happen. So you will prophylactically put the endotracheal tube. And post endotracheal tube, when you try to calculate the GCS, you cannot check the verbal response. So that's why it goes in non-testable. Confused and words. Confused means patient will give you a different story. Like he'll say that, okay, you'll ask how did the injury occur? He said, I don't know how the injury occurred. I was standing in the road and I was eating some pani puri and I don't know, maybe something has hit me from the behind and now I can see I'm in the hospital. What happened in between? I don't know whether I was hit by some, bull or some bike. I don't know. So patient is confused. He is not telling, he does not know. And words mean patient is not speaking sentences. He is speaking in words. He does not finish a sentence. Okay, so that is the meaning. Okay, triage. I'm sure you know the top priority is the red. Immediate requirement of some medical help is required. Tension, pneumothorax, profuse bleeding, massive hemothorax, EDH. Yellow means they need hospitalization, like compound fractures, degloving injuries, pelvic fracture, spinal injury. Green means ambulatory patient, like simple fracture, minor laceration. Black is unsalvageable, like very severe brain injury, very severe burn, loss of chest or abdominal wall structure. That comes under black. Now see, what is shock index? Shock index is heart rate divided by systolic blood pressure. And what is modified shock index? That is heart rate divided by mean arterial pressure. In both the cases, in the normal condition, it is less than 1. In shock, it will be more than 1. Okay, classification of hemorrhagic shock. You should know that the hemorrhagic shock is divided into class 1, 2, 3 and 4 depending on how much blood the patient has lost. Okay, less than 15% it is class 1, 15 to 30% 2, 30 to 43, and if the patient has lost more than 40% it is class 4. Important things I'll tell you, the pulse rate is less than 100, more than 100, 120, 140. BP remains normal and it starts decreasing when the patient has lost more than 30% of the blood. More than 30% of the blood. Yes, all these degloving injuries will be yellow because degloving injuries there are chances of underlying nerve and the tendon damage. Okay, so these patients need hospitalization. You cannot dispose them off from the site of injury. They need hospitalization, any degloving injury, because there can be, although it is not life threatening, but they still need hospitalization. So if the patient needs hospitalization, yellow is given to them. Okay, so remember about this. And in class 1 is known as compensated, 2 is mild, 3 is moderate, and 4 is severe shock. Severe shock. Okay. Another thing in septic shock, previously like 2-3 years back, there was more importance given to SIRS criteria as per the sepsis 2 guideline. But now there is sepsis 3 guideline and they give more focus to the Q-SOFA score. So Q-SOFA score, systolic blood pressure less than 100, respiratory rate more than 20, and abnormal mental status, GCS less than 15. So you will give 1 score to each, and if 2 or more than 2, that indicates high mortality in the current admission. High mortality. SIRS, there were 4 things, either hypo or hyperthermia, respiratory rate more than 22, heart rate more than 90, and WBC count either less than 4,000, more than 12,000, or more than 10% band forms. Out of these 4, if there is 2 or more, then you can say that the patient is under SIRS. Okay, 2 very frequently asked question. Rule of 9 for the burn calculation of the percentage. I'm sure you know head and neck area constitutes 9%, each upper limb 9%, each lower limb 18%. Front of the chest wall as well as the abdominal wall is 18% together, and same in the back 18%. 1% is given to the genitalia or the perineum, so that is like 100%. Okay, so in case of small patchy burn, palm of the patient, the whole palm including the finger is 1%. In the child, how it is different, at the time of birth, the main difference is that the head and neck area is 18% and the lower limb is 13.5. Now there are different charts, like Lund and Brauer chart is given for age specific, but the main difference is in the head and neck and in the lower limb. So broadly or very grossly, you can say that for every year till 9 years, add 0.5% in the lower limb from here and subtract 1% in the head and neck. So you will get the the broadly, I mean grossly, that how much is the percentage at that particular age. Okay. PCO2 is same as respiratory rate. Okay, somebody asked Tarun, PCO2, I mean respiratory rate more than 22, or you can say PCO2 less than 32. That is same as respiratory rate. Okay, now fluid resuscitation in the burn patient. See, until unless they specifically say as per the Parkland formula. So if they ask as per the Parkland formula, you have to follow the Parkland formula, that is 4 into weight into percentage. Unless they are saying Parkland formula, these days people they follow ATLS guideline for the fluid calculation, where the multiplication factor is 2 for adults. Adults means more than 14 years. For kids like less than 14, 3, and for electric burn, whether it is adult or child, it is 4 into weight into percentage. And the goal of urine output is, in adults it is 0.5 ml. This question was also asked like 2 days back. They said that I guess in the child they have given that in a child there is some burn 22%, and you are giving fluid, but somehow the urine output of the kid is 0.3 ml per kg per hour. What will you do next? So obviously you have to increase. You will give a bolus of fluid. Okay. In SIRS the value is 22. In Q SOFA it is 22. Okay, it is wrong written here in this chart. More than 22 here and more than 20 here. Okay, so in this particular chart it was written ulta. Q SOFA it is 22, and in SIRS it is 20. Okay, thank you for pointing out, Pratyush. Okay. If you get an image based question and they ask about the degree of burn, if you see the blister, it is 2nd degree superficial, partial thickness superficial. If you see pale or the mottled pink area, it is the 2nd degree deep or the partial thickness deep. If you see a black color or a white color S char, it is 3rd degree or 4th degree, and very obviously if it is going up to the bone, it is 4th degree burn. Child wala part again. See, this is the main thing in the kid. The main difference is where? The head and neck area and the lower limb. Rest of the thing is same as adult. So, as the child grows, for every year in the lower limb you add 0.5%, and in the head and neck you subtract 1%. Okay, so then you will get for that particular age. Okay, funny star. Breast cancer, overall the most common cancer, you can see satellite nodule, ulceration. This is the skin involvement. Okay, this is the ulcer, this is satellite nodule, skin involvement. Cancer on cuirass you will see mostly in the as a recurrence when the cancer cell has spread to the whole chest wall. Paget's disease, the patient can present to the dermatology OPD as a itchy scaly lesion, but actually it is a ductal cancer which can present as a superficial manifestation. Now this was the question asked, like I said 2 days back, that there was an image given of the dimpling and they asked what is the reason for this. So very obviously it is involvement of Cooper's ligament. You know these things. Nipple discharge, which type of discharge is suspicious? Single duct, single side, spontaneous, and mainly serous. Okay, it is mainly serous type of discharge. Okay, 4S, circumferential type of nipple retraction, and this is very classical podiorange appearance because of involvement of the superficial lymphatics, blockage of the tumor cell. When the superficial lymphatics gets blocked, there will be podiorange appearance. Staging is, this is the one staging which you need to know. T1 is when it is 2 or less than 2 centimeter. T2 is 2 to 5 centimeter. T3 is more than 5 centimeter. T4 is irrespective of the size. If there is involvement of the chest wall means intercostal muscles, ribs, and serratus anterior. Pectoralis muscle involvement does not fall into chest wall involvement. Same as latissimus dorsi does not come under chest wall. T4B is skin involvement. Skin involvement means either ulcer or satellite nodules, or if there is podiorange appearance, but this podiorange appearance should be involving less than 1/3 of the skin, because the moment it involves more than 1/3, it fulfills the criteria of inflammatory cancer. That is T4D. And T4C is when there is both chest wall as well as the skin involvement. Okay, see, medullary carcinoma, Anshita, is a type of ductal cancer only. Okay, there are two types. See, listen to me. There are two types of breast cancer, either ductal or lobular. So same, ductal carcinoma in situ, lobular carcinoma in situ. Invasive ductal cancer, invasive lobular cancer. Now, invasive ductal cancer can be of different type. The most common is invasive ductal cancer, no special type. Then comes invasive ductal cancer, medullary type, colloid type, papillary type, micropapillary type, inflammatory type. So all these are, you can say, are the types of invasive ductal cancer. Now, which type of invasive ductal cancer is having the worst prognosis? It is inflammatory breast cancer. Okay, inflammatory breast cancer. Nodal staging, N1 there is mobile ipsilateral axillary lymph node, and 2A is when it is fixed or matted axillary lymph nodes, and 2B is when there is involvement of internal memory without axillary, and 3B is internal memory with axillary, and 3A is infraclavicular, and 3C is supraclavicular. If there is contralateral lymph node involvement, that is considered as distant metastasis. Contralateral is distant metastasis. Dimpling does not fall under skin involvement. So for dimpling, whatever is the tumor size, you will take that into consideration. Suppose it is 4 cm with dimpling, it is T2. Suppose it is 6 cm with dimpling, it is T3. Okay, dimpling does not come into skin involvement. In the vascular system, this is one thing which they are asking very frequently, the CEAP classification. Remember, you have to remember the C1. Okay, so C1 is, C classification, telangiectasia, reticular vein. C2 is varicose vein. If they write R, it is recurrent type. C3 is edema. C4A is hyperpigmentation or eczema like skin changes. C4B is that lipodermatosclerosis or atrophy blanche. C4C is that fan-shaped dilatation of the small veins around the ankle, corona phlegmatica. C5 is healed ulcer. C6 is active ulcer, and the site of ulcer is the medial aspect of the leg on the lower 1/3 gaiters area. Remember, lower limb ulcer, you have to see the site. Okay, if it is in the medial side, lower 1/3, it is venous ulcer. If it is in the dorsum of the foot or the tip of the toes or the web spaces between toes, it is arterial ulcer. If it is present on the foot, calcaneum, then it is trophic ulcer or the neuropathic ulcer. Okay. Etiology, when they write P means primary, S means secondary, N means no etiology, C means congenital etiology. Pathophysiology, R means reflux, O means obstruction, both means both reflux and obstruction. Anatomically, if the superficial system involved, S, deep system, D, perforator, P. Okay, so this is the C4A and C4B. C4A is the, what happens first? First there is hyperpigmentation, eczema like changes. Lipodermatosclerosis is a later stage, so that's why it comes in C4B. Comparative study of thyroid malignancy, papillary thyroid cancer, follicular thyroid cancer, anaplastic cancer. They have the same origin. What is the origin? Follicular epithelium. So that's why the tumor marker is same. Serum thyroglobulin, serum thyroglobulin, serum thyroglobulin. Okay. But medullary thyroid cancer has a different origin. It arises from the parafollicular cells, which are neuroendocrine cells. So that's why it has a different tumor marker, CEA and calcitonin. Okay, the common age group 20 to 40 years for papillary, is slightly more in follicular. Anaplastic is elderly, middle age in medullary. Gene mutation, although multiple gene mutations can be seen, but the most common is BRAF in papillary, RAS in follicular, P53 in anaplastic, and RET in medullary. Main risk factor, radiation, thyroglossal cyst, Hashimoto for papillary, multinodular goiter, iodine deficiency for follicular. Anaplastic is usually these genetic causes, radiation can be a reason. Medullary carcinoma can be again sporadic, or that can be associated with men's syndromes, familial medullary thyroid cancer syndrome. Most common route of spread, papillary lymphatic, follicular blood. Anaplastic, locally it can involve the structures, medullary again lymphatic. Two histopathology images, I'm sure pathology sir must have talked also. Amyloid stroma is you see in medullary thyroid cancer. In papillary you will see the orphan NEI nuclei and samoma bodies. Papillary is a better one, so that's why you can do a hemithyroidectomy, especially in the low risk feature like if the tumor is less than 4 cm, no extrathyroidal extent, no history of radiation, only in one lobe, low grade type, you can go for hemithyroidectomy. Routine level 6 removal is not recommended in these cases. In these two, you don't have to remove the lymph node in all the cases. But yes, in anaplastic, although majority of anaplastic are beyond repair, so you go for palliation. But if you are doing surgery, level 6 you routinely remove. Okay, these are high grade. Similarly, medullary thyroid cancer, you routinely remove level 6. Level 6 you have to remove in all the cases. And because the origin is different, so there is no role of radioiodine scan or ablation in case of medullary thyroid cancer. Post-thyroid complications, I mean post-thyroidectomy complications. Okay, this is when there is bleeding. Bleeding can present as airway obstruction. So either you intubate the patient or open the wound bedside, and then you take the patient to the OT and control the bleeding. External laryngeal nerve injury, which is more commonly seen, leads to loss of pitch. This question was also asked in the recent FMGE exam. Recurrent laryngeal nerve on one side lead to hoarseness of voice. On bilateral side, the vocal cords will come in the midline and it will kind of cause airway obstruction. Airway obstruction. Yes, this is hypocalcemia that can be seen if you remove all the 4 parathyroid or if there is ischemia of all the 4 parathyroid. This hypocalcemia is usually seen from post-op day 2 to post-op day 4, not on the first 2 days. And yes, this is Vostek sign. And putting the BP cuff, keeping it inflated, the hand will go like this. That is Trousseau sign. Most common external laryngeal nerve. Okay, Ganesh, most common is external laryngeal nerve. Okay, parathyroid. Parathyroid. Hyperparathyroidism. The most common reason is parathyroid adenoma. Okay, see, hyperparathyroidism can be associated with, okay, let me tell you one thing. Okay, parathyroid adenoma. So how will you localize? The investigation of choice for localization is technetium 99, Cesta, MEB is methoxy isobutyl isonitrile scan. This is the scan. In the initial 15 minutes, all the glands will take, even salivary gland will also take the uptake. But later, only after 2 hours, only the affected gland will have. This is taken by the oxyphilic cells. Oxyphilic cells or the oncocytic cells that are rich in mitochondria. So now if I ask you one question for you, that which type of thyroid cancer can give a false positive result if you do a SESTA-MEB scan? I mean, you have done a SESTA-MEB scan and a type of thyroid cancer will also pick up this and it will remain there in this. Tell me which type. Yes, the indication for surgery, either symptomatic. Yes, very good. It is Hurther cell cancer, because Hurther cell cancer also has oxyphilic and oncocytic cells. So Hurther cell cancer can give a false positive result if you do a SESTA-MEB. In asymptomatic patient, there are indications like age less than 50, serum calcium more than 12 milligram per deciliter, urinary calcium more than 400 milligram in 24 hours, GFR less than 60, bone mineral density, Z score or the T score is less than minus 2.5 standard deviation. And yes, treatment is, you are saying, for parathyroid adenoma, it is minimal invasive parathyroidectomy. Minimal invasive parathyroidectomy. Confirmation that you have removed the correct thing, that can be done either by frozen section or by the Miami criteria, drop in more than 50% of the maximum pre-op value 10 minutes after surgery or removal. And for hyperplasia, hyperplasia, either 3.5 gland removal or all 4 with auto transplant. Now see, if it is a sporadic type of parathyroid hyperplasia, then this is, I mean, among both, this is more preferred. This is more preferred, and this is especially more preferred in MEN syndrome, MEN 2 or 2B, in secondary hyperparathyroidism, also in tertiary hyperparathyroidism. Autotransplantation wala is more preferred. And also in these cases, when you are doing the surgery, just this is maybe something new, you need to do a thymectomy also. Thymus also needs to be removed when you are doing this all 4 gland removal with autotransplantation, and especially in the MEN syndrome and in the secondary and tertiary hyperparathyroidism, remove thymus also, because at times there is ectopic tissue in the thymus, and even after doing this it can lead to recurrence or it can cause failure of the treatment. So that's why thymus is also routinely removed if it is MEN syndrome or secondary or tertiary hyperparathyroidism. Half gland, if you are putting it back into the patient body, the preferred one is the brachioradialis muscle of the non-dominant forearm. Pheochromocytoma is a tumor arising from the adrenal medulla or the chromaffin cells elsewhere in the body. What are the cardinal features? Tell me 4 cardinal features. Hypertension is the most common. Headache. What else? Hypertension, headache. Tell me 2 more features. Palpitation, sweating, flushing. I want you to remember these. Either they can occur as continuous or they can be paroxysm. Means there can be attacks of these things. Usually that is because of the physical activity. That can be because of general anesthesia. Okay. Now see, when we talk about the investigation, first is biochemical investigation. Now you can check the plasma or urinary. Either you can check the catecholamines or you can check the metanephrines or VMA. Now this metanephrine and VMA is more sensitive, so people they generally check metanephrine or VMA. Catecholamine also you can check. Second thing, plasma you will check in the high risk patients, like if the patient belongs to syndrome or there is family history of pheochromocytoma or if there is personal history of pheochromocytoma. Syndromes like MEN syndrome, VHL syndrome, neurofibromatosis 1 syndrome, SDH associated pheochromocytoma, paraganglioma syndrome. So then you check plasma, otherwise you will check urinary. One more thing. Now for localization, first thing you will do is CCT. If it is not seen on CCT, then you go for MRI. If it is not seen on MRI also, then you go for MIBG. If it is not seen on MIBG also, then you go for PET scan. So this is the sequence. Now see, MIBG is also done. MIBG is also done if CT or MRI shows extra adrenal. Okay, so another indication of MIBG is, see, one indication is if MRI and CT both fails to localize. Second indication is suppose CT or MRI shows extra adrenal pheo, then also you go for MIBG. And PET CT, one indication is suppose all the 3 fails, and it is also done if malignant pheo. If it is malignant pheo, then also you get a PET CT. If they ask next best investigation, see Divya, there is a way of making questions. Next best investigation in trauma is okay, but here there is, here you can say that suppose they say that a patient is having pheochromocytoma, CT does not show where is it, what is the next best investigation? MRI is the answer. Suppose they say CT and MRI both fails to localize, what is the next best? MIBG scan. Okay, MIBG scan. Okay. Okay. Now we'll see MEN syndrome. Comparison of this MEN syndrome. There was a question on MEN syndrome also in the recent this thing. MEN1 syndrome because of MEN1 gene located on chromosome 11. 3P, parathyroid, pancreas and pituitary tumor. The most common feature is hyperparathyroidism, autosomal dominant. Okay, remember MEN1 gene is a tumor suppressor gene. But when we talk about the RET gene, that is a proto-oncogene that is seen in both MEN2A and 2B. In MEN2A, there is parathyroid, pheochromocytoma and medullary thyroid cancer. In MEN2B, there is pheochromocytoma, medullary thyroid cancer, and there are multiple neuromas of the lip, tongue, and GIT, and there will be marfanoid habitus. This red gene is present on chromosome 10. Okay, medullary thyroid cancer is seen in 100%, so that's why you go for prophylactic thyroidectomy in MEN2A at the age of 5 years, in MEN2B within 1 year. MEN4 is a very rare type, recently diagnosed in 2006, CDKN1B gene that is present on chromosome 12, mainly parathyroid and pituitary tumor. Okay, so almost phenotypically it was same as MEN1, but because of the different gene, it was given a separate entity. Prophylactic thyroidectomy in MEN1. Okay, prophylactic thyroidectomy in MEN2A at 5 years, in MEN2B 6 to 9 months. Cleft disorder, two common question. How does the cleft lip formation occurs? Because of non-fusion of the median nasal process with the maxillary process. Cleft palate is because of non-fusion of the palatine shelves in the midline, and palatine shelves comes from the maxillary process. Okay, now a slight update. Timing of surgery. Let's make it very simple. Cleft lip 3 to 6 months. Okay, let's try to keep it simple. Cleft palate 6 to 18 months. Ideally, maybe you can say 1 year. 1 year is the ideal time. Okay, make it simple. Okay, beyond 18 months you don't do, before 6 months you don't do. 1 year for cleft palate, cleft lip 3 to 6 months. They say when cleft palate can be repaired earliest 6 months, when cleft lip can be repaired earliest 3 months, and the later period 6 months for this, 18 months for this. Okay, now see, when a scar does not go outside the boundary but just elevate, that is known as hypertrophic scar. And if it elevates and goes beyond the original boundary, then it is keloid. Okay, beyond original boundary is keloid. In both the cases there is increased collagen, but in case of keloid it is disorganized. Keloid generally develops 3 to 4 months later the incision or the trauma. Hypertrophic scar, if it has to develop, it will develop within a week. Sternum, shoulder, earlobe are the common sites for the keloid. Flexor surfaces for the hypertrophic scar. Pain is there in the keloid. Itching is there in the keloid. Keloid can be familial in the autosomal dominant inheritance. Keloid can be seen in the colored people, so it has some racial predilection also. And the first line treatment is intralesional steroid or the triamcinolone. You have to give like multiple injection weekly. In both the cases, you will see collagen 1 as well as collagen 3. Okay, in both the cases, collagen will be high. Both collagen 1 and 3 is seen, but in keloid, it will be disorganized. Okay, these infections, necrotizing fasciitis, a soft tissue infection caused by Streptococcus pyogenes, usually involves skin and the subcutaneous tissue fascia, does not involve the muscle, very high grade type of very rapidly spreading infection. Melanese gangrene, when the soft tissue infection involves the anterior abdominal wall, mainly it is caused by Enterococcus, common in the post-surgical patients. Fournier's gangrene is a similar infection in the groin or in the scrotum. Mainly it is caused by E. coli. In all these cases, you have to do early aggressive debridement, give antibiotic, negative pressure wound therapy, hyperbaric oxygen therapy. All these therapies is going to help in these patients. Yes, majority of the time it is polymicrobial, but if they ask the most common organism, these are the most common organism. Decubitus ulcer or bed sore is almost always a question. Most common site is the ischial tuberosity. And the grading is you see the burn grading. If there is intact epidermis like this, it is stage 1. Partial thickness is stage 2. Stage 3 is full thickness going into the subcutaneous tissue but not beyond the fascia. It looks like this. And if it goes beyond the fascia involving the muscle, bone, it is stage 4. Stage 5 is unstageable when there is a scab or a eschar. So unless you remove it, you will not see how deep it has gone. Treatment, like I said, debridement, negative pressure wound therapy, hyperbaric oxygen. If you want to prevent it, change frequent position in the bed every 2 hourly. And for the person who is sitting on a wheelchair, ask the person to lift a little bit every 10 minutes. Now, in the salivary gland, the nerve injuries in the parotid, facial, greater auricular, auriculotemporal. Greater auricular is the most common. Auriculotemporal nerve can lead to this problem. This is known as Fraze syndrome because of the misinnervation of the postganglionic parasympathetic nerve fibers coming from the auriculotemporal. They get aberrantly joined with the sympathetic fibers of the skin, which were responsible for the sweating and erythema. Okay, so you put a starch iodine test. So first you put the iodine, then you put a starch, and when the sweating occurs, that area will become purple. To see it, treatment is botulinum toxin injection or interposition barrier. In the submandibular surgery, lingual nerve, hypoglossal and marginal mandibular branch of facial are the common nerves which get injured. Marginal mandibular is more commonly injured, followed by the lingual nerve. Now this question is becoming favorite for the examiner. What are the landmarks which will help you to identify the facial nerve during the surgery? So there is facial nerve which divides into 5 branches inside the substance or the parenchyma of the parotid. Tympanomastoid suture is the most important landmark. The facial nerve present just below this. Posterior belly of digastric, facial nerve present above this. Cartilaginous part of external auditory canal, facial nerve is present 1 centimeter below and inferior below and lateral to it. In case of reoperative cases, it is difficult to find the main trunk, so you can find a peripheral branch. Usually people find the buccal branch and then they trace it back to the main trunk. Stylomastoid foramen can also be a landmark. Mastoid trephination is done in those desperate situations where everything you have done but still not able to find the facial nerve. So open up the this thing and go for it. To prevent the facial Fraze syndrome, you can take the temporalis fascia. These days there are synthetic acellular dermal matrix. We generally put sternocleidomastoid in between. Okay. Other thing to prevent the Fraze syndrome is keep your skin flap a bit thicker. Okay. If it is too thin, then the sympathetic fiber gets exposed. This is again a very important image-based question. What is this? This needle is having this is a spring-loaded needle known as Viris needle, used to create the pneumoperitoneum or carboperitoneum in the laparoscopic surgery. A spring-loaded needle. Okay, so in those cases where there is already a midline scar around the umbilicus, because Viris generally you put around the umbilicus. So if there is a midline scar because of the prior laparotomy, then you can go for the open method of creating pneumoperitoneum. That is also known as Hassan's method. But suppose you want to put Viris only, don't put the Viris around the umbilicus. There is an alternate area that is known as Palmer's point. Okay, Palmer's point is 1 to 2 finger breadth below the left costal margin in the mid clavicular area. So that is also a safe area where you can put the Viris. Most common vascular injury during the Viris placement is inferior. In the Viris, the most common vessel injury is the iliac vessel. And during the port position, the most common vessel injury is inferior mesenteric vessel. Okay, inferior mesenteric vessel in the port, while putting the varus, it is iliac vessel because the varus direction is towards the pelvis. Okay, when we talk about the you can say the what do you call ergonomics, this is the telescope, or this is the camera. These are the surgeon's working hand. So between the working hand and the camera, this angle is known as azimuth angle. Ideally it should be 30 degree. Between the two working hands, the angle is known as manipulation. It should be 60 degree. And all these instruments, from a horizontal line, they are making an angle that is known as elevation angle. That should also be 60 degree. And remember, while doing the laparoscopic surgery, the level of monitor should be 25 to, you can say, 15 to 40 degree below the line of sight, not at the line, not above. The distance of this screen from this is maybe 100 to 200 centimeter. The instrument handle should be at the level of, elbow should be at the level of the instrument handle. Okay, so this is like the ergonomics. The ideal intra-abdominal pressure is 12 millimeter of mercury in laparoscopic surgery. 10 to 15 is the range. And when you are putting the carbon dioxide, there is peritoneal distension. And because of this peritoneal distension, there is vagal response, and that can lead to sinus bradycardia. And this is the most common arrhythmia you see in the laparoscopic surgery. Okay, total parenteral nutrition, there are certain complications. Let's see the mechanical catheter related complication, because you give TPN by the central line, so there can be pneumo, hemo, chylothorax, air embolism, thrombosis of the central vein. Metabolic complication, if I ask you which is the most common is hyperglycemia. Okay, this was asked also. Liver dysfunction, cholestasis, gallstones, all these things are also seen. All those nutrient deficiency can be seen. See, refeeding syndrome is after a prolonged starvation, when the patient takes carbohydrate rich diet, there is increased insulin secretion because of increased GLP, and due to this increased insulin secretion, what happens? There is increased uptake of the potassium, magnesium and phosphate by the cell. So if these things goes inside the cell, there will be hypokalemia, hypomagnesemia, hypophosphatemia. All these things can cause serious arrhythmias, cardiac arrest. So that is about refeeding syndrome. Okay, so thank you so much for your patient listening, and best of luck from my side. I can see in your comments that you are well prepared, and I'm very, very sure that you will do very well in the exam and you will get a very good rank. And I pray to God that all of you get your desired branch in the desired college. Okay, so thank you very much, and best of luck from my side, from the whole DAMS family. And we'll meet again, we'll talk again, maybe on the day of the exam, and we'll discuss that, what were the questions asked. Okay, thank you very much, and God bless you all.